I'd like to start by introducing John Garcia, thanking and then introducing John Garcia. He's the director of the ABRC. Welcome, John.
Well, as Steve said, I'm the program director for the Arizona Biomedical Research Center. And with me today is the deputy director, Keelan McCool. And together we are the dynamic duo. So I just wanted to give you a couple of things about the Arizona Biomedical Research Center. Originally, it started out as a commission in 1984. It was established by statute. And then in 2011, the legislature moved it under the Department of Health Services. And its primary goal is to identify and support innovative biomedical research to improve the health of all Arizonans. Then in 2017, the commissioners were removed and the name was changed to the Arizona Biomedical Research Center, which it is today. As I said, our mission is to identify, support innovative biomedical research. Our funding comes from two sources. The Disease Control Research Fund was established under statute with monies received from the Arizona Lottery. So get your scratchers and buy those tickets because we need the money. Then the Health Research Fund, established under statute, were monies that come from tobacco tax. And the idea there was that we wanted to do research originally for cancer research. And then it just expanded from there, that there's so many things that can be have an effect on a person's health, and cancer wasn't the only thing, so they broadened it to just about anything of a medical nature or disease. Recently, we had a couple of special fundings. House Bill 2298 a couple of years ago set up for marijuana testing for clinical trials. They gave us up to $5 million a year for 5 years, and that came from the Medical Marijuana Fund to test the safety and efficacy of marijuana and research the impacts of interactions. And it was kind of broad because they said, oh, yeah, we wanted all the interactions with prescription drugs and non-prescription drugs, which could be illicit drugs as well. So that was awarded to the, I think it's Southern Arizona Autism Research and Resource Center in Tucson. And they're working on that because one of the things that the statute said is that autism could be one of the areas of study. Then we have Senate Bill 1847, which was marijuana research and gave us $250,000 from the Medical Marijuana Fund to look into the correlation between marijuana use and mental illness, including violent behavior and psychosis. So we issued 2 grants under this. One of them came here to NAU, and one of them to ASU. So they're looking into this topic for us, and hopefully in a couple of years we'll have some results. We have a website if you're ever interested in learning more about the ABRC. It is azdhs.gov biomedical, and it's broken up into our program areas. We have research grants, research education, we have documents, and the public cord blood program. So the research education is what's funding this conference today. Research grants, we give out about $9 million over 3 years, at least once a year or every 2 years, depending on how the funding goes. And we just made awards under the research grant for a new cohort, and we're about to open another solicitation. In fact, Keelan and I were just looking at the draft of the solicitation. So keep an eye out for notice on that, and we'd love to have lots of people apply for the funding. We have every year we do an annual report. You can find that on the Documents tab of the website. And our staff, Keelan and I work for the Executive Director, Victor Waddell. He is also the Bureau Chief for the Arizona State Laboratory. And myself, we have a Science Advisor, Shini Lin, and a Program Coordinator, Teresa Napoleon, and Finance Manager, Martin Ohlmeyer. And there's also, not on here, is our Office Support Specialist, Vanessa Barnes-Acido. Public Cord Blood Program, Research Grants, Research Education. Under Research Education, money goes to ASU, U of A, Tucson, and Phoenix, and here at NAU. Under the Cord Blood Program, money goes to the Tucson Medical Center, Dignity Health for St. Joseph's Hospital and Chandler Regional Hospital, and soon to be added another hospital that we haven't made the award official yet, so I can't say the name, but we are adding another hospital here this year. And then Valleywise Health is one of the other hospitals. That's it for me. See, I got that done pretty fast there, Steve. So thank you very much. A pleasure to be here. Pleasure to see all of you here. And for those of you who are out in the intranet land, welcome. And I know this is going to be a great conference. So without further ado, take it away.
All right. Thank you, John. So today, before I introduce our fabulous workshop hosts, I do want to mention two other workshops that we have coming up this year, the last in our series of 5. May 18th, we're bringing a workshop on whole school and community collaboration for child health. That's going to be in Flagstaff in a hybrid format. And then we're also going to return to Yuma for the 5th annual forum, Collaborative Partnerships Translating Research to Practice. And that's led by Amanda Aguirre, who was a past state senator as well. But today, this seminar focuses on health messaging, culture, and pandemic response. And this is a collaborative offering from NAU's College of Health and Human Services, the Center for Health Equity Research, and the Department of Health Sciences, along with Arizona State University, the Cronkite School of Journalism and Mass Communication, as well as other departments and programs at ASU. So it's nice seeing this university collaboration on this. As we think about the COVID pandemic, we can all identify ways that we were affected or touched. The pandemic really revealed many of the strengths from a genomic response, public health structures, but it also exposed many weaknesses and things to learn from. Furthermore, the intersectional challenges of public health and health disparities, genomic and immunological science, and then particularly with politics and media. It was really, truly fascinating and something to learn from. This exposed challenges of communicating to a public for whom a majority of their information has come from sound bites and social media. The workshop today is taking a retrospective, lessons learned look at the COVID-19 pandemic in Arizona and focusing on how did we respond and what did we learn and how can we help with our response to the next pandemic. So I'd like to introduce our fabulous workshop leads here. The brains behind this workshop, Dr. Don Gilpin and Matt Moore. So Dr. Gilpin, she's currently Assistant Dean for Research and Associate Professor with the Walter Cronkite School of Journalism and Mass Communication at ASU. Her research interests focus on interaction between organizations, media, and public policy. She is one of the 2 co-leads for this today. Matt Moore is currently a lecturer in public health in the Department of Health Sciences at Northern Arizona University. Matt has worked in environmental health and was a senior epidemiologist for Coconino County for the previous 6 years. Matt collaborated with communities across Northern Arizona and was a leader who coordinated the Coconino County response to the COVID pandemic, and you'll hear more about that here shortly. These 2 have brought some amazing scientists, scholars, and professionals and panelists together today. So thank you to Don and Matt for putting this together, and we're excited for what this day will bring, and I'm going to turn it over to you 2. So.
Pull this down. Thank you, Steve. I'll be really brief. So social scientists use the term wicked problems to describe situations that are extremely complex and seem unsolvable because they have so many causal factors. And this is usually applied to things like poverty, right? Large-scale phenomena that are extremely multifaceted. And I think, if nothing else, these last few years have taught us that pandemics are among those types of wicked problems. They are multifaceted. If we can't approach them just from an epidemiological perspective, if we overlook the social, political, economic, etc. factors, then we will fail. As many will say, we have failed in this situation. So that's what I really value about an opportunity like today, to bring together people, not just from different universities, but also different disciplines, different perspectives, to talk about what we know, what we learn, what we've seen, to try to tackle this wicked problem, since we know it ain't over yet, and there are more to come, and see what we can learn and try to do better in the future. So I think that the only way we can productively address these kinds of situations is through collaborations like these. So I'm really excited about today, and I'm very grateful to Steve and the ABRC and for bringing us together today to have these conversations. So thank you, everyone.
Great, wonderful. Good morning. Yeah, thanks, Steve. Yeah, thank you all for showing up this morning. It's going to be very exciting. One of my favorite topics to talk about: infectious disease outbreaks, pandemics. Right? It got we may have got burned out a little bit over the last few years, but still incredible. And so you're going to be hearing from me a couple times today. I got a presentation coming up, and then also being on a panel. So I won't bore you too much this morning. I'll just introduce our first speaker, if we're ready for that. Yeah, great. So our first speaker today is Dave Ingelthaler, a wonderful, wonderful individual. He's a professor and director of TGen North, the infectious disease arm of the nonprofit Translational Genomics Research Institute. He's also a scientific director of TGen North Clinical Laboratory, which stood up in March 2020 to specifically provide COVID-19 testing, and has provided tests for tens of thousands of underserved Arizonans, especially in tribal and rural communities. His team has coordinated the statewide SARS-CoV-2 sequencing of the first year of the pandemic. Dave oversees a number of research groups on detecting and understanding infectious diseases, such as COVID, tuberculosis, and valley fever. His team at TGen also provides genomic services at CDC, state, local, and tribal health departments, and Arizona healthcare institutions. Dave was previously the Arizona state epidemiologist and a biologist for the CDC, and is a double alumnus of Northern Arizona University in '91 and 2014. Sorry for aging you there, Dave. He's published over 150 scientific papers and chapters on epidemiology, disease ecology, genetics, and microbiology. He has over 24 patented inventions. He has started for profit and nonprofit businesses, sits on a number of local and national boards, and proudly led the establishment of Flagstaff, Arizona as America's first STEM city. Wonderful mentor, wonderful individual, and very excited to hear. So it's all yours, Dave. Thank you.
Thanks, Matt. Had I known that you were actually going to read the bio I sent, I would have made it much, much shorter. So sorry about that, everybody. It's truly it's great to be here. Thank you to the organizers for inviting me. I don't know everybody here, but I've been in public health for a very long time, going back to the 90s. Matt pointed out how old I am, and I've been at TGen now for almost 17 years. I'm not going to talk too much about TGen, although I would love to. I'm here really to talk a bit about the science side that was brought into the pandemic, namely genomics. But I'm going to focus larger on science and what we learned about science. And I'm hoping that I'll have a couple of minutes at the end for maybe get up on a soapbox a little bit, because There's so much we can talk about. I'll try to keep it concise, but from a perspective of a public health scientist, I'd love to, I'm glad to be part of this conversation. So let's jump into it. I got a lot I'm going to run through. I'm going to show some science, a little bit of hardcore science, but we're not going to dwell on it, and I'll try not to bore you. But this pandemic, I like to say it's a 21st century pandemic that met 21st century science. So this really was a pandemic that unfolded in a way that only could in the 21st century. It moved around the globe faster than anything else we've ever seen in the history of the planet, and that is because of the technology, global travel, and globalization of our modern world. And we had so much science to bring to bear on it, and we did in a lot of ways. Testing, of course, was one of those. We had essentially PCR tests developed instantly, faster than we've ever done before, to bring to bear on a disease outbreak. And this is for the global pandemic. They weren't all perfect at the beginning. We had some problems, but they became better and are incredibly accurate and provided us really good intel on what was going on with the pandemic, as well as diagnosing patients. And then we moved to at-home tests, which, again, this is something brand new. We really put a lot more power into the hands of people to essentially assess their own health and make their own health actions, which is an important thing that was able to happen. Genomics, of course, and I'll spend a little bit more time with genomics. Sequencing, genome sequencing, really important, did help us understand what are the new variants and tracking those variants and all of that. But we also use genomics for a lot more than that, including things like genomic epidemiology. And I'll get to some of that, and as well as just understanding this virus as it's evolving. Pharmaceuticals, so the mRNA vaccines, essentially this is the first time we really put those into play. They'd been looked at for a few years prior to the pandemic, but really this was a brand new technology, was a real game changer in the middle, but now we're learning a lot more about how good they are, as well as what their limitations are, and hopefully we can improve their use into the future, as well as new antivirals. We've always struggled with antivirals. We haven't had great antivirals. But now we've learned enough with this pandemic that we can actually make some really good fine-tuned antivirals. Of course, they're going to have their issues too, but the science advanced during the pandemic. We also found ways to make sampling easier, rather than those MP swabs, the deep, tickle the brain swabs that we had at the beginning. We were able to bring in others, nasal swabs, saliva, spitting into a tube, finger pokes. People could collect their own sample. Again, really important when you're dealing with something that involves the entire population. And there was a global science. We had really everybody was on board. We had thousands of labs around the world that were either repurposed or stood up just for this pandemic, and hundreds of thousands of scientists all being brought to bear. That was a big deal. It helped us learn a lot more. We'll talk about whether or not we ended up using what we learned, but it was an amazing amount of science was happening in a way that has never happened before. Virtual health, telehealth, these things we had before the pandemic, but again, being brought to bear and being able to be used in real life situations that really helped reduce the burden on our healthcare system, helped be able to track and monitor patients at home. Again, in a way that we could only imagine before the pandemic. And then One Health, which is really a 21st century science discipline of looking at humans, animal, and the environment all as essentially a holistic approach for understanding the disease and the pathogen. And so lots of ways we've been doing that with wastewater surveillance and pet and wildlife testing. TGen played a really cool role. We were honored to be part of this pandemic from the very beginning, and especially in northern Arizona and working in rural parts of the state, working with many of the tribal communities across the state. I'm not going to go through what we did at TGen, although I could brag on us forever, but it definitely was an honor to be a part of the response. So one of the big things, though, was genomic sequencing. That's our bread and butter at TGen. We were able to kind of stand up essentially the state's genomic sequencing response for about the first 12 to 18 months. We were able to, we did pretty much all the sequencing, and then ASU and U of A and CDC and others really started to help out to the point that we were able to test our sequence tens of thousands of organisms, now 140,000 total organisms, I believe, and be able to monitor how the virus is moving, these different variants, and keep that going on a statewide dashboard. Everybody had access to that. And this really was a pandemic of variants. The virus continued to evolve and change as it was adapting to us, and then we adapted to it with our pharmaceuticals, and then it adapted to us. And it's really been a kind of a two-way evolution throughout the pandemic, but these variants are really important. And what we're dealing with now is nowhere near similar to what we originally had to deal with at the beginning of the pandemic. And I'll get to some of these pieces. One of the things that we can do when we understand the genomics, so we're spelling out all the letters of the genetic alphabet in the RNA of this virus, is that we can see who's related to who and build family trees. This is actually a larger coronavirus family tree. I only put it up because we did have sequence data early on, and we could understand exactly what type of a virus this was. And there's a whole lot we still had to learn about the virus, but where did it fit in? It was clearly part of that SARS-like family of viruses that were in bats. That's how we know no matter how it got into humans, it originated from a bat at some point, which did give us a lot of information early on. Now, it also gave us probably some false starts. We made some assumptions about how this would really transmit and move around. And so we got caught up a little bit in not advancing our thinking fast enough because we did make some assumptions based off of what we know about these viruses. But we were able to have a much more high resolution view as well. What I like to call building kind of the ancestry.com for COVID. We did that in Arizona, and as well as places around the world did this, sequencing thousands to now millions of genome copies. This has never been done before for any pathogen or any entity, the amount of sequencing that's been done for us to understand this virus, track where the virus is coming from, where it's going to, and then understand the importance of mutations, how that makes new variants, and what does that mean for the epidemiology and the clinical side. So in Arizona, as I mentioned, about 140,000 genomes have been sequenced between TGen and ASU and CDC. And we've been able to build a lot of these maps, and we have a really complete, not just a baseline genomic map, but really complete map and understanding of the virus and how it moved around in Arizona, which then led us to not just say, hey, now we're dealing with Delta or now we have Omicron, but actually use that data. We could work with our public health partners. It was great to work with Matt in the county team. We work with a number of tribes and other communities to understand what's going on within the community, what's going on with maybe a specific set of care facilities or a university or across an entire tribal community. And we're able to really tie the genomics to what was happening on the ground epidemiologically, so we could understand how does a virus like this unfold in different population settings. So I'll use this one example. This was recently published, but this was a study that this was a investigation that we did with the White Mountain Apache tribe back in 2020 as the virus emerged in that tribal community. There were 2 strains that showed up that affected pretty much, those were the only 2 strains that were seen, and those strains were not seen really anywhere else, and it had a different epidemiology. And so we really dove in to try to understand this more clearly. And we worked with the on-the-ground epidemiologists, public health workers, who were essentially trying to understand, okay, this patient was in this household, how many people were infected, what was the next household that maybe was infected or the next facility, and then we tied that to the genomics. So we had some really interesting connections between the shoe leather epi and the genomic epi. And I'm not going to go too far into this investigation, but just some of what we got out of this. We look on the right-hand side, we'll see the epi diagrams that were essentially pieced together by doing the kind of door-to-door knocking, phone calling, all of that work that our community level epidemiologists and community health workers do. And then also look is how does that virus evolving and unfolding within the community. And so I'll just zoom into a little bit of that family tree that was over on the left-hand side. Your left-hand side. So we'll just zoom in and just tie some of that data then to the clusters that we were seeing that were first popping up. These were the very first cases, and because they had such a great public health response, they could identify pretty much every single case that was occurring in the community and did identify the very first cases. And so we could see that when we know that the very first case showed up, actually went to work while sick, infected, unfortunately, a couple coworkers went home, and then we were starting to see every single person in the household was getting infected, enormous attack rates. We didn't see this elsewhere in the pandemic, at least at that time. This was really remarkable. And then those coworkers would go home, and now we're seeing everybody in the household getting infected. And so much so that people, and this is part of tradition, was if something's coming in the community, we're going to send our kids away to a different house or other relatives or friends so they don't become infected. Unfortunately, we didn't know how fast it moved. They ended up sending kids who were asymptomatic, as most kids were, and ended up then exposing other households. And then all of a sudden this starts unfolding. We could see that within the genomics and watching where the mutations show up and how it evolves. It was really fascinating. And another cluster that involved a correctional facility, we were able to actually use the genomics to show really the first cases were in the household, of which then somebody in that household went into the correctional system, and then the whole correctional system got exposed as well. And then being able to use the genomics to actually tie these two clusters together, because epidemiologically we couldn't understand how did one cluster relate to another. We could find the one person that was the link between those with the genomics of the virus. So some really interesting and fascinating ways to use genomics. I throw this one up here because we were able to do some molecular epi with Major League Baseball. You remember they were really trying to keep going and needed to understand if the virus shows up, how does it spread in the clubhouse, and how does it potentially spread between teams. And we did some, at least there was some fun stuff there that was involved. Okay, so I want to talk a bit now more about the science of what we learned about infection and immunity. And in the end, it is all about the spike, and I'll show you why. So vaccines, infection, and immunity. I'm going to go through a bunch of bullet points here. It's most things that people have heard, but just as kind of baseline. Vaccines are a way to trick your body into thinking that it has been infected with a pathogen so that your body now develops immunity. This is what a vaccine is supposed to do. So that immunity that you then get is now you're in this state of readiness, your immune system is, so that it is ready to respond quickly to when it does get exposed to that pathogen into the future. And that immunity can be from a prior infection or from vaccine. So antibodies are the first line of defense in that immunity, in a person's immune system. They act quickly to respond to an infection. You still get the infection, but the antibodies respond to clear the infection, but antibodies don't last forever. They do wane. Depends on the pathogen, depends on the vaccine, but it could be months to years. And now we're finding out in some cases only even weeks. Cellular immunity, which is your white cells, the B cells, and the T cells that really respond much more slowly, is what we call our secondary immune response, but those last a long time. So you can still get an infection, but you're not typically going to have a serious outcome or die if you have good cellular immunity. And that can last for years, even a lifetime. And then no immunity in the end is a force field. It doesn't prevent the pathogen from coming in. It just responds once the pathogen comes in. You can still get infected. So this is a hard thing for people to understand. Like, why did I get infected after I've had a vaccine? Well, the vaccine wasn't going to stop you from getting infected. It just stops you from having a more serious infection leading to a more serious disease. And so we saw that this was happening in most people who would get exposed after having immunity would have, very limited disease, but you still get infected. But the immunity, the antibody immunity, does wane rather quickly. And then immunity from natural infection and vaccination, you get from both. They're roughly equivalent, but they are different. We learned that natural immunity, you don't get the sky-high antibodies, but your antibodies last a lot longer than the vaccine antibodies, which would be sky-high, and then they would start dropping off pretty quickly. This really played an important role during the pandemic. So moving into I said it's all about the spike. I want to talk a little bit more about the virus, and we'll come back to the disease. So that spike protein, we all know the crown of spikes. That's how it gets this name. The spike is the part you see that's protruding out. That means that's what interacts with its environment, especially interacts with cells. So that's the most important part of this virus that we have to deal with for a number of reasons. When we look at the spike, this little cartoon you can see on the inside, on the outside is kind of the genome showing the different genes. The red section of that genome is the spike gene. And if you get a mutation then in that gene, it could affect how that spike protein is shaped. This is looking at the spike protein from the top view down. That's just all those amino acids make up, how that protein folds together. And if you make some changes in the genome, that protein could change a little bit. And so when that spike protein is interacting, you see with the blue cell receptor, that's a human cell receptor. When it's interacting, if that spike protein changes a little bit, it's going to interact a little bit differently. And that spike protein changed a lot during this pandemic. And so much so that you can, I don't know if you could see, but that middle figure, that's the spike protein. And at the top of it is that part where it interacts with human cells. Every red spot up there is a mutation that occurred and a little bit of change in the protein. In Delta, there was a lot of changes that we saw that was occurring when Delta came in, and it made it so that antibodies didn't bind very well, but it also changed enough that it was a little bit better key that fits into the lock of the human cell receptor. And so it would actually cause more infections, and it was evading some antibodies. And that's why we just continually had this. Even after the vaccines came out, it was figuring out a way to adapt to us. But then Omicron, which is over here on the far right, is you could see all those red spots. That's how different it was. Omicron was so different. It was radically different in that not only could it really was evading almost all of our antibodies that we were getting previously, it was also fitting better into that lock and changing the way it gets into our cells in a way that could be much, much faster and more effective. So what we learned really early on held true throughout all of Omicron, and this now became the Omicron pandemic. It was very different than anything we had seen, although we didn't act very differently in the response to it, and maybe we should have. It preferentially invaded upper airway cells over the lower airway, so it stayed in the upper airway, mostly up in the bronchial and even higher. It entered cells differently, as I mentioned. I won't go through why, but it made it so that the virus could get into cells faster, cause an infection faster, so you actually needed a lower infectious dose of the virus to cause an infection. But again, it also stayed in the upper respiratory tract for the most part. This resulted in significant decreases in hospitalization, severity, and death. There was a lot of concern about saying this is not milder. It was milder. It was absolutely mild. It's a very different virus. The Omicron version of this virus didn't mean that there weren't some serious outcomes, because there were, but it was a very different virus, and we didn't try to adapt to that way because of the fear of how that messaging would come out. And it was even milder in children. This was never a pandemic of children. Of course, some got serious illness, but very, very few, relatively speaking. But even Omicron was even milder in children. So we should have adapted to that sooner. And then evaded antibodies from vaccination. I already mentioned that just because that spike protein changed enough, antibodies weren't binding to it that we had before. So even antibodies we had from previous infections weren't as good, but certainly not from the vaccine. They tried to adapt the vaccine, still not a very effective overall antibody response to Omicron. But it didn't evade T-cell immunity. So even though it was milder, we also still had T-cells that helped prevent, even if we did have a more serious infection, a possibility, our T-cell immunity was really strong. So what have I learned? Okay, so I just have two last slides. So I know we might be running a little long. I think we started a little bit behind, so I apologize. Two last slides with bullets of what have I learned. And I think we've learned, but this certainly as a public health official, former public health official, I look at this, I struggle because There was so much we refused to learn, even though it was right in front of us, and so much that we thought we learned that actually maybe wasn't true. So I'm going to start there. It's not what we don't know, it's what we know for sure that just ain't so. So vaccines, wildly successful early on, but then they had limited impact once the Omicron pandemic started. And that was partially because of the mutations, but partially because the mRNA technology and the boosters was not giving us a good response that was lasting long. This far in, the more boosters you had, the less of an effective antibody response. We didn't know that. We still haven't really absorbed that. We got to learn about these mRNA vaccines and how that works. And those vaccines were not completely harmless. Again, it goes against public health messaging, but nothing is completely harmless. There was some effects. Probably the one biggest one is limited myocarditis in young adults. So much so, European countries do not vaccinate young males at all. You're not allowed to. We actually haven't absorbed that information and try to understand what does that mean and what is the risk benefit of for young males getting vaccinated. Herd immunity we talked about it forever, ended up being less important than individual immunity because the virus just kept adapting. We couldn't achieve a herd immunity that would shut this virus down. It just wasn't going to be possible with this virus. We tried, we hung our hat on that for a long time, trying to get to that. And as well as then the opposite, zero COVID failed. You couldn't stop people, lock them up, prevent them from getting real immunity and still survive. China's suffering through that experience right now. Masks, again, not a force field, but they did provide some protection. But that protection also started to drop off as we got to Omicron. We were seeing 20 to 60% reduction in virus being able to move in and out of airway space because of masks, but that ended up being about a 5 to 10% reduction in cases overall. So some effect, but it certainly wasn't as good as vaccination, and it wasn't something that could work on its own, and really was much better on an individual level. And then Omicron, you only need a very few virus particles to get in to get that infection, and therefore even like things like cloth masks were really becoming obsolete. They weren't doing anything for the Omicron virus, and the N95 masks still providing a lot of protection if they're worn correctly. Outdoor spread, fomite transmission, not significant factors at all. We didn't know early on. We didn't adapt probably quickly enough, but that meant we definitely should not have closed down parks. We got to get kids outdoors playing, getting physical exercise and interacting with each other in a way that we force them not to. So it's one thing, hopefully we've learned from this. We've got to admit some of these things that we got wrong. Fomite transmission, all the wiping down of every surface that we did it at TGen, probably wasn't doing anything for COVID. Was probably working for some other pathogens though. School closures in the end probably had either a negligible or negative effect on community spread. We actually knew this before the pandemic. Studies had been done with flu and other school closures do not have an important impact on community spread. And this was not a risk to the students. What we needed to focus on was who was at risk individuals that would have been in schools. Right, and have that focus protection around those individuals. But it was, again, something that hopefully we've learned from this. And lockdowns, bam, boy, did they slow that spread initially, but it also stopped the economy, brought it to a grinding halt, and it didn't in the end stop the pandemic. So we got to figure out, can we use those strategically to slow down to make sure we're supporting our healthcare system without killing our communities? And then, sorry, this is my last slide. Science and humanity, I promise. Well, maybe. Here's my biggest takeaway, this line and my last line. We need to use science neither as a punchline nor as a weapon, but rather as a tool to illuminate the best way to serve humanity. And I'll come back to what I really think that means. But we ended up kind of on two sides. One that was, I don't want to say anti-science, even though that was being called that, and one that was like really pro-science, but neither of those were actually using science in the best way to serve humanity. We need to accept that there will still be some risk for those that are at risk. This virus is not going away. We just have to accept that. We have a lot of other pathogens in the world that aren't going away. We have to accept that. We need to give them as much support as possible. We need to accept that some people, though, will still be afraid, concerned, that fear won't go away completely. This really affected us as long-term mental health trauma, I think, to individuals. And that is something that we have to understand. And we have to accept that everybody got many things wrong. And I mean everybody, from President Trump to Tony Fauci, from Doug Ducey to Gavin Newsom to me to you, we all got many things wrong. And we got to maybe own the fact that we got it wrong, but we're trying to learn. Right? And it's nobody was actually had this thing right. And we shouldn't have, in my opinion, we should not have mass shamed or vax shamed people either way, whether not yelling at people for not getting vaccinated, not yelling at people for wearing a mask when they don't really need to. That only helped pit us against each other for no reason. We were trying to do the things that was right for us and our families. And I think people will still make their own choices. And I do think that that's okay. So my last point on this then is science needs to be used in the context of community values, not the other way around when we create public policy. We don't make values around our science. Science needs to be used to help us use our values and live that way. I was going to talk about SARS-CoV-2 origins, but I can't. No time. Sorry. Happy to, but no time. And then I just got to put it, a lot of great collaborators, many more than this, but these are people that we worked with day in and day out. I got to give a good shout out to Matt. He was one of the great leaders in our region of the world. And I'm just hearing him talk up here. I miss his voice. I'd be on Zoom calls every single week. He'd be giving updates and trying to rally the troops and get as much information out there. So my hat's off to you, Matt, and everything you did for our community. And with that, thank you.
Great. Well, wonderful introduction. Thanks, Dave. The genomic epidemiology work, absolutely wonderful and vital. So important for us in our response to the pandemic. So now we'll go through looking at, I'll talk about what we did here regionally, and then I'll look to also state, national, global, and we'll really look throughout on what public health does, as well as the community as far as responding to pandemic. What I want to talk about initially, though, is outbreaks in general. So there's a lot of outbreaks going on all the time. This pandemic was crazy. For somebody who is infatuated, too strong of a term, but with pandemics, studying, researching, looking in, and really previous to this COVID pandemic we had, really not thinking it could happen the way it did ultimately in this day and age. And that was one thing I got wrong, definitely. Outbreaks in general. So as far as responding and containing outbreaks, there's really three main mechanisms. Whether we have a known or unknown etiology, so that means whether we know what is causing the illness or not. The first thing we want to do is get laboratory evidence. We want to see what are people sick with. So, of course, if it's a known illness, if we get the report from a laboratory itself or a healthcare provider saying we have 15 people with the same E. coli going on, then we have a known etiology. Or we get that call from somebody who went to a wedding, right? That was the first outbreak I got to work. I was like third day on the job and got a call about people that had attended a wedding and a bunch of people were now sick. So we want to get that laboratory evidence. We want to know what are people sick with. The next thing is interviews and collecting information. Very, very important. So what we do as far as tracking down and trying to understand how is this outbreak taking place, conduct those interviews. So if it's that wedding example, we want to understand, okay, what were the events that took place? Was it a 3-day thing? Was it a 2-day thing? A 1-day? When was everybody together? And then there's plenty of other examples on that as well. Who's related? How did that happen? So that way we can put together a nice survey, start to collect our information. This is all really part of information, collecting information and gathering data and putting that together. But collecting that information, if we get those surveys out, start people start to answer questions, then we can really start to understand, okay, what are the symptoms that we're seeing? If we don't have that laboratory evidence yet, we can start to get ideas on what people are sick with based on their symptoms, based on what people did. We can start to identify a source potentially. And then once we have that information, then we conduct those environmental assessments. Environmental assessment, once we get an idea for where the transmission was most likely taking place or what was happening, then we conduct those environmental assessments to maybe do some swabbing, gather some environmental contaminants, and get that together. So on that outbreak that I got to work, it ended up being a norovirus outbreak. A bunch of people were sick. We could tell from the interviews. We could tell from gathering collecting the evidence. We got the laboratory evidence. And then after that, we got the environmental assessment. We tested the water and found out that there was a contaminated well from the septic system was contaminating the well. So people were drinking their feces and urine. Very exciting. But that's the fun part. So preparing for a pandemic, right? So that's an outbreak in general. Pandemics are just, as we all saw, they're just outbreaks that are crazy. So as we prepare for a pandemic, it's that plan. And planning for a pandemic, most of the plans that we put together are called pan-flus. We're preparing for that influenza pandemic. That's what we're concerned with. Although, and I don't know who's on from ADHS, but in 2019 in June during the infectious disease conference, we actually did and I think this is probably my next slide, but we actually did a workshop on a pandemic, and we brought people to the table, and they did a coronavirus. It was a coronavirus, summer 2019, MERS, the MERS outbreak. We did a pandemic workshop, which was pretty interesting as we started getting December and January and February of 2020. But putting that plan together and who's going to be responsible for what? This is not just public health. This is really what we're doing here today. We're identifying. Dave went through a lot of great lessons learned, and that's all part of future planning for what are we going to do the next time this happens. We may not know what it's going to be. Well, we don't know what it's going to be. We may not get everything right in those plans, but at least having an idea. So that way, when it does happen, we can light that plan on fire and go running for the hills, right? Which is a little bit of what happened, because during practice, we did not bring enough people to the table. So during these work groups, during these workshops, during our tabletop exercises, during our full-scale exercises, we had public health, we had medical, we had laboratories, and we had people that were going to be actually responding to the pandemic. But the pandemic was going to be affecting all of us. So schools weren't necessarily there. Our community leaders weren't necessarily there. Our politicians weren't there. Community members, other people in the community were not necessarily at the practice. And therefore, they went running like their hair was on fire, right? They were not necessarily prepared and didn't realize that we had plans to respond, had plans in place, even though no plan is perfect. But practicing those plans is very, very important. Now we understand to bring everybody to the table, so that way we can see, okay, what are the issues? And very interesting thing during the plans and during the workshops and everything that I was involved in for my whole time in public health, 12, 13, 14 years conducting this practice. We had ideas for pods, point of dispensing. So how we're going to get vaccines out to people, how we're going to get medication out to people. But we all just assumed that our regular testing networks, the hospital, our laboratories were just going to be working. We never really thought about, are we going to have to set up a test collection site? So that we were flying by the seat of our pants for, because we didn't have a plan for that. So pandemic response. And these are the 4 areas. I'll talk more later on, and we'll have some Q&A about other things, but these are the areas I'm going to focus on right now. Really captures a lot of the public health response. Our surveillance, our medical service support, public information, community assistance. These are the 4 that I'm going to go through and really capture a lot of the response that was done. So first off, surveillance. Dave talked a lot about the genomic epi surveillance, which was awesome, amazing tool for us to be able to use, as well as this first bullet point here, increasing understanding of the virus and the associated illness. So as was said, we had these different variants going on. So when the illness first came out, it's very, very important to understand who is most affected, who are our most vulnerable, most susceptible populations. How can we protect those individuals? What's the symptoms? What's the severity? What's the transmission patterns? This is information that is vital to understand from the beginning. We have got to know what's taking place here. Otherwise, we're just flying blind. We've got to be able to offer that guidance. So in our surveillance, a major part of the response is really understanding the pathology of whatever organism it is. In this case, it was a virus. I like to just call it SARS-2, but we all know very much about it right now. When it first came out, it was just a novel coronavirus. The name changed multiple times. As far as messaging goes, a little bit confusing. That part alone was confusing enough. I had people that really didn't understand the difference between a virus, a bacteria, a virus, and an associated illness. The next thing, track disease trends, determine the impact on our communities. This was very, very hard for a pandemic. We have systems in place we have reportable diseases. In Arizona, we have about 85 reportable diseases. This novel coronavirus got added to that list as an emergency order, got put on as a reportable disease. But then how do we track? How do we know who's being affected and how it's affecting us? We have databases for all of this, but those databases really could not handle the amount of people that were getting tested, the amount of people that were getting sick. It was very, very, very hard to track the trends accurately. And that second bullet point under there, managing, analyzing, and visualizing the data. Managing the data, that became one of my, in March, April, May, June, July, August 2020, all the way through. That became one of the really overwhelmed me and my team, was trying to manage the data. And then from there, we were pretty good at analyzing it. We had that. And then from there, how is best to visualize? How do we best get that information out to the people who need it? And the main themes that I kept coming back to was how complete is our information and how accurate is our information. And our public health systems were really not set up. We had to have these backup spreadsheets. Thank goodness for Teams. We got Teams right before this outbreak, and it allowed us all to work in the same document. If we didn't have something like that or all these other programs, it would have been very, very difficult to try to manage or respond to this outbreak and really keep track of who all is getting sick. Because some people looked at those reports and thought of it as a number. How many people were sick today? How many people were sick today? Well, we had to realize that those were actually people, right? And it's very important to understand and have that context that these are actually people. These are family members. These are friends, moms, dads, daughters that are getting sick and dying. And very, very important to be able to see what's the impact on our communities. And then with that, we had multiple different cities, counties, tribal, state, national, global. Everybody keeps track of this information differently. Within the US, every state is different. Within those states, a lot of states, Arizona, for instance, decentralized state. So therefore, any response to an emergency is at a local level. So you could have, we have what, 13, 14, 15 counties in Arizona? And everybody's doing it a little bit differently, funneling their information to the state, who's funneling it to the CDC. And then you get, oh, your numbers, how are your numbers correct? Numbers are incorrect. It's very, very hard to manage that data. And then identifying, and Dave went into this very well, identifying clusters and related cases. We did this through that boots on the ground interviewing people, understanding who are related cases. It got very overwhelming. The term became contact tracing, got very overwhelming to determine, okay, who all is related. So having the genetics of it and being able to identify actually who had the same virus along with the interview information, we were able to do a very good job. And that was one of the things we did well on, was being able to track related cases. But it took a while, especially early on in that pandemic. The next thing that, aside from keeping track of all the information as an epidemiologist or in public health, our medical services support. So that is a very, very important role that we play in public health, is providing guidance for protecting staff, preventing transmission, providing care. So early on, I started a weekly call with all medical facilities within Coconino County and really throughout northern Arizona. And those calls expanded from there. So we get together and really talk to each other, not only to identify what is our circumstance, what's happening, what are our trends, but also what's the guidance, who's doing what, who's seeing what. And protecting staff, so very important. Understand, okay, what's the PPE necessary to be able to prevent transmission among staff? Because here, patients are showing up. They're going to show up no matter what. They're coming to the hospital. They're going to show up. So how can we make sure to protect that staff? And that was one of the main things that we need. That's why we need to understand the virus and understand the pathology of it. So that way we could provide proper guidance to our healthcare personnel that's out there trying to support our communities and the people getting sick. Equipment and supplies, major failure. I think we ran out of supplies in April of 2020. we couldn't even find a mask or a gown or a swab. These systems are in place. We were, at least as far as the planning goes, a national stockpile of equipment that is in place to try to get out to those that need it. And we ran out so fast. I remember getting a call from, not even within Coconino County, because we were really helping with all of northern Arizona, but getting a call in April when the virus really started to hit on Navajo Nation. And there was an ambulance company in a very rural area that ran out of their 6 masks that they have on the ambulance. And they're having to transport patients all over the place, people that are very, very sick. They had no equipment to keep themselves safe. And that's a very important part of not just local, but national public health. And that response is being able to equip those that really need it. And then relief for medical surge. So as we start to get, as a medical facility start to get overwhelmed, as we have major surges or mass fatalities, what are we going to do with all of those people, with all of those bodies, and how are we going to assist? So with medical support services, there were areas, and we can talk about this more, Q&A or in the panel, but there are areas that we did some good job in planning and preparing for those surges. And then there were some areas where we were being very reactive. And then I think this is going to be a big one that other people talk about, so I won't spend too much time here. But all of that, tracking those trends and all of the information that we're gathering and everything that we're learning, trying to put out into public information. So with that data visualization, what's the best way to do that? What's the best way providing guidance, support for infected individuals, people with exposures, and the general public? So with this one, this guidance part is, here's what we understand about this virus, and here's how you can help protect yourself, guide schools, businesses, shelters, organizations, government, community leaders on strategies for safe operation. So that guidance part is very, very important. And that was one of the main things that I tried to focus on, was really staying out of the political and public mess that this became. And really, how can I deliver information in a way that still keep confidence in not only the medical community and those that are getting sick, but also within the general public and our organization and leaders. How can we properly assess risk? A restaurant owner calls up and says, how can I continue my operation safely? Right? Providing that risk assessment, and really good risk assessment, as Dave alluded to and talked about quite a bit, really getting a good understanding of how can we continue to operate our businesses while decreasing that risk of transmission, and providing that guidance in a good way, and not just saying, oh, you got to close down, but actually working with them and understanding and identifying those strategies. And in some instances, did that well, in other instances, not so well. Publish current disease trends is another thing that we do. So this is a picture here from the ADHS website, looking at COVID-19 date of death. And even this, as we track these trends, I already talked about the difficulty in tracking those trends previously. But what's the best way to publish those current disease trends and keep that confidence at the same time? And then media communication. So for me, early on, we started talking to the media very early, delivering one of the most stressful parts of my job was it was weekly meeting where whoever from the media could call in, the number was just out there, and I would open up and deliver, here's our status, and then they could ask whatever questions they wanted to. And I learned a lot from that on how to actually present information, present myself, and not be so theoretical, because I get very theoretical on this, but be very concrete and deliver the information accurately as possible. And then community assistance. And this ended up becoming very, very, very important. One of the main things, establishing shelters. We actually had hotels and places to put people who needed to isolate. What do you do when you test positive and you're in a house of 7 other people and you're trying, some of them are vulnerable populations, and you're trying not to get them sick, but you really have nowhere to go. And so it was very interesting to see that during this pandemic, the shelters that we were able to establish. I talked about the testing sites already and how we really had no plans for that initially. And so here in Coconino County, I think we were a day behind New York City as one of the first testing sites in the country that we set up. That was a very difficult process, long process out at Fort Tuthill, out there with FMC, and thanks so much to TGen. We were so lucky because we had these local resources to where we could send tests. The state at the time was only accepting tests if people fit a certain definition, if there was certain exposure or within a certain classification. You couldn't just test a random person. So having resources available, other laboratories to be able to conduct those tests was so, so important. And we were so fortunate in Northern Arizona and throughout Arizona to have that ability. Vaccine distribution, of course, we're all very well of that. The point of dispensing, whether it's a distribution or medication, but we went through and set up the vaccine distribution, mental health resources, and then social safety net services. Once somebody is told they need to isolate because they tested positive, or told they need to quarantine because they were exposed, now how are they going to afford anything? And what do they need to do at that point? So that became very important as well. But I just wanted to provide an overview of how we responded to COVID-19 in general, but then also how we might respond to pandemics, and we can talk a little bit more about that. But thank you. So our next speaker is Brittanya O'Connor. She earned a PhD in epidemiology at University of North Carolina, Gilling School of Global Public Health, specializing in infectious disease epidemiology. She earned both a Master's of Public Health degree with a concentration in environmental and occupational health, and a graduate certificate in international health policy from the George Washington University. She is currently the MPH Program Director at Northern Arizona University. Britannia's research focuses on rural health, health disparities, and barriers to accessing healthcare, including accessing and remaining in HIV clinical care. She has worked at the National Cancer Institute, Worldwide Fund for Nature's Global Arctic Program Office in Norway and throughout Europe, and rural Brazil, focusing on maternal and child health, and at Northern Arizona University.
Okay, good morning, everyone. Thank you so much for having me here today. I'm really excited to be part of this workshop. So I was asked to speak about moving towards an endemic. So sort of coming out of the classification of pandemic and moving towards endemic. So I wanted to start out with just some information about some of the terms. So the first one I have here is epidemic. And so when you hear the term epidemic, I put in those blue boxes some of the sort of keywords that you would think of. So when we have an epidemic of a disease, we're having case numbers and spread of the disease in a way that's sudden, maybe unexpected. It's increasing. It's not really controllable. But when we use the term epidemic, we're usually talking about one area or multiple localized areas. So as all of you know, with COVID-19, this turned into what we call a pandemic. And so a pandemic is when the spread of a disease becomes global or at least pretty widespread. So it doesn't have to affect every single country, but you're seeing some spread across continents or a lot of different countries. And so I put in those blue boxes some of the things you should think of when you think of a pandemic. So we think global or at least multiple countries, widespread, uncontrollable. So then we have the term endemic, and here things are starting to stabilize a little bit. And so as you can see in some of those blue boxes, you might see these sorts of terms used to describe a disease that has become endemic. So things start to become more constant, more predictable, more consistent, more steady, possibly more controllable, because for health departments and healthcare providers, it's easier to sort of plan and predict and be prepared at this stage. Okay. So I liked the graphic on the top with the little needle that goes from sporadic disease, which might just be, a couple of cases, to something that's endemic, epidemic, or pandemic. Because what I think is really important to remember is that blue sort of needle can move between these different categories. So just because we go from, let's say, pandemic with COVID to eventually endemic doesn't mean that we can't move back into having epidemics or even pandemics again, right? And so you'll see the graphic on the bottom trying to sort of illustrate through images. Pandemic is the one on the right there where you see all those red dots spread across the entire globe. Epidemic might mean that we have a more localized area where things are still spreading rapidly, not so controllable. And endemic, what you see on the left, is that sort of more steady or predictable state. So we may still have the disease, such as COVID, across the entire globe, but it's not the same as the pandemic. So I wanted to talk a little bit about some of the ways we classify diseases in the field of epidemiology. So we have what's called the basic reproductive number, which is referred to as R0. And this is really a theoretical concept that we use in infectious disease modeling. And so we look at what's the average number of secondary infections that we have if we had a single infected person, someone who's infectious, introduced into a susceptible population. So this is theoretical because very quickly, we no longer have an entirely susceptible population. Once people start to get vaccinated or they have an infection they recover from and they start to get immunity, they may not be entirely susceptible again. But what you can see illustrated here is an example of an R0 of 3. So if we had one infected person on average giving rise to 3 cases, so spreading the infection to 3 other people, we would say that R0 was 3. So these are the thresholds that we use when we have R0 greater than 1, meaning that on average, an infectious person is spreading the infection to more than one other person, will be in what we say is an epidemic condition. If we have R0 less than 1, so that would mean on average an infectious person is spreading the disease to less than one other person, will eventually move towards extinction. And if on average each infectious person spreads the disease to one other person, we say we're in an endemic or stable disease prevalence. And this graphic illustrates an R0 of 2. So you can see the person in red is labeled as patient 0. So if we had an R naught of 2, that infectious person would be on average spreading the infection to 2 other people. And then each of those people, once they became infectious, they spread the disease on average to 2 other people. So what is really challenging, and this is what happens with COVID, is you can see we very quickly get to exponential spread. So you can see all of the people who end up infected. So as we move towards endemic status, here are some of the factors. These aren't all of them, but some of the factors that can help push an infectious disease towards becoming endemic. So if the infection cannot be entirely eliminated, and we're still going to have it in our population, then protective measures that either prevent or reduce transmission can lower that R naught value. Immunity, even if it's partial immunity that comes through vaccination, recovery from natural infections, can also lower that R naught value and lead to spread to a fewer number of people on average. Okay. But I think it's really important to remember the message I put in the box, and we'll talk about that more in a few minutes, that just because an infectious disease becomes endemic, it doesn't necessarily mean the disease is mild or harmless, or that you don't need to think about it, or that you can end all of your public health or clinical efforts. And as was pointed out earlier, Dave talked quite a bit about mutations, new variants that can arise, changes to that spike protein, for example. We know that change can still happen, and we could move back towards epidemics or even pandemics. So I think a really important message is that we cannot just view endemic as, not being of public health concern. So I copied out a couple of news headlines, and 3 of these are all very recent from 2023. I don't know if you can read the dates up there, but 2 of them are from this month. One of these headlines is from last month, and then the very bottom headline about Arizona is from a year ago. And I put these up here just to point out what all of you probably know, is that there's a lot of controversy about terms and whether the pandemic's over or if the pandemic's still going on, right? So some people say, well, now COVID-19 is in endemic status. And then some people might say, well, it's still a pandemic, right? And I personally don't think it's so important to definitively answer the question of what exactly we're going to call it. I think what's more important is our public health efforts and, clinical efforts. But I put these up here just so you can see just a small sample of sort of some of the controversy and debate when you look at headlines. This article, which is from the journal Nature, I encourage everyone to read it if you haven't already, because I thought there were a lot of really important messages in this publication, not just for COVID, but in general when we think about future pandemics, right? So this article was published in the journal Nature a little over a year ago. This was January of 22. And I took some quotes directly from the article that I wanted to show all of you. So one of the points is that even if we do label COVID as endemic or, a different infectious disease, that doesn't mean, right, that it's harmless. It could still be widespread. It could still be occurring globally, and it can still be deadly. Here's an example of 2 other infectious diseases that are considered endemic, right? Excuse me. So malaria, for example, still killed more than 600,000 people in 2020. 10 million fell ill with tuberculosis that same year, and 1.5 million died. So we have other examples of infectious diseases where we might put the label of endemic on them, but they're still posing a huge cost to life and to public health. Another key point is that sometimes there's a misconception that when an infectious disease becomes endemic, that it's going to become more mild, it's going to be tamed, we'll just go back to sort of a normal life. But that's not necessarily the case. Some infectious diseases that are endemic are like that, but not all of them. Another very key point, just because we might put the label of endemic on an infectious disease, it doesn't really tell us exactly what's going to be happening with sort of the stability of the cases, the case rates, impacts to morbidity and mortality, or susceptible populations. We can still have disruptive waves, right? So even if overall we're saying that an infectious disease is endemic, we can still have localized epidemics. And I thought this was also really key, that we really have to focus on health policy. We have to focus on education around individual protective measures as well. And those can help shape, what form something takes. Okay, a couple of more points. So the same virus can cause endemic, epidemic, or pandemic infections. So, it's just really important to remember, as I showed that picture of that blue needle on the spectrum earlier, we can still be moving through those different stages. And where we're at can depend on health policy, on the behavior of a population, and immunity, and so on. So this is also really important when we think about mutations and new variants. We can think about that for COVID, but also just in general with other infectious disease pathogens. If we have enough mutations and get different variants, we don't know in advance how that's going to play out. So we have had examples where we've had new variants that were actually more mild, but that's not necessarily the way it will always be, right? So we don't know what a new variant might bring. We may have new variants occur in one part of the world, at least before other parts of the world, and that can help shape the progression. And then I thought this was also a really important point. There's often a misconception that over time and as things become endemic, that they're going to be more benign or, not quite as dangerous. And luckily, that's often the case, but it's not necessarily the case. So I think it's just really important to remember that just because something becomes endemic, we still have work to do. I also want to touch on messaging to the general public, because as everyone knows, that's really hard, right? It's really hard to take all of the scientific information and get messages out to the public that aren't contradictory or confusing people, right? So here are some things that endemic doesn't mean. And it's really important that the public knows, just because COVID becomes endemic, it doesn't mean it's going to end, or that we don't need to still think about pandemic preparedness in general. Another key feature, and this is, not just for COVID, but for any infectious disease, even once we're in an endemic phase, it's really important that we keep a special focus on vulnerable groups and think about how to protect them. So which groups are most vulnerable may vary depending on which disease it is, which location. But it's just really important to remember that we may still need to be focusing public health attention on those vulnerable groups. So I looked at some of the current literature on, when different countries or states declare that COVID's endemic, what are some of the sort of changes they make in response to changing their terminology? And these were some of the things that I found. So still focusing on promoting vaccination, depending on if you're in a certain vulnerable group, masking, having general awareness. The second bullet point, movement of testing and treatment from the public healthcare system to the healthcare system. So that definitely seems to be where we're moving towards. Changes to surveillance, how we conduct surveillance, rather than focusing just on the numbers of cases, moving more to a focus on, how many cases of severe disease are we seeing? What's the overall impact? Which groups are being most impacted? In general, we'll probably see more limited monitoring and tracking as more states and more countries label COVID as endemic. We're seeing the end of official emergency declarations, ending of data collection. I don't know if any of you use the Johns Hopkins global tracker for COVID data, but they just recently made an announcement that they are stopping their data collection after about 3 years. So these are some of the types of changes we might expect to see as more states and countries label COVID as endemic. You may be aware of this date. So in the United States, we, of course, had an official declaration of a public health emergency, and that's set to expire. I guess originally it was set to expire in April, and then they moved the date just recently to May. And it's not just what we call it that matters, right? So whether or not we refer to COVID as an official public health emergency or not may not be so important, but it's all the impacts that can come from that. So you can see here, I won't read all of these to you, but at a legal level and a policy level, once we let the public health emergency declaration expire, there are actually quite a few changes here in, COVID testing and COVID treatment and provision of those services and who pays for those services. So some key ongoing needs, I think, are to reduce misconceptions, think about clear messaging, which is, easier said than done, right? So the messaging is actually quite complicated, and I think it's our job to try to find a way to develop clearer messaging, especially when we're going through transitions. Provide ongoing education and awareness, not be complacent, be ready to adapt to new situations. We need commitment at a global level and from the pharmaceutical industry to continue to provide therapeutics and vaccinations, especially to vulnerable groups. Vaccine equity is a key issue, making sure that vaccines are accessible, distributed, and actually available at a global level to people who want the vaccines, and continuing to have some form of surveillance, even if it changes a little bit. So I'm sure a lot of you have seen this visual before. They call it the Swiss cheese respiratory virus pandemic defense. And even under endemic conditions, there are still things people can do to their comfort level or to their need based on if they are at higher risk of a disease. And this is not, just for COVID. This can be applied to a lot of different respiratory illnesses, but there's still, a variety of options available to people that they can take in response to sort of fluctuations in risk levels depending on the disease. So I felt like there were some sort of key things, unanswered questions, key avenues for future research. And one of those is related to immunity. We don't have all the data on, how long vaccine protection lasts, how long recovery from natural infection, that type of immunity lasts. We still will have to wait and see what happens with emergence of new variants, transmissibility of prevalent variants, vaccine efficacy, especially over time. Mortality. So I saw an update. I was looking this morning and I saw some numbers that were more like about 250 deaths per day from COVID in the US currently. But that's still really high, right? So I think it's really important to remember that even though things have calmed down a lot and we may be ending, the public health emergency declaration, there's still a lot of people dying from COVID. A lot of unanswered questions. So as we move into the endemic stage, what's sort of the baseline level? Because COVID is new, we don't really know that. Like, what should we expect the baseline of cases and hospitalizations and deaths? What will that look like? What will seasonality look like? We still don't really know the answer to that. And then I also thought it was really interesting to think about generational changes. So all of us were first exposed to COVID as adults, but children today, it's highly likely that they'll have their first exposure to COVID within the first 1 to 2 years of their life going forward. And we really don't know the science behind that. We don't know, what immunity will look like, what will happen when people have a chance for a greater number of total exposures across their lifetime compared to people who had their very first infection in their 30s or 40s or 50s or 60s. So there's a lot of ongoing questions. And then a few recommendations. So stop or avoid what's termed by this author as lazy optimism. And I think that applies not just to COVID, but we should think about that in terms of future pandemics. We want to be optimistic, of course, but we can't just be too optimistic and blind to pandemic preparedness. So we need to be realistic. We need to be thinking about the risk of new variants. And again, that doesn't apply just to COVID, but to, future pandemics, just for us to have that in the back of our mind. Use all of our public health and clinical tools that we've improved on through the course of this pandemic. Invest in vaccines. Again, that applies to COVID, but also future infectious disease outbreaks. Promote vaccine equity. Try to stop unconstrained spread. And remember, this goes with the bullet point above it, the more unconstrained spread we have anywhere in the world, the more chances we have for new variants to arise. Couple of final quotes. So the first one, defining when exactly the pandemic will end is not easy. So I showed you some of that controversy in the news headlines before, right? So different people will say different things. Are we still in a pandemic? Are we in endemic? We have our definition within the field of epidemiology, but the epidemiological definition is not, really enough just on its own. Endemic disease can still have serious consequences, right? So if we're still having hundreds of deaths per day, that's still serious. Public health measures really have to keep on focusing on the most vulnerable groups, educating them and protecting them. And then this is my final slide. So just to sort of summarize, there's still action needed. We need to really make sure that we don't become too complacent. We have to think about bad things that can possibly happen in order to be prepared for pandemics in the future. But just because we have to think about, things that could happen doesn't mean that we don't have hope, right? So I put that final picture of the flowers sort of coming up from that crack in the ground to show that, we have learned so much from the COVID pandemic thus far, and we can use all that knowledge and all those tools to try to help us be in a good place to be thinking about COVID, but also future pandemic preparedness, to try to protect people and make sure we don't encounter all the same difficulties we have with COVID. So thank you very much.
That was fantastic. Thank you, three. We're bringing our speakers up. So we're bringing Dave and Britannia and Matt up to the table, and we'd like to open it up for questions from anybody in the room and also online.
Thanks. So I have like a million questions, and maybe some of this we can talk about in the afternoon, but just by way of context, so I'm from the journalism school, so the news headlines were great. And I'm always thinking about messaging. And a lot of my research recently has focused on trust and trust in institutions. And so just thinking about all of your different presentations, which were all amazing. And a lot of what you've learned, it seems, is like how to message this to people. And so I don't know, I'm trying to think what actually what my question is right now, but I'm thinking about what you said about not vax shaming people, but I'm also thinking about the importance of vaccines in the long haul, right? And also the way that people conflate the COVID vaccine with like a regular course of vaccination and potentially what's happening to people not getting any vaccinations as a result of this. And so I guess my question is, how do you reconcile those things? Because vaccination is obviously critical, but I see your point. So it's a question for you specifically, since you mentioned that, but I would I'd let everyone respond.
Yeah, that's a great question. It's actually really hard. So as a former state epidemiologist, this was my job, was to really ensure that we were getting as much uptake of primarily childhood vaccines as possible to keep a lot of these diseases at bay that we thankfully don't see anymore, or rarely see anymore. Some, and hopefully we'll never see again. And vaccines are such a critically important part of that. I do believe, the vaccine issue became, unfortunately, not a public health issue, became a political issue. Like so much of this pandemic. And I didn't talk too much about that. To me, that was maybe the most disheartening thing. It was disheartening because we really allowed ourselves to become bifurcated into, well, generally two worlds. There were a lot more than that. But it was, in the end, it was like we had Mars and Venus, not the men and women, Mars and Venus, but Mars and Venus, in which they weren't speaking the same language, and they weren't even talking to each other. They were just talking within their own groups. And so then when you had people who had difference of opinion, they were not only wrong, but they were so completely foreign, it didn't even make sense. And so it became very easy to really do shaming. And I think that vaccines were one of the poster children of this. And I really blame both political sides for this, because they both used it as a political football, and that could be dissected probably for the next 20 years as to how that happened, the timing of that. If we look back, we can see the enormity of the population that got vaccinated. It is completely impressive when we look at the numbers now. Did it all happen overnight? No. And in reality, almost everybody, I would say probably we're at the 99.99% of the population has some level of immunity from vaccine or infection or both. And that is nothing that I don't think we're going to improve that level of immunity now by really focusing just in on the vaccine issue. Like, you have to get vaccinated, because it's really not, the vaccines right now are not as effective as they were at the beginning of the pandemic. We need better ones. We need more. We need to not just focus on just this one vaccine and say that was the end all be all. It was fantastic and it was great. And it had limited side effects. But there was so much mistrust that we were really pushing. And it wasn't just, say, Republicans and Democrats. There were communities of colors that did not want to get vaccinated because they didn't trust the government for very reasonable, longstanding reasons. And we shouldn't have shamed them either. And I just think that we all, I'm coming from the science perspective, but I think we all need to have a bit more humility and grace when we're dealing with each other, because we're still all humans. We're still going to think differently. We're going to respond differently, but we're going to try to do what's best for us and our families. So I do think the tenor of the conversation needs to change a lot. I think that was more of my point.
Yeah, I'd love to follow up on that. I really appreciated the way you framed a lot of this in your discussion, and the what were your words? Grace and something else? Humility and grace. Mwah, love it. But something you said also sent up a red flag for me, and that is both sides are guilty here, which is something which is a sort of favorite hiding place for journalists to sort of give an impression of nonpartisanship. But that both sides bit doesn't always, it sounds like a moral equivalency in an instance where there may not be a real moral equivalency or a public policy equivalency. Can you talk about that in the context of embracing vaccination or rejection of vaccination or suspicion of vaccination?
Yeah, and I don't want to dominate the conversation, so sorry, but okay. So there's a lot to that. I agree that the moral equivalency thing is a problem, but I see this a lot, and trust me, I come from a family that is wildly on both sides of this issue, and as a state epidemiologist, that was very difficult. 20 years ago, it is still difficult, especially difficult today. But what I've learned is people are coming from their perspective for a reason, and it is not because they are completely wrong or completely right. Some will weigh values and their interaction with other humans more importantly than they would weigh what scientific data is being presented. And so it's a balance. And so I think the humility part is for us all to understand we don't have the full picture. And scientists, we're the worst at humility, but we need to have a lot more. And well, we're not the worst. Politicians are the worst at humility. They need to have a lot more people who are trying to get messaging out there. But I think I'm just going to use those two words again. We all need to have a little bit of more grace that we are humans living in this world together, and we are trying to make decisions that are best. There's bad actors on all sides, but they're a minority. Most of us are trying to make the best decisions that we can based off of the information that we're hearing. And if you spent time looking at, and I did a little bit of this because I wouldn't have any hair left if I did much, but actually trying to understand what the news media perspectives were coming out. If you watched MSNBC and got your COVID news from that, you're getting very different news than if you watched Fox for your COVID news, and neither of them were correct. I can point out scientifically where both sides were wrong, but I could also probably point out from a community relations and community understanding where both sides would have been really hard to understand what the other side was saying. So I do think there is an equivalency of everybody was not correct in this. And was not giving enough grace to the other side to try to understand. We got to meet each other in the middle to have those conversations. That's what I want us to do.
Thanks.
Did you have something there?
Yeah, I have one thought to add is that I think that historically there can be a lot of distrust of the medical profession, vaccinations, right, clinical medicine. And a lot of that is very justified due to things that have happened in the past. And then, of course, we have all the controversy from the retracted study about vaccinations and autism from years ago that a lot of people remember, but remember incorrectly. A lot of people haven't actually read that retracted article that incorrectly linked vaccination to autism. They just remember sort of the sensational headlines, right? And I think maybe one of the lessons we might learn from this is that in the middle of a pandemic, when there's an urgency to get everyone vaccinated to try to slow spread and protect people, it's not the best time to be focusing on vaccination. I feel like we need to have more education and work to do when we're not in a crisis mode, rather than just waiting, right, till what happened, unfortunately, is that new vaccines came out and everything was urgent and there's this huge push, and that's not really going to do it for a lot of people who have this historic mistrust or, fear. So I think that's one of the lessons learned, is that just in general, we need to be doing a better job in that area.
I think that was summed up pretty well.
Okay.
The piece, it's a very complex issue, I think, just culturally, in a lot of different ways. I mean, it's so complex. You look at just our societies in general. I take this to be an example of prevention versus reaction, and in general, we're just set up so much as a race to I'm not going to do the prevention steps, but because of my thoughts on it. But as soon as I'm being affected by something, I don't care what's in it. I don't care what the ingredients are. Now that I'm sick, and so really accurately describing the benefits, especially when it comes to vaccines, and its ability for prevention. But one of the things I'll add to that, and is we were in such a unique circumstance when it came to this pandemic, and just how many people were being affected and how it was affecting our societies economically, individually, our communities, everything, hospitals, everywhere we were being so affected. So one of the ways that I put it to people is, we're at war with a virus, and taking a vaccine is better than being shot at. And so I would try to put it in that context of, you're being asked to do something that's going to move us forward, move us to enable next generations to not have to deal with this necessarily, by helping to try to build that immunity, at least decrease the burden of this disease on us in a variety of different ways. And so by doing so, there may be some risk involved in that, but there's a lot of other risk as well by not doing it.
One last point on that. If you are not you, but if you're shaming me because I'm not doing what you think is the right thing, you're not convincing me. You are not helping me come to the middle. You are not helping me understand maybe something that I don't understand. And at the same time, you're not understanding what my reasons for hesitancy might be. And so that is, to me, that is one of the big reasons. Is I think that we did have a lot of very poor messaging about this early on, as well as even till today. So I think we could do a lot better job of, again, trying to understand where you're coming from, and then maybe you'll understand where I'm coming from. And I don't mean you and me specifically.
Okay. So I understand we're running a little late, so if you need to take your break now, please feel free to. But we do have another question I want to pose to the panel, if you don't mind holding off. You just for a minute from Samantha online, and Samantha, this topic is going to come up later on in some of the panels, and already we've seen that Pauline and Lisa will address that to some degree. But to the panel, the question from Samantha is, quote, "I like the call out to vulnerable populations with quieter voices and less value, especially during pandemics and as they move into endemic periods. What lessons can steer future communication or media messaging to support or target care for these populations?" So I don't know if Britannia or any of you want to address that at all, knowing we will come back to that further later on today.
Yeah, thanks for the question, Samantha. So in terms of communication, right, to especially vulnerable populations, I think, if we look at what happened during the COVID pandemic, that was really hard because we were trying to figure out in real time what was going on, which populations were most vulnerable, and what the messages should be just for the general population, much less for, specific vulnerable populations. So I feel like going forward, one of the lessons learned would be perhaps to talk to some of those vulnerable populations, hold focus groups, just have conversations with them, maybe around the messages that were used in the past and what was unclear, and actually solicit some input on how messages might have been made more clear that we could then use for current messaging for COVID, but also for future pandemics. And I feel like messages ideally should be very well tailored to the population. So it's hard to give sort of a general statement. I think you'd have to really try to understand what are the key concerns or barriers in each population, and maybe develop many more messages, not just one that you could provide at a local level to vulnerable groups. So I don't know if that completely answers your question, but I feel like we'd really need to talk with those populations about what maybe went wrong with previous messaging.
I think that's a great point, Britannia, is oftentimes, and a lot of times during this pandemic, during an emergency, you're trying to get out as much information as possible. So the communication is always very broad. And we treated the entire population like they're all the same, like we're all a bunch of cloned lab mice that will all respond the same. Our immune systems will respond the same. We all have the same issues. And none of that's true. We were lots and lots of different communities of people that are all different individually. Our communities are different. And so we need better messaging to where people are at, so that especially if there's specific risk information and protection information that could be brought out to specific communities, we got to have better focused communications, and understanding that not everybody's going to hear things the same way or need to hear things the same way.
This will be our last question, and we'll take a 3-minute break and then come back after.
So I am actually a frontline healthcare provider. I work in the emergency department at FMC. And one thing I've noticed, well, first of all, thank you all for your hard work in this pandemic. Like, the things you all have done has honestly made my life much easier. So thank you. But one thing I wanted to ask about is how we can improve communication between frontline staff and the research and the work that you all are doing. By frontline staff, I mean, doctors, nurses, everyone else who's kind of working in like the on the front lines, health, like social workers, anyone who's in this kind of field. I just have noticed that there's a pretty significant disconnect between the work that you all are doing and what I'm hearing kind of on the front lines, and how I would be curious for our next pandemic, hopefully not in my lifetime, how could we improve this kind of messaging and communication between you guys and me?
do you mean communication to your patients or communication amongst your staff? Communication to between like public health and
you're doing and communicating to me in particular, let's say as a nurse or a physician,
yeah, definitely. Yeah, super important because that's where, and that's one of the main roles I see, especially within public health, but a variety of different spheres is, taking the research that's out there and being able to bottle it up in a very understandable way. So understanding what the research is, interpret that, understand it, and then being able to put it back out to the community of people who need it. So for the medical community, for instance. And for me in that field, I think it's super important to keep those networks open. Who is what I did locally, at least, was try to reach out to who is within our medical community, who are the leaders, but then who are also the frontline staff, and how can we open up those lines of communication? Be like, okay, here's what I'm seeing. Here's what the researchers are saying, or here's what we're understanding, here's what we're being told from the feds or the state or however. And so really, really piecing together, finding a way to have that place where those groups can come together and meet, whether it be physically or virtually, but talk, right? There's reporting that goes on and there's communication that goes on between, like at the hospital, for instance, it's your infection prevention group. So we're talking a lot, but then it sounds like you're talking about disconnect between frontline staff and then who public health or researchers or education are talking to and talking with. And so, yeah, it's a very good question. It's a very hard one because ultimately it's channeled right now. It's through the media. We'll put it out there through the media and you can read about it, or we'll tell like your boss's 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 boss. And then that information may not get there either. But the more that there can be actual meetings or meeting places or things like this that we're doing here to be able to know, okay, who's the person I can call? What meetings can we set up? How can we open up those lines of communication? Because that's a super important thing, especially within public health or research or education, is to get all this great information out to you all to be able to utilize. And then also share stories too. So, because you're talking, like I was asking, are you talking about the public? So I talked a lot with the public. You're talking with the public. And so what are ways to frame the messaging and what we're trying to get across? So I don't know if that helps answer your question at all.
Yeah, it does. Yeah. I kind of would be curious to see how that would translate into future conversations.
Yeah.
I would love to see something more centralized.
Yeah.
Not just relying on, let's say, the conversation you were having with my infectious disease staff at my hospital actually getting down to me.
Yeah.
There's an board of nursing.
Yeah, or being included in some of the briefings as well, to where you have, you have your morning briefings or weekly or however, being involved in that and the outreach there, so that way the staff are getting to hear directly from any of us. I don't know if anybody had other thoughts on that.
Well, I just think that what you're pointing out is we can do better. I think there was a lot of efforts, and especially I know in this northern Arizona, as I was pointing out, Matt was just doing a tremendous job trying to help get as much information out on as a regular basis as possible. But it was not enough because everybody was involved. Typically, we've been through a lot of emergencies before. Not everybody's involved. In this one, everybody was involved. So we didn't have great communication set up for everybody to hear it the way they needed to hear it. We can do better.
Okay. Thank you all. Let's take a 5-minute break.
All right. Yes. So our first panel is going to be about health and health messaging. We have a mix of people in the room and people on Zoom, which hopefully we're going to be showing them. Oh, wait, I see. Pulled everybody up, meaning. Oh, yes. Sorry. I just assumed everybody was going to come up, and because I'm going to have everyone introduce themselves rather than do a calling up, because it's a fairly large panel. I didn't want to take up too much time. There we go. Now we have Lisa and Pauline on Zoom joining us, and we have Alexis and Nikki and Jonathan here in the room. So as I mentioned, this is, I think, our largest panel discussion of the day. So the way that we would structure this is give everybody, a couple of minutes to introduce themselves, talk a little bit about the work that they do, especially relevant to our topic today. And then we'll go into kind of a larger discussion. And then hopefully we will have time towards the end to open it up to the room for some Q&A. So why don't we start here with Alexis, and then we'll end with our panelists who are on Zoom.
Hi, so everyone can hear me, right?
Microphone?
Okay, just kidding. Oh, great. Hi. Hi, my name is Alexis Koskin. I'm an assistant professor of public health at ASU's College of Health Solutions. Today, the hat I'm wearing is related to some research that I've conducted with Dr. Christy Roschke, who's also here, about some work about folks who were considered positive deviants who had really great information practices related to navigating some of this COVID-19 messaging. Just in general, my background research is community-based research. I'm a qualitative researcher. I enjoy mixed methods and intervention research. And really starting to work with populations to figure out what works best for you. So with that said, I'm going to pass the mic.
Hello, my name is Nikki McLaren. I'm an assistant professor in the Walter Cronkite School of Journalism and Mass Communication. And so in context to this room, I feel my experience in vaccines is pretty recent. I just started in 2018 before the pandemic, but was really interested in why parents were choosing to get philosophical waivers for childhood vaccinations and really exploring those reasons. And so I was going out to farmers markets and community events and interviewing people, even though I'm mostly a quantitative scholar, and then also looking at what messages are being put out there in entertainment media and media that might be incidentally or implicitly persuading people to have certain beliefs about vaccines. Then clearly COVID happened, and my research geared towards that and looking at trust and the role that trust was playing for different groups in getting the vaccine. And my research mostly looked at two things: of one, what beliefs did people have that were informing their trust, but then also what beliefs did they have that could potentially affect their trust in the future. And so for example to that, we found a lot of people, specifically who were Black and African American, were saying beliefs related to COVID, the vaccine, this was before the vaccine got put out, that it was a cure to COVID. And they use that wording a lot, that it's going to cure COVID, which for us, we know that could cause issues in the future related to trust. If, hey, you get the vaccine and it's not curing you. So that's just a little snapshot. We can talk about it more.
Thank you. Good morning, everybody out there. I've been Jonathan Nez, former president of the Navajo Nation. And what interested me in this morning's panel was the study on the White Mountain Apache tribe, TGen, and the mentioning of only two variants that were prominent in that community. And I think what we're going to be talking about today about messaging and the media has a big play in that. And I'll talk a little bit about the Navajo Nation in a bit, but to all our healthcare professionals, our frontline workers, our first responders, I guess everybody, right? Good job throughout these, 2-3 years in this public health emergency. We all came together and helped our citizens, and I appreciate each and every one of you for the hard work that you have done. Thank you.
Great. Thank you, President Nez. Let's move to our Zoom panelists. Let's start with Lisa.
Hi, I am Lisa Hardy. I'm pleased to be here. I wanted to be there in person, but can't make this up. I have COVID. And so here I am isolating. I want to thank Britannia for your talk, reminding us that this isn't just a cold. I've been miserable, and so have my daughter's teenage friends are in a lot of pain and they're suffering a lot right now. We all were exposed. So that is why I'm not here in person with you. I started COVID research with my little team at that time within the first week of the declaration of the pandemic. We wrote an IRB the day of that declaration and started interviewing. We grew our project to an international 9-country collaborative, and now we continue on, including some local youth-led partnerships. We're right now interviewing Southwest teens about youth mental health. If you're interested, we have written 6 peer-reviewed articles. We have a few more. We've got a book on pandemic governance, and also did a lot of work, 6 op-eds and essays, getting our research out to public audiences collaboratively, and have thought a lot about what that messaging looks like and kind of how we had to work on messaging things in a way that sometimes meant pushing on the expectations for how to communicate about the pandemic during that time. And this work is ongoing. But I'm pleased to be here with all of you. Thank you.
Thank you so much, Lisa, for joining us, even from your isolation space. And last but not least, Pauline.
Hi, everybody. My name is Paulina Arriaga, and I'm joining you from the Cronkite School here in Phoenix. I'm also sorry I can't be there with you in person. I will say I think I may be the only actual journalist in the room, so please take it a little easy on me. I promise that's not why I'm not there in person, but so before joining the Cronkite School in 2019, I worked 27 years for the Associated Press. I was a senior national writer there, covering major news stories across the globe, as well as deep features and enterprise stories. I then was the head of U.S. enterprise journalism. So I was one of the senior editors at the AP. I came to Cronkite in 2019 to launch our Robert Wood Johnson Foundation Southwest Health Reporting Initiative, where we are working with the journalists of tomorrow and teaching student journalists to report on health disparities in underserved communities and communities of color. I'm very proud of them. I'm very proud of the work that they've done. I led our student coverage of COVID throughout the pandemic for Cronkite News, one of our professional programs here. And Cronkite News, if you don't know what it is, it's a lot like the AP. Cronkite News produces daily coverage from across Arizona, but also around the Southwest, that is delivered to professional media outlets ranging from KJZZ, the NPR station here, to Arizona PBS, the Arizona Republic. So our content is used all across the country. And I personally just want to thank President Nez, because he was very, very helpful to us and to my students in a lot of the coverage that we produced during the pandemic. So I'm now in a different role here at the Cronkite School, and I'm not going to get into that. But again, happy to be here. I hope I can provide a somewhat different and important perspective.
Great. So I'm so excited to have such a panel with so much expertise and such a diverse array of areas of expertise and experience. I think that's going to lead to a really interesting discussion today. So I want to start out by a question, and we can do this. I can handle handing off the mic to anyone who wants to answer in the room. And if you're one of our Zoom panelists, you can, raise your hand or just intervene. We'll try to keep this a fairly informal discussion as we move forward. So I want to start, what do we know, or what have we learned about where people actually get their health information, whether that's on purpose or information-seeking behaviors, but also, as Nikki alluded to, these messages that we might be receiving through entertainment or other types of, where does our knowledge and understanding of health issues come from?
I'm actually happy to jump in on that and then turn it over to Nikki. Oh, sorry. No, go ahead. And Dawn, can you hear us okay in the room?
Yeah, absolutely.
All right, I'm going to try to share my screen very, very quickly. Can you all see this there in the room?
Yeah, I have to say yes on the microphone.
Yes. Okay. I can barely hear you, Dawn. So this is a very early study that Pew Research Center did, and specifically it was around COVID and where Americans are getting their news. And I think it's very, very interesting because what it's going to show is that it was sort of equal between national news and state and local level news. But to me, this is the more interesting for this audience graphic. So 56% of Americans said national news outlets, 51% said public health organizations and officials, then 46% said local news outlets. So I just wanted to share that to kind of start the conversation off, because I'm going to return to the import of number 2 there, the public health orgs and officials. But I just wanted to share that, and I can turn it over to other panelists.
I'm actually so pleased with the order of this this response.
I thought you would be.
Yeah. So I think she gave a great overview of where people in general, based on this Pew Research survey, I'm guessing, response of where people were getting their information. When we conducted interviews with folks across the nation who had the top knowledge scores on COVID-19, and by knowledge scores, we use Kaiser Family Foundation's most common myths about COVID-19, and we paired that with 10 additional questions related to myths. Then we conducted in-depth interviews with folks who scored a perfect or near perfect score on these knowledge-based questions. And we really aimed to interview a diverse array of individuals coming from rural areas, towns, suburbs, big cities, and then across the political spectrum. We found that the people who, and this might not surprise you, had that great information or more accurate information, trusted science. They trusted the CDC. They trusted the World Health Organization. They called them out by name. They trusted Johns Hopkins and the Johns Hopkins dashboard. They trusted Cleveland Clinic. They trusted Mayo. And some responded, oh yeah, we trust social media. But social media was used in 2 ways. We totally trust it or we totally don't. Usually if it was a we totally don't trust it, they're reporting Facebook. My angry uncle got online and posted some nonsense on Facebook about COVID-19 vaccinations, et cetera. When people were more likely to trust information, it was coming from very specific sources on Twitter. So I chose to follow this physician. I chose to follow this public health organization. I chose to follow the leaders. When they trusted other sources, it also included Reddit. These were some of our younger respondents, not surprisingly. I see some of the younger folks giggling a little bit. Not that anyone in here is not young. But they would respond, hey, we'd follow these mega threads, which served as these RSS feeds that gave us really up-to-date information. And they describe how each page on Reddit really served as its own moderator. So depending on the personality of the page, you'd get good information. And often, if it was a good information page, people would kind of shame out the people posting nonsense. So it was almost this debunking of poor information, or even removing of poor information, if it didn't align with the views of whoever were the main moderators of the page. In terms of news, we got a mix. Some folks said, oh yeah, I get, the overview of what's going on from national news, but really people trusted local. And I think that feeds back to some of the responses that were in the last discussions that were being held about this community context, this local context. Sometimes national news or even state news didn't really fit the reality of, okay, I'm in New York and you're reporting on what's happening in New York City, but I live in upstate rural New York. What you're saying about New York City does not apply to me. So I'm going to trust my local health department, and I'm going to trust the reporting of what's going on locally. And so in my mind, this kind of brings this question of, in what way should we respond more at that community level than at the sweeping national level, which was divided by politics right before a national campaign, right? And during a national, and then right, after, of course, science is going to be politicized. So these were just some of the main sources that people reported. And then also, again, people who were trained in science, whether it's public health, whether it's medicine, whether it's, I've got this cousin who, is a very strong advocate, and she just finished her nurse practitioner program. Fill in the blank. People often trusted folks who had some kind of scientific training with this belief. Again, these are the folks that had this accurate knowledge of the 17, 18 answered correctly questions, with the belief that they don't have a hidden agenda. They have no reason to tell me the information that they're providing. We're interested in listening to them because I don't think that they're trying to persuade me to do anything. They have, again, no ulterior motive. So if these folks perceived that there was some kind of hidden agenda, they were more quickly to start questioning, well, why would I believe you? And then begin cross-referencing information to verify what seemed or did not seem accurate, or even asking their healthcare provider, hey, I learned this. What do you think about that? We're just, again, some practices to better clarify those sources information.
Oh, okay. Yeah, so going off of my work, I suppose in entertainment media, I don't think anybody is turning to Grey's Anatomy to get information about COVID, right? I mean, I don't think during the crisis, during those decision making, I mean, just in production, right? It was hard to get that content out there. But I do think entertainment media can serve as a reflection and also an influence of how we think about issues and our beliefs and our feelings towards it. And I'm not sure if anyone does watch, for example, medical dramas. I mean, I do for research, just for research, but literally every medical drama out there had some type of COVID storyline. Grey's Anatomy had a whole season about COVID. Chicago Med, New Amsterdam, all of these shows. And I've done research not post, but in 2021, 2022, that looked at how people felt about health information in fictional television shows. And surprising to me was that most participants said they thought that medical shows, crime shows, all of these shows presented accurate and accurate information about health issues. And this stemmed from this belief that TV producers, TV writers were not going to be putting false information out there, that there is an obligation not to put misinformation, so that the information put out there must have been fielded. It must have gone through the accurate means. And so for the communicators in the room, or those who are trying to shape beliefs and behaviors, I think entertainment media tends to go overlooked for its influence on a lot of health beliefs and behaviors. And, that's my soapbox for the day.
Well, and I do think it's important. Yeah. So I do think it's important to think about not just deliberate. Is it that one? Okay, that's working. So I do think it's important, and that's why I framed the question that way, to think not just about deliberate information seeking behavior, because we all receive messages, cultural messages, ideas, information, things that get transformed into what we store in our brains as knowledge, even when we're not looking for it, right? We get it from our families, we get it from our churches, from our schools, outside of class, from our friends, and I think from the media. So I think that's really important. President Nez, I think that another important factor here to consider is that lots of different communities would have different places that they go to find or seek information. So I wondered if you wanted to add anything to this about, from your communities, are there any differences in how and where people get their information about health issues?
Overall in Indian country, we get our information from the radio because it's being broadcast in our own language, KTNN, word of mouth from government meetings, but because of COVID-19, there were no face-to-face, in-person government meetings. Newspaper is another. But I guess COVID really forced tribes and tribal members to get information from the internet. There was a really big push, I guess, overall, right? Everyone being pushed to the internet. And we utilize that to our advantage on the Navajo Nation, Every week we had town hall meetings all the way up to January 10th. Of this year, we had weekly town hall meetings. I would present, and I would also translate in Navajo to the Navajo people. And then our epidemiologists, Matt and Dell, many of you all were a part of those national and statewide discussions, and we would get that translated into the Navajo language. So there was a question about healthcare professionals. A lot of our healthcare professionals on the Navajo Nation would tune in to these town hall meetings. And we had special guests, I guess you could say, at our town hall meetings. Dr. Fauci was one of them. Dr. Anthony Burla from Pfizer was one of them, and many others. Bringing them in and having them talk about what's happening nationwide. And I even heard stories of family members who would tune in just for that town hall meeting every week and share that screen with their elderly because it was in the Navajo language. And that's how they got their news. And then that's a lot of information that was being sent out to our Navajo people because they were informed. Of course, the national media was very helpful, giving updates. Gosh, CNN, Fox, MSNBC. Gosh, there was just so many national reporters, international and even statewide, Cronkite as well, getting that message out there for Navajo. And I think it really helped not just get information to Navajo people, but also letting everybody know nationwide that this is a virus that needs to be dealt with appropriately. And so we used that opportunity to share with the rest of the world what was happening on the Navajo Nation. And Navajo Nation is 27,000 square miles of land. There's about 408,000 members, and half of those members live off the Navajo Nation. So maybe this is going to be another question later on, but just imagine how hard it was to keep people out, because we didn't want to keep our own people out. We did these lockdowns, and I got a lot of pushback from Navajo relatives who wanted to go home and check on their family members. But we told them, well, we want to develop this bubble on the Navajo Nation and keep everybody safe. But I got a lot of pushback from members living off the Navajo Nation. And, I was just mentioning to one of our travel members here today that maybe that's the reason why I lost the election too. But like I said, I would do the same thing over again to save Navajo people lives, everybody's lives. Thanks.
No, it is important, to think about the fact that when we're talking about information or messaging, that there are tangible impacts, right, on people's lives about the messages that they receive and how they behave as a result of them. So to kind of follow up on this, when we looked about where people get their information, and of course, as has already been touched upon, a lot of it has to do with trust in specific media, but trust in other types of institutions. Kirsty brought this up earlier in her question. What kind of impacts have you seen in your work in various areas related to different degrees of trust, where people trust, loss of trust in different institutions, and how we might be thinking about that trust as we prepare to face future pandemics? Yeah, go ahead. Jump right in. Oh,
hi.
Yeah.
Okay. Yeah. So it's Lisa, which I guess you can all see me. I want to say before I jump into trust that I just also echo Pauline's comment about I'm also honored to be here with Jonathan Nez. And I want to say that studying this from the very beginning, from day one, the ability to watch the way that the Navajo Nation under your leadership handled this pandemic and how effective it was and what it meant to be living during a time when there was a lot of narrative about different communities, indigenous communities and indigenous tribes and people of color, this sort of narrative of people are vulnerable and suffering, when in reality, we saw these brilliant ways of managing the pandemic from tribal nations like yours, I think is so important. So I just wanted to say that as someone who's been studying this so carefully and watching it, that's really stood out to me as one of the really important ways. And that doesn't mean there isn't suffering and grief and loss of life. It does mean that I admire and want to highlight the effectiveness and brilliance that came out of these different ways of managing the pandemic in tribal nations and elsewhere, including the Navajo Nation. So thank you for that. I think that I'll just say quickly, for thinking about trust and mistrust in our research, we did not find high levels of trust, and we did not find high levels of trust in government. In our research, we were looking at general populations, and we still are looking at a general population within the US, so people over 18 within the US, across the political spectrum. And what we found was that on both sides, and I think there are multiple sides, so saying both sides is not very accurate, except for that we looked at people on extreme, sort of both sides extreme, and then all throughout. And what we found was that on different levels of political perspectives, there were very different ideas from the beginning and now about what caused the pandemic and who should not be trusted, but that there was a common thread that there were powerful people and are powerful people in charge who should not be trusted. Who those people are varies. So on the far right, we heard a lot of Chinese government, things like that. Chinese people, some xenophobia there. Of course, that's not a surprise at this point as we look at all the research that's coming out. On the left, we heard a lot of greed, healthcare, pharmaceutical, whoever it was, there was this common theme that we cannot trust. We are not safe. There is a secret group of elites who are out there to get us. And so I think that was a really important finding, and it continues now, where people were saying we're looking at all different news sources. Especially in the beginning, I wake up, I listen to NPR, we ask people, and they would have a long list of the different places that they went. And usually they would also have a personality, maybe a blogger or a vlogger or someone who they would go to regularly. And then over time, people stopped looking at all the news. People started to think about just surviving and figuring out, just talking to my family. So it has changed over time, but the levels of trust were low. And that is across the board, which I think we put this in +1 in an article, which I can link. But I think that's something that really points to the idea of looking at the healthcare system, of looking at the kind of power that's involved in the healthcare system and also in government that we can look at as part of future pandemic response. And we have some recommendations at the end of that article that kind of tell us that there's something else going on here besides people on the fringes who are saying that the pandemic is nanoparticles that are being injected into people through the vaccine, that there's a lot of other mistrust here too, all throughout the population. And that's something I think we need to take seriously.
Yeah. Any other thoughts about trust?
Add.
Yes.
So this is less about, it's on. Yeah. This is less about the work with the folks who had good knowledge and more about some research I had conducted with folks living in rural Arizona. And whenever I'd ask, like, who do you trust, who do you not trust? I saw waning trust in the CDC. People who were less likely to vaccinate would report less trust in the CDC. And it kind of led me to question, at what level of transparency, what's too much and what's too little transparency, right? We had information from Operation Warp Speed that was telling about vaccine development. People were learning more about VAERS, right? Like the Vaccine Adverse Events Reporting System. And people would start hearing things, and sometimes that information would be construed correctly, sometimes incorrectly. I really liked the statement that David made about everyone made mistakes about everything. And that is a really great, transparent statement. Sometimes that's almost like scary for people to hear, though. And that could erode trust in science, because, oh my goodness, if these people who are supposed to know and supposed to be the people who save the day are unsure of what's going on, who do we trust? Right? So we're going to trust our confirmation, our own biases that we have, and we're going to trust our own intuition. And we're going to stop trusting science because science doesn't have it fully correct. So it's this really interesting question of, yes, transparency is great, but how much transparency is too much transparency to allow people to keep trusting that we're all learning together and we're using these tools that are supposed to reduce bias to get you the best results. But sometimes there are ebbs and flows in science, and you don't get to the answer automatically. There are scientific studies that move you forward a little bit, and then there's some that kind of move you back a little bit, right? And then there's some that you learn something new and you question information that seemed to be publicly accepted. I remember some of the interview participants mentioned Dr. Fauci saying that this whole debacle about mask wearing, when we were told, yes, you need to wear masks, but don't go run out and get N95s. But yes, you need N95s because they're 95% protective, right, against, X, Y, Z particles. And if I'm misstating that, I am so sorry. But that this mask debate made them question Dr. Fauci. Additionally, there was this book that had been put out by one of the Kennedys that was called The Real Anthony Fauci, which was this whole conspiracy about who he really is, what he's doing, and questions that you should be asking about scientists. Comes out, the same individual was named one of the disinformation dozens who was actually buying Facebook ads and who was targeting minority populations with misinformation specifically about COVID vaccines. So yeah, a lot of public health entities, experts were really questioned at this time. And so, Pew Research published a report saying that trust in science is an all-time low. When you zoomed in, you started seeing that there was a political divide. And that pointed to, where are people getting their information sources and what kind of agenda might be going on with those information sources. And so the Pew Research article pointed specifically to people watching Fox News and who identified as being more politically conservative were more likely to question trust in science and public health. And so another question is, how do we start, without further dividing a country, how do we start getting more trust from all entities in folks who dedicate their lives to trying to help prevent and control disease? So that was a very long-winded way to say public health. Took you on a journey through my brain. But yeah, public health and medical experts, I think, lost trust over the pandemic, but it wasn't all of the population. It included different subsets of the population.
Well, what I am hearing is that it's an issue, to a large extent, an issue of science literacy, right? To understanding how science works, that just because scientists today are more or less, well, we already know from climate change research that any kind of dissent or disagreement among scientists can be weaponized for political or other types of agendas, right? And people often don't understand that, but especially when you're looking at something that is brand new that we are learning as we're trying to address the issue, right? So we have this novel virus, we're learning about it and trying to manage the crisis at the same time. So of course there's going to be, first we said this thing and now we're going to backtrack and we actually found that this other thing. People who don't have good science literacy say, these scientists don't know what they're talking about, or none of this is real. Nobody knows anything, right? So, I mean, that sounds kind of like what you're saying, that is eroding trust. Nikki, did you want to build on any of that?
So
this actually came up because when I was publishing the article, I was talking about one of the reviewers justifiably said, "You're measuring trust kind of poorly." And I was like, yep, that's true. I did. And I know there's a lot of work being done in the political science and the political communication spheres trying to disentangle what trust is and specifically how that differs between distrust and mistrust. And there's different definitions because once that reviewer said that, I went into a, my little academic Google Scholar hole of how do we define this? And some define distrust, right, as more of a negative approach to the situation. Sometimes people specifically say based off prior experience, whereas mistrust is more kind of a suspicious, questioning attitude that you're not just thinking they have your best interests at heart. And a article that I just recently read, which I thought I would just share, was I want to give them credit. So Jennings et al. 2022, they did a big survey of US, UK, Japan, Australia. I'm missing a country, but they looked at trust, mistrust, and distrust measures and how that affected different pandemic behaviors, not just vaccines, but mask wearing, social distancing, all of those things. And it was really interesting. They found for specifically US participants, trust was a double-edged sword. So low trust resulted in less prevention measures, but also high trust, too much trust, how they defined it, led to complacency, where people weren't actually engaging in the behaviors because they're like, they got it, they'll be fine. And it was actually those who were slightly mistrusting, right? Not necessarily distrusting that they have negative intentions, but had this kind of questioning, kind of literacy mindset of, okay, I'm going to think about this information and what it means and compare it and analyze it, were the ones that ended up having highest prevention behaviors, which I just found
very interesting.
Yeah, notey.
Pauline, I wanted to ask you if in your students reporting about COVID and the pandemic, if you encountered any particular situations related to these issues of different types of trust, whether they had trouble maybe talking to people because of a lack of media trust, or if there are any surprising or interesting findings that came up with regard to trust in different types of institutions.
Sure. And I may not exactly answer your question, but I'll get there. I'll touch on it. I wanted to go back to the idea of transparency. So yes, it is, of course, a media literacy and a science literacy issue, but, trust in the media is at an all-time low, as we all know. And so we hope the responses to that, the way to address that is transparency. So I'm a big advocate of transparency. And I would say early on, some of that messaging, I think, was overly definitive and overly conclusive when clearly we all knew we were dealing with something not seen before. So I think folks on high figured that out in public health and in the federal government and began changing their messaging. But by then, it's too late. Again, you're always going to have that group. You're not going to win people back over because they already have mistrust. They already have distrust. So that messaging from early on is so important. But I want to show you something else on transparency, especially when we come to how lessons learned, I'm going to come to this. Transparency too. So look, data, transparency in data. And a lot of conversations early on this morning were around data and managing the data. So one of the things I would say is be as transparent as you can. And remember that when you're putting data like this out to the public, think of yourself as an everyday American looking at this data. Does this data, it's on the right side of my page under people in Arizona. We're talking, this is the AZ-DHS Vaccine Administration. I wish I were in the audience or in the room with you, because what I'm asking is, does this look transparent on the face of it? Does this look transparent on the face of it? Total number of people who have received at least one dose, percent of people vaccinated, percent of eligible people vaccinated, number of people who are fully vaccinated against COVID. There's a big thing that's missing there. And that is the percent of people who are fully vaccinated against COVID. So what I would tell you is, do you want to know how many media outlets assumed this 76% was the number of people fully vaccinated in the state of Arizona? I saw that error so many times because, look, journalists don't like to do math and they're not great at it. Sorry to throw my colleagues under the bus. This forces you to do the math. In reality, there's about 64% in the state fully vaccinated. Why can't we just add that if we want to be fully transparent and if we want to help the media get the story right? So I mean, Dawn, that doesn't really answer your question, but I have a lot of advice and lessons learned everybody has mistrust. I mean, I had to tell our student journalists again and again and again, 76% of Arizonans are not fully vaccinated, even though that's what this might look like to you.
Yeah. I think it actually does address the question because, one of the guiding principles, I guess I would say, behind the organization of this event is that it's important to bring together in a room people from health institutions, media, research, et cetera, to talk about these different perspectives. And I think that you highlight one of the reasons, clearly not all of it, but one of the reasons why there is this lack of distrust, because sometimes people who think they're being clear and putting information out that makes sense to them from their perspective within a particular discipline or institution are putting information out there, but others who are taking it are not reading it in the same way. And then if a reporter uses that 76% figure and then they're corrected by a public health official, both of them lose credibility, right? It looks like, why isn't the public health institution putting out accurate or correct data, or at least, and then also, why can't the journalists get this right? So we're back to everybody is wrong.
and the cynical part of every journalist is, are we trying to make it look like more people in Arizona are fully vaccinated than are? That's the cynical part of journalism. We don't want to think that. But again, one big piece of advice as we're managing data is, I would suggest, especially because people are getting their news from local news, and local news, you're going to have maybe even people with a realm of experience in journalism have almost tutorials. When you're having those regular calls, really make sure they understand the data that you're sharing with them. Walk them through it. Make sure that they clearly understand how to interpret that data. I think if we just have more actual conversations around, here's what we're trying to say. Do you get what I'm trying to say? So that you can then communicate it properly to the community. Oh my gosh, I feel like we would just make huge strides in messaging and in trust.
Well, and going back to the earlier question about how to get some of the information to frontline workers, et cetera. I mean, we know this will probably come up later in our disinformation panel, but we know that a shocking to me number of healthcare workers were purveyors of misinformation within the medical establishment, which is another issue. But how do you get accurate and correct information to those people? And it came up that the media is an important vector for that, which means that, yes, the communication link between our public health institutions and government institutions and media organizations needs to be closer. It needs to be more collaboration and dialogue up front. Well, that's a good segue into my last question for the day, which is, what are some of the takeaways that we can use for different types of messaging campaigns, or how we address trying to get the word out about the next big thing, the next pandemic, or the next major healthcare crisis that we have? Anybody chime in?
I'll go ahead and start. I think we all know the issues that came along throughout this pandemic. There was lessons learned. Back to the previous question, I think what helped with the trust aspect of Navajo people, maybe Indian country. For us, we had Navajo professionals scientists. Gallup Indian Medical Center, one of the largest Navajo area, was headed by a Navajo, one of our own, Rosalind So. And now she's the director of the Indian Health Services. We had Dr. Jill Jim, PhD in public health. Del Yazi, one of our Navajo who speaks Navajo, epidemiologist. And so that helped, I guess, overall rebuild the trust towards the federal government or others. And so there are leaders out there that help rebuild that trust. And I know in the state of New Mexico, Governor Michelle Lujan Grisham did an outstanding job. Even Governor Herbert from Utah, not so well here in the state of Arizona, but I'm a voter of Arizona, so I can say that. But, one of the things that really help overall, and this is something that we would like to build upon, God forbid another pandemic, is to utilize our way of life teaching in this. That's what we used during the pandemic to regain and build that trust. We used our stories. There's a story in Navajo culture, and we learned this when we're growing up. When there's a storm coming, you go home. The safest place to be is at home. And that's why it made sense in Indian country or Navajo that when we did the lockdowns and stay-at-home orders, people knew that was the safest place to be. And then when the storm comes, you stay home and you stay reverent. You don't run around. You don't do any other things. You stay reverent until the storm passes. Then you get back to normal. See, those are examples of teachings that we use along the way where our Navajo people could understand when we were talking to them in our own language. And it's no wonder we had a big percentage of vaccinated people in our communities, and more so of our elderly, 60 and over. I know when I was in office, we were at 80%, over 80% fully vaccinated of our elders, because they understood those teachings and those stories. And they knew that it would protect not just them, but it would protect their families, you see. It wasn't about us, like, society out there. You're not going to force me to wear a mask. You're not going to, force me to get a vaccine. But I think in Indian country, maybe in other places, it was more about others, less about being about themselves. So we used our teaching. I think there's a lot of opportunities to do that more into the future. And, with the politics, everybody knows the politics. I know maybe a year and a half ago, there was a reporter that came to me saying, people say masks don't work, and you're just putting a burden on people. Some would say you're putting a burden on your people. And what do you say to that? And I said, well, at that time, we already knew the data. I think when we were going through these mask mandates, we realized that not many people got the flu or all these other viruses. So you go back to pointing at the data now for an endemic now, or the lessons learned. We point at those, the information, the data, and the science, that there's some truth and much truth into some of these protocols that were put in place. Like I said, majority of our people live, bless you. That's my son, Christopher. And as you can see, he's still wearing his mask. And, being in 3 states, 408,000, more than half living out the Navajo Nation, it was hard. especially when in Arizona, when they didn't have no mask mandate. People come home and say, well, there's no mask mandate out there. Why are you forcing us to wear a mask? Or you get travelers going through the Navajo Nation say, we're in Arizona. No, you're on a sovereign Navajo Nation. You are mandated to wear a mask. That was the difficulty throughout my tenure in trying to push back on a lot of the politics, especially in the state of Arizona. But, we overcame, and I think the Navajo people, I always say, did an outstanding job by following these protocols. Thanks.
I'll just keep it short. I think we need to know more about trust and the influence of pandemic behaviors. And I think mistrust, distrust, and trust are not mutually exclusive, right? You can trust the government, for example, but distrust that they have the information to help I don't want to say fix, but help prevent the spread. And so, and the messaging, I think, we can talk about this more in the workshop, but I think the messaging does need to recognize, as was said in previous panels, that there are many people and communities that have legitimate reasons for distrust and legitimate reasons to have mistrust when giving information, and it cannot be ignored. And just echoing what was said in last panel, right, just pushing the behavior doesn't work from a communication standpoint. And so there just needs to be, I think, more work, and we'll talk about that in the workshop.
I'm going to try to tie some of the things I've heard in both of these panel members' responses to this question. Is that there's an element also of narrative. Some people really respond well to numbers, stats, etc., but other people really respond to community-based, community-level narrative. And it sometimes this one size fits all of we'll just tell this one story from this one perspective is not going to resonate in all communities the same way. When it comes to questions about childhood vaccines, when it comes to questions about COVID vaccines, when it comes to questions of different demographic groups, different political groups, stories probably need to focus on different elements that are relevant to those communities, whether it's the metaphor of go home and you can be safe at home and be reverent to health information in Navajo Nation, or whether it is, this is not meant for population control. Speaking of the vaccine, like this is meant to help be something to protect your health and to help, keep your community specifically and at large safe, right? And it's meant to keep other people safe, not just you as an individual, but other people in your community safe. I think those community level narratives fit some people to get to understand and better, I guess, resonate with information, as well as there are other populations who really take the more logical approach of, no, give me the stats and give me the information and I want to see the numbers. And we need to be able, as communicators, to appreciate both. If there's a phenomenal way to tie in this logic and this storytelling, more emotionally driven narrative, that'd be excellent. I think we're learning how to do that hopefully better with time. I'm optimistic. But I do think that there's a place for all of these different ways of sharing information, and different types of information will resonate with different people.
Thanks. Lisa?
Yeah, thank you. This connects the last one to this one, which is, I think that there's one way to look at this, which is scientists have information and then the general public doesn't get it. And we have to educate them. And I think that that's really problematic. I think that we need to trust that people have the capacity, and we see it in our research in an ongoing way, to understand that science changes over time. People know that in the very beginning, we didn't know about particulates and masks, and now we know more. And so I think that what is really important, one of my colleagues who's also a medical anthropologist wrote, Dr. Sandhya Ganapati wrote in a really important article that the US has undergone a broad-based reckoning about inequality during COVID. And what that means is that we have looked at the inequalities that have existed for a long time. We've seen the uprising of Black Lives Matter. We've seen the disruption of children being taken at the border and immigration. We've seen all of these different things that are not new, but we've understood that this pandemic has highlighted inequality in a particular way. And one of those inequalities, one of those entangled inequalities, has been the idea that people don't get it, and the idea that some people are disposable. Or in the news, this idea of political leaders at the beginning saying, oh, don't worry, only the immunocompromised and elderly will die. And I think that what we really need, and what all of our data is showing us over this time, is that we need to really focus on this broad-based reckoning through health messaging as well, which means not just saying, oh, people of color are not wanting to get the vaccine because a long time ago something happened, but instead saying we have ongoing medical systems that are racist, that we have racist gaslighting in medical systems. We have ongoing settler colonialism. We have ongoing inequalities that mean some people have access to life and others don't. And how do we address that in our messaging, which is a very different way than saying, how can we package this so that people will listen? And so I think that that is the real nut. That's the deeper level. That's where we need to think for our future. What does pandemic response have to do with white nationalism in the United States? Let's talk about that and xenophobia when we're talking about the next step in pandemic response, instead of how do we come up with a pretty package that people are going to listen to.
Thank you. Yes. All right, Pauline, last word, but quickly, because we want to leave at least time for at least one question. Because
I will try to keep it very, very short. And this is like, again, from the advice sort of point of view, talk to us. I know that it can be scary to talk to the media. I assure you, most reporters want to get it right. We didn't get into this business to spread misinformation or get something wrong or be inaccurate. We need one another. So educate us. We're not just looking for a quote. We want to get it right again. So help educate us, help us understand so that we can help improve that messaging. And then the second thing I would say is this: help the media not just tell the doom and gloom story. All right. I mean, and that's something we really tried to do with our coverage in Indian country in particular. There were a lot of good things happening out there, and the world can learn from stories of solutions. If someone's doing something great, we can learn from that and pass it on. But the doom and gloom stuff also, let's face it, that's a public health issue. That's affecting everyone's mental health. So help us go beyond that and tell the good news stories as well and the solution stories.
Yeah, great. Thank you so much. Okay, Steve, do we have some questions from the online crowd that we might want to incorporate? No? Okay, question in the room. Do we need to get a mic? I think we have our extra mic over here. You're going to be our mic runner?
Yeah.
Our mic
Thank you,
cobbler.
panel, for that very interesting conversation. Having been in this field and having been in communications for a long time, I think one of the issues, because there has always been some level of this discussion about lack of trust in the media, lack of trust in our elected officials, lack of trust in, whatever leaders, in this case, it's public health officials. But it's never the discussion about the other way, which I think is very true. If you're in a relationship with somebody, trust is a two-way street, but we never talk about it as a two-way street here. I do believe that's a real impact here. Having talked with many people in many different places, they feel like they're not trusted as individuals to make decisions for themselves and their families. And it's absolutely, I would say it's undeniably true that there's a lot of disdain that comes out in conversations, maybe conversations, some of what we hear here, but definitely, especially politically driven conversations, there's disdain for a whole group of people, as opposed to trust that people generally want to do the right thing. And I don't see that a lot of times. And so I think that's an area where we can help build trust, is try to make sure that there's that two-way trust, a better trusting of your constituents or your readers or other members of the community. I think it's something that we can all do to improve the trust that we would love people to have in us. Sorry, I meant that as a question, not as a statement. So sorry.
Well, does anyone else have one little last question real quickly? Okay, well, I want to thank again all of our panelists, whether in the room or online, for a productive discussion. We'll continue this throughout the day, and I think we'll have a lot of really important things to discuss during our roundtable workshop portion of the day too as well. So thanks, everyone. Okay, so in the interest, I suppose, of transparency that has come up a lot, I should say that I know all of these people. We are all members of ASU's Disinformation Working Group, which is part of why I thought they would be great panelists for discussing disinformation. So as we did last time, I thought we would just go down the line and have everyone take a few minutes. It's a smaller group, so maybe up to 5 minutes to talk a little bit about who you are, what you do, the kind of work, especially in relation to disinformation, just to kind of set the context for today's conversation. So why don't we start down the end with Lance, who has the mic.
Oh, yeah. I'm Lance Garavi. I'm excuse me, professor of theater in the School of Music, Dance, and Theater at ASU. I'm associate director of ASU's Interplanetary Initiative. What is a theater person doing here? I specialize in collaborations with scientists and engineers, and then several years ago, some research took me into the area of disinformation, misinformation, propaganda, and malign influence. And so I think all of us were part of the Disinformation Working Group even before it turned into what is now called the Center for Narrative Disinformation and Strategic Influence. So that's why I'm here.
We're all old timers.
Yeah, OGs.
OGs.
My name is Christy Roschke. I am the managing director of the News Collab at the Cronkite School of Journalism at ASU. And we are, generally speaking, an initiative that focuses on media literacy. And so I am a media literacy researcher, sort of like by training. I'm a former high school journalism teacher, an English teacher. So I have a former PR practitioner. I have a wide array of experiences that have sort of led me to this place. So though I kind of focus on media literacy and media literacy education, there's obvious overlaps with mis and disinformation, and that conversation has been heated for many years now at this point. And then a lot of the work that I'm doing currently is, with a lot of people in this room, but I am really, a lot of my focus now is sort of on this intersection between information of all sorts, trust, and education. So I'm doing more work in the area of health, but it's not mutually related to health. So,
okay, great. Sean?
Hi, my name is Sean Walker. I'm an assistant professor of social data science in the School of Social and Behavioral Sciences. My background is in information science, so where librarians come from, not IT. And I study online resistance is one of the, and so looking at protests, looking at social movements, looking at elections, and also I see mis and disinformation as resistance to the online information environment. I also do a lot of methodology work. So how do we work with trace data, social media data, other forms of data, and do rigorous quality research, not crappy research, some of which is mine. And also, how do we collect and archive this data so that we can use it in the future? But I also have another odd perspective, is that I'm president of a pet therapy organization in Scottsdale, and we visit seniors in hospitals. Feel free to ask me about my deaf and blind Australian Shepherd, who's a therapy dog. But the point of that is that, thinking about someone that we go in and we visit seniors, we visit hospitals, we keeping those folks safe, right? And fighting maybe, or encouraging, volunteers to wear masks and other kinds of things in the face of this, right? So I bring those multiple perspectives in this discussion.
Okay, great. So again, even though we are all on this same working group, one of the things that I really appreciate about this initiative at ASU is how very interdisciplinary it is, how it brings together people from vastly different backgrounds and methodological literature perspectives to discuss, again, these wicked problems that I mentioned earlier today. So in the context of the working group, we talk a lot about misinformation, disinformation, malinformation, getting granular about definitions as academics do. So I thought for those in the room who are not embedded in this particular world, it might be worth talking a little bit about what are the differences between these things and how did they manifest as part of this pandemic. So anybody who wants to go there, take it away.
Apparently I'm it because I have the microphone. So we can think of misinformation and disinformation. We often look at the intent of the spread, right? So misinformation is probably more unintentional. Disinformation is we know that that's incorrect information and we continue to spread that. And this can change over time. So I can post something knowing that it's false. Christy could trust me, and then that turns into misinformation. But I think in many terms, I would rather look at the impact of the spread versus the intent behind the spread, right? We also can get into information operations, which governments are involved in this, organizations are involved in this. And I think another level we should discuss too and think about is grift. Many people profit from the spread of mis and disinformation, and many politicians profit from that. Many folks that are in the orbit of politicians profit from that to the tunes of tens of millions, if not hundreds of millions of dollars. And so I think it's a really complicated ecosystem within which this operates. And also, mis and disinformation has been a problem since humans have been communicating. So this problem is not going to go away. We are not going to solve this problem, right? But the question is, how do we lessen its impact? And how do we understand why people adopt and propagate mis and disinformation? And I think the answer to that is because they find mis and disinformation valuable. It serves a need. It resonates with a need in their life. And I guess I'll let Christy keep going.
I just would add quickly that, to echo what Sean said, sort of definitionally where we stand, it's sort of as a misinformation research community, is that misinformation is unknowingly or unwittingly sharing false information, whereas disinformation, there's intent. But there is some debate over that. And so as someone who's I think I've kind of come full circle on definitions on this, and maybe this is like a bit of heresy to say, but I think that we need to, we overcorrected on defining things in a way that now it's kind of meaningless, and it was never really meaningful to the general public anyway. And now we call everything misinformation, which I think is problematic because there's a lot of misinformation is misperception, or, it's just a rumor. Are we at the place now where if you hear a rumor, you're like, oh, you're spreading misinformation? And I think we've kind of come to that place. So maybe that's a little soapbox for later, but there are these definitions that exist. I do teach them. I tend to just mostly talk about misinformation. I think where disinformation for me is most helpful is in the operations, like when we're talking about campaigns, when we're talking about bad actors who are using technology to willfully spread false information for political gain or monetary gain. Often those are the same.
I want to pick up something that you said. One of the ways I got into this area of study was doing research into outrage, the phenomena of outrage. And if you think about the way outrage has intersected with COVID, with the pandemic, we see a lot of examples. Outrage over school closures, outrage over mask mandates, outrage over vaccines, outrage over people not masking, and so on. So in my research, one of the things I looked into was the social function of this phenomenon. And one of the things it does is it's constitutive. It forms communities. and subjectivities or identities. It helps them cohere. It polices them, and it serves a kind of maintenance function for this. And I think this is one of the challenges that we have of so far today. I've heard a lot of talk about how do we get the from the science to the messaging to the convincing of the public of the right thing, the correct information. And where I struggle with this is I'm totally in favor of people getting correct information, but too often in these cases we're bringing data to a gunfight, and you don't win that way. And because this isn't a matter of facts and data, this is a matter of this word has cropped up a few times, narrative. It is a matter of communities. It is a matter of subjectivities and identities. And you don't transform those with facts.
Certainly. Yeah, I'll just briefly add that I've mentioned to a few, some of you know that a lot of my own research is about gun culture, and especially mediated gun cultures and gun communities. And one thing I've learned through that work is I was sort of aware of it before anyways, is the power of identity, the power of a social identity, and the markers that define that social identity. And if we think about behaviors related to the pandemic from a social identity perspective, taking it out of, I think we often devolve into a political discourse, and obviously politics are part of it, but it's much more nuanced than that. And it's how people identify, or also just, I show that I am part of this particular community because we all wear masks all the time, everywhere when we're out in public. Or, I mean, I have friends who still don't leave the house, basically, if they can avoid it. I have friends who go out to big parties, and we're all a little bit old for raves, but, you know, whatever the rave equivalent is, who go out quite all the time, and, you know, and everything in between. But they, whatever groups that they are associated with, they have these markers that are still characterizing, I think, their social identities, and that often gets left behind. I think that's a good point.
Can I just add something? We maybe won't answer any of your questions. We'll just keep talking.
Well, I prefer the informal discussion anyway.
But I want to just to what you were saying, and Lance bringing up this idea of facts. And, you know, so I work in a journalism school, and obviously facts are very important, and they're very important to scientists and to our common understanding of things. So I'm not saying that we don't want to pursue facts, but to your point, I just think it's important to also remind ourselves collectively, and this kind of group of people as well, that facts have never been the motivating factor for people. Like, to think that we believed facts before the pandemic and now we've just decided we're not going to believe facts is just factually inaccurate. And you know, and I think about the history of journalism, and sometimes both people within journalism and people who kind of opine for the whatever the golden days of journalism were. Walter Cronkite gets evoked often when we talk about that. There is this idea that people used to just listen to facts from the news, and the news only gave facts, and we were all much better off. And a lot of people have pointed out a bunch of different reasons why that actually has never been the case. And so I think one of the things that will be a useful exercise this afternoon in these conversations is to remember that pretty facts aren't really what we're like, you know, if we like, how does Michael say it? So like the truth value of a piece of information is usually not the most important part. And so all of this identity work, the emotions, the narrative, those things are much more compelling to people. And it's hard for us people who like trade in facts to accept that. But I think like that's why we've been limited in our success to this point, at least in part.
Well, you might say that one of our social markers is this idea that we are about facts. And this is how this is what we tell ourselves.
if I can continue the rogue theme here, I want to talk about dashboards for just a second, briefly. So this is work with a colleague of mine, Michael Simeone. Shameless plug. We also have a podcast called Misinformation Weekly, which, shocker, is not weekly.
Wait, is that misinformation?
Yes, that was a joke just to us. Everyone else doesn't think it's funny, but I want to say first props to public health officials that they spun up dashboards immediately in an environment where they didn't have the resources to do so. They used the tools that were available, and this was a massive effort to share data, which is amazing. That also meant they used the tools that were available. They used Tableau, Microsoft BI. These are tools that are designed for business dashboards, not for public communication and consumption, which then led to this lack of context, right? I mean, this was an amazing thing that happened. Like this data-driven, like we could see and get like a pulse of the pandemic in a specific way. Now that we lost a lot of context within that, like how do we explain these things? Like who knew algebra was going to be super useful in your life? Like algebra teachers and calculus teachers everywhere celebrate, right? But that context, right? Like how do we add context to something that is so complex? How do these dashboards evolve as the data evolve? Like, so one example for the AZDHS dashboard is there was a heat map of the counties, right? But that as COVID numbers increased, the map just turned into like a blob of red. There was no distinction between different areas, so it was no longer helpful, right? Or we would see examples of politicians like Andy Bigg screenshotting the dashboard and then tweeting about it and saying, see, look how the numbers have decreased in the last 24 hours. But then not admitting in the context that it takes about 72 hours for all of those numbers. I mean, like people faxed in data to the state for the data to process. So of course it takes a while, right? But like, how do you explain that in a dashboard? But one of the other things that we lost is that those dashboards weren't able to be archived. So tools like the Internet Archive, tools for journalists, like we can't go back to and look at what did the dashboard look like on this specific day, right? And sometimes when we can do that across the world, right, whenever we do that in like the Internet Archive and their Wayback Machine, the Wayback Machine, if you don't understand how it works, that was like, we want to make a complete web page. So if we take data from different days, different months, different weeks, we don't care. We just want a complete web page. So that we would go back and look at these dashboards, and only a handful of them actually ever replayed. And those that did, you got a graph from 1 month, you got a graph from another week, and that didn't reflect what journalists were reporting. So then that further undermined that as a communication strategy. And in talking to health departments in Colorado and Arizona, they're like, we can't go back and recreate the dashboard. Like we've got some Excel files if you want those, but like we can't recreate that dashboard. So that undermined that sort of communication. And that undermined trust in the institutions that were communicating this in ways that were not intended, right? The intentions were amazing, but then how do we work with that in the face of decades of campaigns to actually undermine these institutions, right? So that context it's not just the context of the data. It's not just, as earlier we said, one of the panelists said, like the data for every county, every city, every state was different. Like, how do we even compare, right? But also that was there were external environments, there were historical contexts that were undermining all of that communication. And lastly, I'll get off my soapbox, is like, how do we meet people where they are? So if we think about public health messaging, which this is not a criticism of y'all, right? But we think about public health messaging, it's some of the most boring communication on the planet, which I understand, right? But let's think about mis and disinformation in TikTok, a short video format that's a testimonial, like you're in church with the camera facing you, that's also communicating music, video, facial expressions, and it's being banned, which I understand, but also like now public health officials, they're not using the norms of the platform to communicate with those communities, so they're not communicating, right? We had doctors pop up to do that, right? But the like official channels of communication are stuck in like press release stage, not in like TikTok, Facebook, God forbid, Parler, right? Like alt-right platforms, Gab, right? And so like, how do we combine these things together to meet people where they are, to communicate with them in the ways that they're communicating as a community? How do we show up for that online and physically?
I want to try to, Christy, I think you're the one that said we've always had misinformation, and that's absolutely a fact. but I think we're in a different situation than we were a decade or so ago. And I think it's one of the things that makes this an even more wicked problem than it was, or that I think we've addressed here. So one of the challenges that we have is deep structural of our communication environment. And what I mean by that is that something that's known, a term that is probably familiar to many of you, as an attention economy. That the structure I'm talking about is physical and economic. We all have these gorgeous and wonderful machines, and we have Google, and we have TikTok and Facebook and Twitter, and all of these are free, right? Well,
for some definitions of free, yes.
Yeah. It's free because we're the product, not the consumer. And what the economic model is based on is advertising. It's trying to get our eyeballs and our attention. Now, what drives attention on the internet? It isn't data. It isn't facts. It's emotion. Particularly appeals to moral emotion. This is, where I pull from my outrage research. If you have a story or you create a post that is emotional, has an emotional impact, especially to moral emotions, not only does that, as I said earlier, produce subjectivities, produce communities, but it spreads much, much, much faster than data or factual information. And this sort of economic model that has arisen just in the last 20 years, the economic model of our narrative and information ecosystem, is baked into it. And it pushes us in certain directions and makes the solving of the wicked problem much, much, much harder. I don't have a solution.
If you did, you'd probably
except
be in
like
a different
the
room.
overthrow of surveillance capitalism, but I just want to try to give the sort of structural picture that I think's going on here.
Well, and I think, yes, when you say that it's baked in, the most, I guess, obvious example that comes to mind is, the algorithm, which has become a term about algorithms for various things, but I was thinking specifically of YouTube, right? And I don't know if they have corrected for this a little bit, but I know that a few years ago, if you started, looking for baking tips, you would end up in some kind of a radicalization effort. If you just kept watching whatever the recommended videos were, all roads led to increased outrage, right? No matter how banal the starting point. The idea was that to keep you watching, to have you stay on longer for the economic model, it was to keep that temperature gauge rising, right? And of course, that has big implications for something like if we're talking about mis and disinformation. I'm going to keep doing that just to not conflate for those who do like the distinction. And we know that, for example, this is kind of a segue, that YouTube has been a huge vector for bad information by people. I did a study with a graduate student. It was a global study trying to understand like where people got their information about the pandemic in mostly developing, but a lot of countries all over the world. And especially with regards to conspiracy theories about Bill Gates and or the vaccine, etc. And or the vaccine, YouTube came up over and over again. Oh, there's this doctor on YouTube that my mom was to, or she's always sharing these posts on WhatsApp, and this was a big vector. So
I just want to add the algorithm, but also put out there like what are some of the primary vectors for mis and disinformation based on the work that you have all done, especially, but maybe not limited, but especially given the room related to COVID and the pandemic in general. Like, where's the bad information coming from? Inside the house.
So many places.
Both inside and
right. Right. I think that's true. And a lot of bad information came from powerful people, elites within the healthcare community, within the political realm. And that continues today. And so I'm working on some research right now that's about trust, and we are not exclusively asking people about COVID, but that is coming up. And this research, and we are doing some qualitative interviews with the general public, pretty representative sample, journalists and medical doctors. And our goal is to try to tease out some relationships and trust, how trust is created, how it is lost, how people are defining trust, who they trust, who they don't, that sort of thing. And we're looking to see if there are any similarities between these two institutions. Our hope is to interview people from other institutions like government, business, NGOs, democratic institutions along the way. And it's just really interesting now. And again, we keep saying like, we're at the lessons learned phase, even though the pandemic isn't really over, but we definitely know a lot more. But it's been very interesting to hear people talk about what they think happened. And it is wild, man, how different the answers are. And, some people think that the government completely misled us about everything related to COVID. And their justification for that is because they're still standing. And everyone around them, for the most part, is still standing. But maybe some of their businesses in their community are not still standing, or maybe they've lost their job, or there's some other impacts that they've felt. And now they feel like they've been wronged across the board. And this is not a representative answer, but just as an example. So I guess to answer your question, in some cases, like what I'm learning now, is almost it doesn't even matter where they're getting this information, because now we've reached the point where people have settled on their ideas about what happened specific to the pandemic. But I think you can probably apply this to other things that happen in society. And they have come to their own conclusions, some good, some otherwise, and that's it, right? And so these are not necessarily intractable ideas or intractable problems, but it is really important to realize that like now people are not interested in like preventative message. Like, I don't think this is the time for preventative, messaging. Honestly, I think people are like, I'm done. I am alive. Maybe I got vaccinated. There's a lot of people we interviewed who got, and this came out in the work that Alexis and I did too, who got the first vaccine and kind of felt maybe like they were duped into it, and then didn't get the second of the two shots, or maybe is not getting boosted because now their relationship with the vaccine has changed. So there's a lot of people just arriving at conclusions that aren't related to like any specific messages, right? So I don't know. It's really interesting.
Sure. I want to come back to a theme I've heard a lot today, and that's trust. Love it. Big fan of trust. The one of the challenges is there are players in the information space who don't love trust, who want to actively work against trust. As Dawn suggested, some of this group are just grifters, and we see those in the media, we see those among politicians that want to create us and them, that want to fracture any social cohesion communities might have. But there's another group of practice what we call malign influence, and these can be other nations. So, in the sort of classic example of this is the Russian operation in 2016, especially around the U.S. presidential election, and the the purpose of the campaign wasn't to make Americans believe one thing or the other. They don't care what the Americans believe. The strategy was to and they did this really, really well, to spot the existing fractures in our social fabric and apply pressure to them so that they would fracture further. Fractures around race, fractures. They were actively seeking to create distrust of in communities of the government, of politicians, of the other party, of other communities, and I think one thing that a lot of people don't understand about malign influence and disinformation is you think, well, I am media literate. I am an intelligent person. I would never fall for that. The thing is, the strategy isn't mostly about making you believe something you don't already believe. It is to affirm the things that you already believe, make you believe them stronger, make you identify with them more strongly. If you're a mask embracer, for example, it is to get you to embrace that even more fully and be suspicious of those who don't. I worry that I am just giving all kinds of reasons why this is such a hard problem. I'm fun at parties.
Nobody is here. I don't think
You are
I mean,
the fun
I
at
hope
parties.
nobody is expecting us to just come up here and say, we have solutions. We have solved disinformation in this room. So I don't think that's a problem.
I think Sean can speak about. I'm going to tell Sean to say something here in just 1 second. But to Lance's point, at least in part, we are not doing our jobs if we walk away from this event thinking this is an individual problem, because we are all, and someone said it at some point. Oh, I think it was in the last panel. Most people can handle information just fine. Most people have the cognitive capacity to understand what you're telling them. This is not the problem of individuals being vulnerable to certain, to being duped, right? To being fooled. These are fundamentally flawed structures of our society that are being surfaced again and again, that are, there's so many contextual factors that lead to us accepting some information over others. And this is where I'm going to turn over to Sean, because he's real good to talk about this.
What am I supposed to say?
About why people find certain information useful.
So this is work that in collaboration with Christy and our colleague Michael Simeone that we've been looking at, instead of thinking about this as individual, right? We see these like epidemiological metaphors of infection, right? Like, so we're exposing you to misinformation, and because you were exposed to it, now you're infected, and then you take it to your communities and infect them. And that, again, as Christy was saying, that focuses on like the shortcomings of the individual. Like, that's my problem, right? Because I have some failing, I'm stupid, I'm not trained, I'm not media literate. But then, we think about media literacy training is important, but also it's hard, right? Like, if you just follow these 8 steps with every piece of information, that was our first podcast episode. And, this is hard. Like, mis and disinformation is designed to piggyback on top of that training that you have to make you believe it. Right. And that's not just a Russian information operation or CIA information operations, right? Like, that's run of the mill, everyday mis and disinformation, right? We can easily create 15 websites that look like legitimate news sites, have stories that look very similar, but not exactly enough. So, like, are there multiple sources? Does it look like it was made with a crayon? And then we delete that within about 72 hours. And now we can't reference that again. Now that's caused chaos. We can't have a discussion about it. But this is hard. This is hard. Professors can't do it, right? Not that we're the echelon of anything, but journalists have a hard time doing this. Like, everyone has a hard time. And I think, so if we go back to, we kind of step outside of those metaphors, and then we think about, like, why do people adopt mis and disinformation? Why do people adopt any information and propagate it? We can think of this like complex system that you have that you kind of work through every time you're exposed to a piece of information, whether it's true, right? which that's a different that's a different panel, but like whether, or mis and disinformation, right? Like we go through and that affects our system, that changes in small ways or maybe in major ways, kind of reconfigures that kind of matrix that we use to make that determination. And so then we think about like, well, this might be a marker of, as Don said, this might be a marker of my position in a community, right? I'm an anti-vaxxer because that's part of my community. So if I get the vaccine, right, let's like think about children of parents who are anti-vaxxers, the amount of courage it takes for them to go get vaccinated and their parents are like, what's wrong with you, right? And so that's a marker of being part of their community, but they're turning their back on that. It might be that there's a distrust because of the medical community has treated my community for X number, right? So we can think about like HIV and AIDS. We can also think about this in the context of monkeypox, right? Like LGBTQ folks were treated like the beginning of the HIV epidemic, right? They could not go into a doctor's office because people would not want to touch them because they didn't understand monkeypox, right? So you can understand why that community might be reticent, but also the LGBTQ folks are like, we all want vaccinated like en masse, right? So we can think about why people might do that, but also every time we're exposed to information, that's going to change how we react to that in big ways. So we can go back to the example of the lab leak theory for COVID. That Trump said that initially, folks that were heavily anti-Trump, that reconfigured their system to be like, nah, I'm never going to believe that. That can't possibly be legitimate. On the other side, we're kind of doing a little hyperbole here just for the example. Those folks that believe Trump and think that like they're fans, right? They're like, truth. That came from God, truth. Then they're not going to believe any other possibility, right? Or it's going to be very difficult to reconfigure that system. But if we dive into that, we have markers of community. We have markers of like parents might want to believe that vaccines aren't important and COVID isn't important because then that makes you feel safe, right? For so long, we're like, just keep your kids at home so they won't die. That's hard for parents. I don't have kids. I have dogs. I can't imagine, right? And so the other thing we should also consider is the new relationships that were formed, right? The anti-vaxxer parents are now aligned and friends with the militias, right? And so that new relationship is formed. If you look at some of the work that we've done with the Bridging Divides Initiative at Princeton, we've done with New America around Parler and the role of that in January 6th, like we can see it in protest activity. People in Texas were protesting COVID lockdowns because they were hearing it on the news from New York and they were like, oh, well, that's going to happen here. That did not happen here. That was not going to happen there, right? But they're seeing these national conditions or conditions in other states as local conditions and a local threat. And so that's reconfiguring that relationship. Folks that never had protested before or had never protested together are now best friends. Right. And so now there's a process of radicalization. There's a process like these folks that weren't in conspiracy theory communities before are now in conspiracy theory communities now. Right. Like you might laugh about like lizard people as a conspiracy theory, but like these are the groups that they're embedded in. And there's a process of radicalization akin almost to what Al Qaeda and other groups use. There's a process of radicalization and that doesn't happen like in public. It's like, hey, are you concerned about illegal immigrants bringing COVID across the border? And somebody might be like, yeah, come join our private Telegram group, right? And then in the private Telegram group, something else happens, right? That then leads to this process of radicalization. And so we have to take a lot of those factors into account. Like this is complicated, and communicating with someone of like with a tweet from the CDC or your local health department doesn't cut it in this, or thinking like this person is stupid because they've been radicalized. No, there's a really complex process that's happening here that's about the society, about our institutions, about structure. And this is not a 5-minute conversation. This is a multi-year process of how do we reinvigorate trust in our institutions? How do our institutions admit whenever they've made mistakes? How do we talk about science, increase science literacy? But not just that, how does science say, this is what we knew yesterday? What we know today is better. And what I told you yesterday about masks was not right. And now we have better correction, but that doesn't mean you should trust us. That means we're working pretty darn hard to figure that out. So how do we communicate that in ways that instill trust and honesty versus just kind of radicalization?
Okay, just really quick. You just reminded me of something. Also, I just want to say the two of you at a party would be huge laughs. Like all this great information. So happy. So you mentioned correcting information. So I just worked with some researchers at Dartmouth, and we just published a paper just last week it's related to journalists making corrections, but there is definitely lessons to be learned for everyone in this room. And it's not great news that we found in this experiment that we ran. And the short of it is, and I'll be glad to share a link to the paper, but is that when a news organization corrects a piece of information, there are statistically significant gains in people getting that new information. So that's great. A person can update what they know about a situation after it's been corrected. So that's really great. That means we need to keep correcting what people know about things because they do take that correction. Like there's been this debate over whether or not people, it's like primacy recency. There's other kinds of theories that suggest that once somebody thinks something, they cannot correct their belief about that. Well, that's not necessarily true. We found in this research. However, we also found that when a news organization corrects a piece of information, it statistically significantly decreases the level of trust in that news organization. So you have a dilemma as a provider of information. Do you want someone to have the correct information at the risk that they will no longer trust you? Now, all kinds of limitations to this study. It's an experiment. We don't know how long those trust decreases or those knowledge increases last, right? Because it wasn't a longitudinal study. But that's a really important conversation to be having. And we did it in the context of like, what do news organizations need to think about when they're correcting information? But now that you said that, it makes me think this is also true for public health and, public health and professionals, medical doctors, anyone who's in a position to say, please do this. Here's the thing you should know. Oh, wait a second. Maybe not that, but this, right? So this is also another thing we could talk about that would be great.
I just want to add some sunshine and rainbows to this.
You're known for that.
There's when you research disinformation, there's a lot of things that keep you up at night. But I like one of the really big things, and it hasn't come up at all in our discussions today, and I'm surprised. It's an area that I've been working in for a few years, and that's artificial intelligence. The new capabilities in AI, specifically in generative AI, that have arisen in the past two and a half years since GPT-3 came out, and we're now at ChatGPT and now GPT-4 and all the other similar large language models, can wildly scale up the disinformation and online influence problems. Yeah, no, I lied. That was disinformation. Yeah. The thing is, with the malign influence operation like the Russian operation in 2016, for example, or any number of, whether they're grifters or foreign operators, there's still like humans behind most of the production of that content. Now we don't need the humans to make the stuff. Now we can have tireless machines cranking out content that's frankly probably going to be better than the content that the humans crank out, because the generative AI doesn't have knows perfect English, unlike many of the folks that were working in the what's the name of it? Internet Research Agency in Russia. One of the things that I think we've all been anticipating is an explosion, a like hockey stick kind of graph. And this, along with deep fakes and the generative AI part of being able to produce realistic looking images and very soon even video, things are just going to get weirder.
things are going to get weirder. There's our takeaway. I just wanted to kind of sum up some of this that we're saying is that, and why I brought up the idea of wicked problems this morning is that aside from the fact that we're in, regardless of when this happened, a pandemic is always going to have social, political, economic dimensions. But now we are living in a particular social, technical context that does make for the spread of information. It makes it so that we have the tools to create these dashboards on the fly to get information out there. But we also have these other tools that do things. And of course, we also know that generative AI has some positive effects. So it's not like, let's just ban generative AI.
No, absolutely.
It's as ridiculous as the idea of banning TikTok, but that's another conversation. So, you know, as we're moving forward, none of that is going away. Regardless of whether TikTok specifically gets banned, if it's other things will be there coming up. You know, we're in a world where we're used to being able to interact, communicate with people 24/7 all over the world, live and otherwise, so both synchronously and asynchronously, and that is necessarily going to have to be taken into consideration when we think about the next pandemic, the next situation that arises, and also knowing that everything that happened, good or bad, everything that we did well and not so well during COVID is going to come back into play because people are going to remember that. Like my professional background before I turned to the dark side of academia was in crisis management, and even then, it was like crises never totally die, because even if you think you've handled it in the moment, if there's any kind of coverage or actual, you know, public discourse about it, if something sort of kind of related happens later, people will put, there will be a sidebar in the article, or will come and say, oh, this is similar to that thing 5 years ago, and it has a rebirth, right? It's kind of a zombie. And so this COVID pandemic, regardless of the epidemiological aspects of how it plays out, from a social and cultural perspective, is a zombie. It's going to keep coming back with the other ones, with, you know, new and improved tools, right? So does anybody have any advice for people? Yay. Like what are some things that we can think about that we can actually do?
So I'll add like a rainbow on generative AI.
An actual
a real rainbow, right?
Okay.
So there are ways to think about this, right? So as an information scientist, right, like think about and work in web archiving, like what data are what are the origins of the data that we train these models on? Like if you want to nerd about models, and we can talk about like word vectors and those kind of different like bag of word models and how these are created, I'm happy to nerd out. But if we think about, Katie Pine and I are kind of starting to work on a project about how do we create more fair, more representative data sets to train machine learning models? So we can think of what role does public health professionals, does the research communities, does the public have in helping these companies understand like what data it's trained on. Right now, the vast majority of these models are trained on something called Common Crawl, which is one of the largest crawls of the web, the open web. So think about what's on the internet. Conspiracy, porn, other types of data, right? But we can think of like, what is the meaning of that, and how do we create better data sets to train these models that take into account public health, that take into account minorities, right? And some of these we do branches, right? Where like right now, if you ask ChatGPT about trans people, it's got a really nice answer, but that answer was hand curated by someone, right? So we kind of think about some of those hand curation, but we also think about like, what data do we need to add to these training sets to make these models better so that we get less toxic responses?
That's lovely. Also, I think that's a good opportunity for people, because this might feel really out of your wheelhouse, and understandably so, but like conversations with companies like OpenAI who are developing these models, like I think they need to hear from people like you so they can understand what is available in terms of public data sets, or maybe even not public data sets that you would have that would help inform these models to make them more representative, equitable, factual, all of those good things. My rainbow is going to be, or my, what was it, recommendation? So we heard a lot today about interventions and things we learned big and small, right? And even though the socio-technical piece is global in scale, and all of the things everyone said are really true about how fast things move and how like damaging disinformation can be once it gets out there. All of those things are true. However, there's also truth in the benefits of localizing information. And so like you mentioned shoe leather epidemiology, shoe leather reporting is a phrase that's popular in journalism. We heard about the positive impact of local news. And the need for multiple messages. It might seem strange to try to fight a global, like super fast, lightning fast internet of social platforms that we can't compete with them. And we shouldn't try. But something else we're learning in our research is that even though people kind of have come to their own conclusions about the pandemic through a variety of means, most of them are saying when they have interactions with their healthcare providers, they are positive. Even when they've had bad experiences, they still trust, to use that word without a big definition, they still will go and seek out information from these people because they need to, right? You're the experts. And so that combination of expertise and local engagement, and President Nez talked about that really nicely in terms of what happened on the Navajo Nation, and different from what happened in the US as a whole, right? Took lessons from their own community to help their own community. And it necessarily was different from what we did as a country. And I think there's a lot to be learned about that because the national response was not great. Well, no. There were plenty of successes for sure. But like when you hear the national narrative, your perception of that is that it wasn't great. But when you talk about your town or even just your interaction with your doctor, more people are likely to say that was great. And I think that is a really, really important piece of this. So we might be fighting like online wars with like talking to your neighbor. That's really like quaint and cliche, but maybe that will help. Now here's Mr. Rainbow.
Yeah. Advice isn't really my bailiwick. But let me give it a shot. Let me pull from my theater background and foreground. That's what I'm a theater professor. Rehearse this. Rehearse the next pandemic and make communication and part of that, and red team, blue team it, so that you're aware of the specific challenges and the future challenges of communication here. There's a really telling lesson from the area of disinformation studies. So what was it, a year and a half ago when the federal government tried to put together an office of that was okay last summer, yeah, an office of misinformation. Look up the it was basically a government office to handle disinformation, to deal with disinformation, and the person appointed to head this, Nina Jankowicz, really respected researcher in this area, and it's the what? Disinformation Governance Board. Okay, so this thing, they rolled it out, and immediately it was attacked by partisan players, by the grifters, by conspiracy theories that this was going to be some, Gestapo of thought, and there was this wave of social media posts and protests about this, completely misunderstanding and mischaracterizing this. And they had no communication strategy to deal with this.
Yes, this hurts my heart.
So the whole thing in like 2 weeks, or maybe less, got rolled up.
Yep.
It got shut down. And so they just didn't, like, they fell victim to their own expertise or what should have been their own expertise. The punchline to this. Do you know what Nina Jankowicz's most recent book is called? Like, she put this out before she took this position.
Oh, no.
It's called How to Lose an Information War. She wrote the book on it and then lived it. But I think it's because they didn't play out what this launch was going to be like. They didn't prepare for what was obviously going to happen.
Yeah. Well, and my background in crisis management, bringing that to the foreground, says the same thing, that rehearsing, simulating, it's time consuming, it can be expensive, it can be complex logistically, but the price of not doing that is potentially very high. And so I think we have a lot of tools. And as somebody, maybe Matt this morning, said that an important thing was also to bring more people to the table than had been involved. And again, even though that becomes logistically complicated to organize, doing some kind of a simulation before it's necessary can really help avoid some of those potential issues. We have a few minutes for questions. Steve, there's somebody online with a question? Do you want to just say over the phone, ask Bob to unmute, maybe ask? Or I'll read it. I think you need what's the easiest way to do it? Oh, okay.
I could have gone over there. All right, so the question from Bob online is there a multi-level model for effective influence or communication on a critical issue that successfully addresses the issues of the ineffectiveness of the, quote, one-size-fits-all approach versus the need for absolutely individualized communication, one-on-one?
I mean, that's a great question. I think that's what we're all striving for. So, I mean, I don't think like a template exists necessarily, but the point of it needing to be multi-level, multi-constituent, multi-modal, a lot of multis in that is probably like how it has to be. And in that vein of rehearsing, like, I think a good communication strategy for different organizations is to think about who are all the people we would need to message to, where do we reach them, and then kind of build out some thoughts around that even before you know what you're going to be messaging. But yeah, I mean, if we could build that template, that would be amazing. Oh, she has a template.
I don't have a template. I'm not gatekeeping this magical template. I just want to make that clear. But there are actually a couple of different models in the strategic communication literature that specifically map out, by necessity, they are generic because they are models to be adapted to any specific situation. So it's a broader framework, but that look at especially different tiers of communication, how they're needed. So, from the interpersonal group and then moving out in a series of concentric circles and the differentiating the needs from those who are maybe directly affected by a specific event. And then there's more complex models that take those into account and the interplay with media and social media. So yes, there are many strategic communication scholars who are working on a variety of models for different types of situations. And I think that one of the many places where this, the disconnect between academic research and practitioners of various types really breaks down is in this sort of thing, is that there are vast literatures about how to handle this. But of course, nobody in the moment when there is a public health crisis, the people who are at these state agencies are not saying, hold on, let me get some strategic communication researchers on the phone and see what models they might have. That's just not how it happens. So those are the kinds of things that, again, building the relationships, having more broad-based versus siloed disciplinary conversations can help prepare the terrain so that we're ready, I think, in the future. Any questions in the room for our panelists?
So this is So this is kind of referring back to one of the earlier comments. I love the discussion about outrage. And I wonder, so how can we use lessons from people spreading misinformation that evoke emotional responses and moral outrage? How can we use these lessons that are so effective in spreading disinformation to potentially spreading good information?
I will only use my powers for good. Is that what you're getting at? I can change her. Yeah.
Can't wait for lunch.
I can. I don't know.
Okay, so my response to that would be one of the things that the work that I've been doing with Michael Simeone and Christy is that we focus on tactics, right? So let's break down what tactics are used. And some of these tactics are like old, and like we can go back to storytelling, we go back to like friendship connections, network theory, other kinds of things, right? But I think an important component that's often missing is let's break this down. Like one of my favorite examples is Paw Patrol. There's misinformation about Paw Patrol, that Paw Patrol was going to get canceled because it, euthanized Chase the police dog, because Chase was, doesn't represent the lived experience of minorities. It's basically like white suburban folks are like, oh, police officers are our friend, but like someone in, yes. And so this turned into this whole thing of, especially within, the Washington Examiner and Fox News and other folks. And it ended with Donald Trump Jr. tweeting out this amazing picture of Nancy Pelosi as Cruella DeVille holding Chase the police dog. But which is my favorite meme ever, but and I'm not trying to politicize, it's just, if you look at where did that come from? And how did that circulate within specific communities? And how was that energized, right? My grandparents watch Paw Patrol with their grandkids. And they're like, Paw Patrol's going to get canceled? And they're like, outraged. Like, talk about moral outrage. Don't mess with my grandkids, right? And so if we think about that from a tactic perspective, right, we can then understand, well, how did this work? And how can we not necessarily do those same tactics, right? But at what points do we have interventions when X tactic is used, when Y tactic is used? How do we detect it as it's happening versus now we detect it after it's already happened, and it's so deep and it's already spread that we're just it's too late, right? It's far gone. So I think oftentimes discussing tactics, methods, and breaking those down to understand, well, some of those tactics are really useful communication tools for public health, for educators, for everyone, but also where is our playbook about this tactic is used, here's an intervention in any space. We don't have that playbook, and we should build that playbook.
Let me just say one sentence. Because I talk about outrage as, honestly, where I get this is from Durkheim's theories of religion. I talk about outrage functioning like a religion, and that it's formative of communities. So the way to use some of this for good is build better communities. Build communities that are based on better foundations.
And you mentioned that with Reddit, right? Not to say that Reddit is a good community, that's not what you're talking about, but there are some subreddits subreddits are built with community moderators, and depending, some of them have really good things, really great tactics that we could take and model or emulate to do better. But one thing I do want to point out, and this is a tricky part of it, is that to have outrage is definitive. It's like slamming on the table. That's outrage. And you are certain. And a lot of what we talked about today is how we can't, we shouldn't have been so certain. And when you are a person of authority, to assert yourself in that way could come back to hurt you. And so that's one reason why outrage, when you're trying to present facts, is hard, because we have to be malleable. One of the things I feel I took away from today, which I was reminded of again and again, is that we have to be malleable enough to say, no masks today, but masks tomorrow. And to be able for us to understand why that is. And you can't do that with outrage, because that's exclamation points and full stops. So I don't know if there ever is going to be a direct comparison, but certainly in terms of engagement, there's things we could learn.
Yeah, and just to conclude, I think there's some really good research by Zizi Papakarisi about affective publics and the way that publics form, especially in this social technical context that we have now, around not just facts or not just particular issues, but there is an affective tie. And whether it's outrage or some other type of emotional connection, that is what pulls people together more than, again, the facts. This is coming up over and over again. And I think there, back to a point that Sean mentioned, one of the tactics that is effective is storytelling. And I think President Nez illustrated this very well when he talked about how a cultural story that is within a particular community that is also an affective public of sorts was able to turn to this story, or the people who were trying to communicate and to induce particular behaviors were able to draw on that story and leverage its emotional ties, its cultural ties to evoke, the types of behavior they wanted. And I think that there are opportunities for us to tell, not just have better communities, but also tell better stories. So I think we'll end on that note. So I'm just going to have each of those present introduce them. So we'll start with Matt.
All right. Well, good afternoon, the post-lunch crowd and those of you online. And so, as I introduced myself earlier, really in the terms of policy is helping to guide policy decisions from the information and the scientific point of view. How does the information that we're learning, how does that translate to policy? And as we've talked about so far today and talked about throughout this pandemic, it's a spectrum. There's no real black and white. You're not going to please everybody. You're barely even going to please 25% of people altogether when it comes to policy and translating what we've learned. But so that was really the role that I played, was trying to deliver good evidence-based decisions. And from some of the communication panels that we had, we of course saw that wasn't, or heard that wasn't the easiest thing to do. But trying our best, and in public health, that's making evidence-based decisions is really one of the main things we try to do, especially in working to build trust, as we've heard that talked about too. Very, very difficult. But so I worked at the county health department it was about 14 years overall. Worked in environmental health for quite a while. Popular person there, inspecting restaurants and going into places. And it's that risk assessment though. So my background in biology, microbiology in particular, is really understanding organisms, bacteria, viruses, how they grow, how they affect humans, transmission patterns and pathways, and being able to put that in the context of where does our risk lie? What do we do on a day-to-day basis that puts us at risk for disease transmission, and really trying to deliver that information out to not only the public, but our community leaders. And then now, since I got completely burned out in public health practice, from going through a pandemic like that, now teaching at NAU and getting to inspire that next generation is great, and really have a lot of real world experience to deliver to, here's why you're learning this. Here's why I'm telling you about this particular virus, or, going through the information that is being learned. Here's how it applies in practice. And so, the main thing I like to push when it comes to policy is the goal in making those evidence-based decisions and evidence-based practice.
Great, thank you. And President Nez, go ahead. We're just doing introductions now. So for anyone who wasn't around this morning, if you wouldn't mind introducing yourself again and just talking a little bit about your relationship to COVID and policy for a couple minutes.
Okay. Well, thank you. And good afternoon. I had to take my son home real quick and pick up my wife here, Cecilia, former First Lady of the Navajo Nation, Cecilia Nez. joining me this afternoon. Maybe if she wants to join me up here, she might have some insight too, because she lived right through the pandemic with me. You know, some of the things that I'm sure a lot of you gone through at home, where I even, you know, there was so much we didn't know about the pandemic early on, right? So at one point we were living with a plastic sheet half the house because I was out there every day. You know, and I felt, since we were talking about trust this morning, you know, one of the things that I thought was important was to have the Navajo people see their leader out there on the front lines during the pandemic. And I thought that was very important. And so every single day I would leave the house and hand out food, supplies, and every day, 5 communities at the time. And the reason why I say this is one of the first public speaking engagements I've had since I left office. And over lunch, I was talking to Steve and Matt about the mental health, I guess, post-COVID-19 that we really needed to talk about. Matt mentioned burnout. You know, many of you have just been going on, keeping on going all the way through. You haven't really had a debrief or talked to people about what we went through. And so this is a healing for me as well, being able to talk about what we went through as a nation. You know, if I want to do something maybe different than I did during my tenure, this is a great opportunity to do so because of all those lessons learned. But I think I've gone through much throughout this pandemic, and even our children. We were talking about our children at home, you know, what they went through as well, and to better prepare ourselves for incidents like a pandemic or any type of an emergency. You know, a couple of days ago, we got our vaccines for COVID. I think I'm at number 5 now. I don't know what number we're at right now, but you know, it was important that leaders walk the talk. And so I would get my shots on film and let the Navajo people know if I'm encouraging you to get a shot, your leader is getting a shot as well. And I think some of us I heard this morning, not everybody's fully vaccinated, but the threat is still here. COVID-19 is still here. But I'm Jonathan Nez, former president of the Navajo Nation. And as they say, life goes full circle. I met my wife here at NAU. We went to public service almost 20 years, and we're back here in Flagstaff. So, and I grew up as a sheep herder, you know, early in life, when I was a child. So I don't know if I'll go back to sheep herding pretty soon. So
that's the next
thank
circle. I really appreciate, President, is also that reminder that policy is about people, ultimately, that it's not just, I think, an abstract or something that stays at a level, but it does have actual impact on people. So that's a good reminder. Okay, last but not least, Dr. Amish Shah is on Zoom, joining us from Houston, correct?
Yes, Houston, Texas. Can you hear me?
Yes.
Okay, fantastic. Yeah, I'm sorry I couldn't be there in person today. I apologize. I had another event to attend. But my name is Amish Shah. I am an emergency physician. I have been practicing medicine for about 20 years now, including residency. I did my emergency medicine training out in Lincoln Hospital in the South Bronx. It's New York City's #1 highest volume trauma center, level 1 trauma center. After that, I was a physician, faculty member at the Mount Sinai School of Medicine on the Upper East Side of Manhattan, and then worked for a little while doing sports medicine with the New York Jets, and made my way here to Arizona, where I completed a sports medicine fellowship at the University of Arizona in Tucson. And after that, was practicing medicine all throughout the state, rural communities and far-flung places, as well as Phoenix and Tucson. And I also have a master's in public health from the University of California, Berkeley, that I got just after medical school. And so this was, I felt as though of all the people in the legislature, I sort of was on the front line. So I also am a member of the Arizona House of Representatives. I have been serving since 2019, and my second year was the year that the pandemic hit. And so it certainly was an experience there in that I was in the nexus of both serving on the front lines and in the legislature and watching the policy happen at the exact same time. So that was my experience. I'm still in. This is my third term, or my third term or my fifth session, and we're currently still in session in the legislature. And so that's a little bit about me. And I have been listening to some of the panel discussions here, and they've been really enjoyable and instructive. So I appreciate the invitation, and thank you for having me. I do remember one in particular that I have to mention, and that is a prior speaker said that scientists are really bad at humility, but politicians are absolutely the worst at humility, which means I guess I am totally out of luck on this one. Yeah, must be the worst guy in the state, I guess.
Well, thank you for joining us, worst guy in the stage. Somebody, I guess, has to fill that role. But I mean, everybody's got a brand, I guess. So that's a good segue, I think, into my first question, which is a doozy, and it may end up being the only question. I don't know. A lot of these are very big. I didn't want to run out, but I don't know if we'll get to all of them. But I want to talk about, from a policy perspective and your different angles looking at that, what that means. What would you describe as the most significant challenges about making and enacting policy during the pandemic? Whoever wants to start can start.
I can start. Probably the worst person in Indian country. Worst politician.
Now it's a race to the bottom for everyone.
All right. So, as a sovereign nation, 500 plus tribes throughout the country, every tribe is distinct and they have the ability to govern themselves. So we have our own laws. And so it's just like possibly governing another small country, right? And so we were able to put in protocols in place on the Navajo Nation. Of course, you put these protocols in place. It's sometimes it's not popular, and then you have to manage multi-jurisdictions. You got state, and for Navajo, we're in 4 states, actually, four corner states, and then you have the counties. And of course, you have the federal agency districts as well. They're not all covering the whole entire Navajo Nation. Sometimes, for instance, the EPA Region 9 on one side, and then the New Mexico side as a different region. So we have to, maneuver through all these different jurisdictions. And so what. Early on, what I did was I surrounded myself with professionals such as yourselves, scientists, public health professionals, and even before the pandemic hit Navajo, when the first case was up in the northwest part of the country, we developed our preparedness team, and getting that message out to the people, said this might be coming, get prepared. And I think we did pretty good. I think if we were a state, we would have probably been the 48th or the 49th state to get a COVID positive case. I think all the states around us had a positive case before we did. But once it got in, as we know now, it spread. And it took advantage, COVID-19 took advantage of our strengths. One of the strengths is, we like to be in have multi-generations living under one roof. That's how we are. But once one person comes home, boom, it spread. And that's what I was saying earlier this morning. We had, because of the high unemployment rate, people have to leave the nation to go to work, or off the nation. And so they come home, and some of those individuals come home with the virus. And that was pretty difficult at one point. How do you do this? How do you manage this? If you have half of your people living off the Navajo Nation, making ends meet for the families that are living on the Navajo Nation. And you don't want to just say, hey, you can't come home. But we did lock down the nation because we were able to create our own laws. And as big as the Navajo Nation is, 27,000 square miles, with the limited police officers, we weren't able to cover all the grounds. And I tease my citizens, I said, I know you all know every back road in and out of the Navajo Nation. So there were people going in and out of the nation. But a lot of it was just doing these roadblocks, not just doing roadblocks and telling people to go, but giving out information, giving out hand sanitizers, masks at the same time. And we could do that on the Navajo Nation because we were able to do our own laws. And of course, we did the mask mandate. I think it just got lifted by the new administration that came in. But I think what I hear is a lot of communities have decided to keep the mask mandates in place on their own throughout the Navajo Nation. So it's quite funny. If you go to Flagstaff here, you go to Walmart, you can pinpoint who a Navajo is because they'll be wearing their mask, right? And that took a lot of education. And, there was a comment earlier today, about infringing on the person's individual right and their what they know, what is better for themselves. But of course, we didn't know what COVID-19 was about, right? So we had to get that information down to our people because the people didn't know what COVID-19 was all about. And so sometimes, and I'm speaking as a government official, sometimes you have to make those tough decisions for the betterment of the whole because they delegate that responsibility on you through a vote. And you get that help from the people surrounding you. And Matt was one of those, Del Yazzie, Dr. Jill Jim, Rosin So, just many people. And at the end of the day, I had to make that decision. And, I think the majority of the people who live on the Navajo Nation respected that. It's just the mixed messaging that those that lived off the Navajo Nation had, because nothing was consistent throughout this country, as you know. Mask mandate one day, we'll lift it another day, let's put it back on. Navajo stayed consistent throughout the pandemic. And I'll share that policy aspect as a sovereign nation, but as a country as a whole, and as the state as a whole, maybe I'll let Matt or Doc, representative, talk about that. Thanks.
Matt, do you want to chime in about
Go
what
for
were
it.
your biggest challenges?
Yeah. As I mentioned in my opening remarks, how does the information that we're learning and how does our understanding translate to policy? It's not easy. as we learned more about this virus, how it transmits. Mask mandates was a big one when it came to policy. Luckily, as opposed to my two counterparts over here, I didn't have to make those decisions. I got to be the one to just deliver, hey, here's the information, here's what we know. And here's some guidance, and here's what I think. But at the end of the day, I got lucky enough to not have to make that decision. And then when it came to infection, who was most severe, understanding who was most at risk, and how do we form policy around those that are more susceptible to an in particular virus. School closures, major challenge, closures in general, really, especially for Coconino County. We closed before we even had a case, and that's a very, very hard decision to make. You don't know at the time how long this is going to last, and that COVID fatigue and those closures that are taking place. And we did it as a country, at the middle of March as an entire country, and we were in very different places at that point. Some states were being affected, some states were not yet being affected, and so the idea was to flatten that curve, of course, get our healthcare systems ready, get ready for fighting this virus. And so those were all major challenges. The school's a big one. We were identifying, and I mean, I still am rather confused about how a virus that is new to humans does not affect 0 to 4-year-olds. That is extremely confusing from a disease point of view, because they're typically going to be affected just as much as our 65 or 85 plus. And so, knowing that they're not affected, and yet there's potential to spread to the more vulnerable populations, how do you make those decisions on protecting your vulnerable populations while allowing the rest of society to go on business as usual? And so I think those were some of the biggest challenges. Virtual world, virtual work, everybody going virtually, and really, I think all of us as a community, as a country, as a state, as counties, did a very good job of going to a remote world as we could. There's some businesses that couldn't operate that way, but especially for those of us that were really working in the response, did an amazing job without being able to be around each other. And that's really translated to the current world here with all the virtual people we have in attendance. But yeah, so I think those were some of the major challenges, and trying to deliver to our community leaders. Here's the information we have. Here's the evidence we're seeing. And so, I got to say good luck, but yeah, very tough. So thank you.
So, Dr. Shaw, obviously policymaking in the legislature happens in a slightly different way. So what were some of the biggest challenges that you faced there with COVID?
Sure. I first want to preface all of this by saying that a lot of the policy that's made regarding something like COVID-19 happens in the executive branch. So you were either the governor of a state, or you were possibly the president of a large tribal nation, one of those. It's not going to happen so much at the legislative level, because everything we do in the legislative branch is pretty much by committee, and it's slow, and it's not meant to be there for action on the ground in a quick response type of situation. And this certainly was a very quick situation that society had to respond to. Most of what we did as representatives, except for maybe one function, and that's appropriation of money. So the legislature controls the purse strings a lot of times. And so when funds become available, either state funds, federal funds, we are often tasked with making sure that those are appropriated and are spent appropriately. And one of the other things, being a state legislator, is that the state of Arizona does not have the budget to fight a pandemic like this. as we quickly figured out. We're talking about a sum of money that is like a log order higher than can be tackled by the budget of the state of Arizona. So really, a lot of this did end up being federal funds that ended up coming in and helping us do that. So we were in a unique position as state legislature, as legislators, trying to make policy in the middle of this, and asking ourselves, well, what exactly can we do? How can we help? And one of the things that for me was trying to find ways to make sure to communicate, to act as a conduit of communication between the people, since we are representatives of our local districts, to be able to move those messages back and forth to key decision makers, really in the executive department. And so I always had an open line, fortunately, with the Ducey administration at the time. And they were always willing to listen to what I had to say about what was going on. So whether it's one particular hospital where we felt that the ICU beds had reached critical capacity, or there was a supply shortage somewhere, and we could find some ways of linking them to resources that were available. Those were active conversations that were going on at the time. At the same time, in some ways, trying to make sense of a lot of a very novel situation, describe it, to explain it, to help people understand from somebody who they know, who's in their community, and explain to them, what are we doing? Why are we doing it? What is this disease? How can it affect you? All of those questions. We forget sometimes how much information about this brand new disease was absorbed by essentially the entire population of the country in such a short amount of time. So we did in fact get a lot of that information out there. And yes, I know about all the prior discussions we've had about, misinformation online and all of that stuff, but yet a lot of what the public had happen was education. To the extent that we were able to push the right messages out there, a lot of that was done as well. So I think some of the challenges I heard the two prior speakers already kind of touch on, and a lot of it is just questions that kept coming up, right? Making policy in the middle of so much new information, research that's just emerging, questions that people legitimately had at the time: masks, vaccines, closures, social distancing. All of these things were all issues and questions that people had to ask and people had a right to ask. And so getting through all of that is kind of the role that I felt like I found myself in addition, of course, to actually working in the emergency department and seeing patients who were suffering from this disease as well. And then treating and being able to treat those one-on-one. I will admit that experience of being right there with the patients certainly helped me to explain to people, both in the population at large as well as key decision makers, exactly what was going on with this virus. So I think that's sort of a broad overview of a lot of the challenges that were going on at the time.
Well, you answered my follow-up question, which was going to be, in what ways did your double life of being in the ER as well as in the legislature, how did you connect the two? So I think you answered that quite well. Okay, so my next question for all of you is possibly moot, and if so, we can move on to another one. I don't know, but we've talked a lot all day, and including just now, about how this was a novel virus. This was new. But it wasn't the first time we'd ever had a virus. It wasn't the first time we'd ever had a pandemic, even though it's been a while since we had one. I mean, at this scale and that moved this quickly, obviously it was new in that. But what were some of the biggest surprises from a policy standpoint in particular that caught you off guard, if there were any? Anybody?
Who wants to start? Doesn't matter to me.
Matt has it looks like he's got some thoughts.
Yeah, I'll start off. Well, in the transition from policy to surprises, what I'm hopeful and what I've seen take shape already is policy translating to habit. And so that's been pretty exciting is, just realizing nobody wants your funk, So if you're sick, stay home was a big message, right? And part of policy and social distancing, and then that with the mask too. And so I think even though there's a lot of backlash, I've seen from many different ideologies out there that when people are sick, they're staying home or putting on a mask nowadays, just not feeling well, throwing on that mask, and the stigma, I think it's decreased that stigma a little bit. So that's very interesting and exciting to see. So that was a positive one. Biggest surprise is easy to go down the negative route here. I'll just say two things. I had that positive, and then really for me, we underestimated the public reaction in all the different ways that we prepared and planned for pandemics or outbreak response. We figured that public health would come in as Superman, underwear on the outside of my pants or however, and cape and everything, and everybody would just like agree and the Shangri-La of, okay, here, these people have our best interest in mind, and we know that that's not the case, and in fact, it's maybe even eroded some of the trust as we've heard previously, and so that was a shock, and that took me by a lot of surprise that. Here, especially at a local level, I think government's looked at a lot of times it's just one group, but you have, federal, you have your state, you have tribal, you have your county, and ultimately, especially at a local level, there's a lot of people making very little, doing a lot of good things, and to see how that was so questioned and really underestimated that reaction from the public when there's a large group of people that are really just have the best interest in mind. A theme that I kept coming back to back to ideology, a lot of different ideologies was that, my bias here is to create a safe and healthy environment so you all can go back to your normal lives. That's my goal. And that's a lot of our goals within public health or medicine or in all of us that were in this response. And so that was one of the biggest surprises for me. But then the word epidemiologist in general was very difficult to say in 2019 and became a household word in 2020. Yeah, right. And then so that was exciting to see that in the first year. People got smarter too, even though we had the misinformation, disinformation. The first year I was asked questions about, what's a virus versus a bacteria versus, just starting to understand diseases. And the second year it was what variant is circulating around. And I'm like, you all got educated, so anyhow.
I was thinking this morning when I don't remember which presentation, the first presentation that mentioned R naught. I'm like, oh yeah, I remember the R naught. We were all talking about what's the R naught. It was not on my radar before that. Other surprises from our other panelists?
Well, this is Jonathan Nez. Those of you that are on the Zoom, we got used to WebEx on Navajo Nation. We went a step further and mandated vaccinations for our Navajo Nation employees. And at one point, we were like 80% fully vaccinated for our Navajo Nation employees because they're out there providing the direct services. And that was very surprising to me that the employees were willing to get vaccinated. And I thought I was going to get some pushback. I thought, here it goes. I'm going to get protests over here at the Navajo Nation Capitol. But it didn't happen, just like what we saw throughout the country, right? Everybody's protesting masks, vaccines, and all that. But that didn't happen. So I think the messaging, the information that was being provided on a periodic basis At the height of the pandemic, I think we had Cecilia, 2 town halls a week, right? 2 town halls a week, and just giving information. You're right. Our citizens, learned a lot about it, and that's what they anticipate now. Now they don't have town hall meetings no more. So now I'm getting all these emails and messages. Hey, what's the information? Because they're hungry for that information. Like what's going on the Navajo Nation. We don't know what's going on, things like that. But I think that was surprising. The relearning of things. And I think really the Navajo people grew a lot from it, and it just showed the resilience. I was talking about the media. Someone was talking about doom and gloom stories, right? When we were number 1 in the country in COVID positive cases, man, I had every reporter from Washington, D.C. over there at Window Rock. You probably might have saw us on the news saying, oh, poor Navajos. And they would tape us, and then they would just change the whole narrative of what I just mentioned. So I stopped doing taped interviews. I said, if you're going to interview me, do it live. Because I wanted to also share with them the story of overcoming here, resilience. Yeah, number 1 in the country in COVID positive cases, but we turned it around to where we're the most highly vaccinated people in the country, maybe in the world, and to show the resilience of our Navajo people throughout that time. And so that was something that was very surprising. Since we're talking about a lot of media today, I thought I'd share that from an elected official's perspective, because you had some cool reporters, and you also had some not so cool reporters, and that made it challenging at times.
That's fair. Dr. Shaw, any surprises that you noticed in relation to COVID and COVID policy?
Yeah, I think Mr. Jewett all touched on a lot of this. I mean, the idea that people would just kind of, as somebody who has practiced medicine and has had patients for the most part, listen to what you have to say, trust that you know what you're talking about, was kind of ingrained in my head. And then, of course, like I said, I have the public health degree as well, and I understand that public health officials are out there. We all know that there's a public health department somewhere in government that does what it's supposed to do and keeps us safe and free of disease. And so the surprise came when the public really wasn't willing to trust a lot of what was coming out of the official channels. So that was surprising. That was probably the biggest one. First of all, the whole pandemic was a little bit of a surprise itself that something like this would actually happen. And so, we're in a very novel situation. Then, the messages are coming out, and we're seeing a lot of distrust come out of it. The fact that science itself would start to get political, as many of us saw it, was a little bit of a surprise and a take back. And that came in, on several issues. On the more operational side, I was surprised when I saw the experience for the first time before it hit the United States. There was the experience in Italy, and we saw that hospitals were being overwhelmed, and all of a sudden the surge was too great for the system itself to absorb, and that we could potentially face that here. That was also sort of a surprising piece of news when we first heard that. And then in the state of Arizona, we mostly were okay and just kind of, I would say, escaped. At the very peak, we had very, very few ICU beds left. There were some places, notably, I remember Yuma Regional, that did kind of get above capacity, had to use things like the surge line. And so some of that was a real surprise, that we would actually run out of capacity, right? We had been hearing that the ventilator capacity wasn't there. We'd just have too many intubated patients. And so those people would exhaust all of our resources. And that it would happen was a little bit of a surprise there. And it's I think those are the main ones, and I think those are some of the places where we learn the biggest lessons. So you hear these things happen. So what has to happen next is we can't be surprised again the next time. And I think a lot of the discussion I've heard throughout this conference has been trying to basically address that and learn from it.
When you say you were surprised that people wouldn't take the information from public health and all that, are you saying this in terms of interactions that you had with constituents who, when you talked to them, were questioning health policy decisions? Are you talking about patients in the ER who would argue with you about policy? All of the above?
All of the above. All of the above. Yeah. And so it went a lot better in the emergency department because you're in the setting where I'm wearing a white coat and a stethoscope and I'm talking to you as your advocate, and it's a setting and a place of trust. And I will tell you that I took an oath to help you and protect you and tried to do the best for you. And that's what my job is as a medical professional, as a physician. So many of those conversations went well, to be honest. I had lots of people who came in and asked all kinds of questions about the vaccine. And I really believe that even though it's difficult, physicians have to have the patience to be able to explain the situation to the patients and then also answer any questions they have about any of the above, right? And that's where a lot of people felt that they were getting their best information. I remember ADOT signs that says, go talk to your doctor about the COVID-19 vaccine, right? Because it's somebody that presumably, hopefully had a relationship with. And so you would trust that they would be able to give you the right information. Now, on the political side, it is a little different. It made me think a lot about our system of government. And some of you may know that I like knocking on doors. I like going out and talking to people, making those relationships happen prior to getting elected, and trying to be, maybe if I haven't met everybody in my district, because there's 250,000 people in my district and I can't get to know everybody, perhaps you're 1 degree of separation from somebody who knows me, right? Because I've knocked so many doors and been out there. That's the beginning of trust. That's the beginning of a relationship. But it made me think about our system of government. Of course, we have a Republican system of government in that you have representatives that represent you in democracy. But how many of us know that person? How many of us, understand who that person is before something like a crisis comes along? And that was the basis of trust. So ask perhaps the people who had already met before and who had, my name and my phone number and my email and could reach out, and, the questions are going back and forth, and there's a higher degree of trust there. Now, again, I don't know. Some representatives may be doing that all over the country and some may not. But I think that also gets to questions of trust in our political system. The more and more we as politicians can get into the community. I think President Ned said this best when he says, I'm actually out there in the community doing the work, and people can see that I'm doing the work. That's exactly what starts to build trust, and having the patience to be able to answer questions and communicate, I'd say, factually.
Okay, well, this has gone really quickly. I have one more question, and then we're going to take it to Q&A. So my closing question to all of you is, if you could think about what somebody stepping into your shoes, what advice would you give to them for the next big pandemic that comes along? Things that you wish you had done differently, or things that, with what happened, you are in a position to be able to say, oh, here's how you can get ahead of it. And we've sort of addressed some of this in various ways throughout, but this is kind of trying to encapsulate that in a nutshell.
I can start. Having your spouse be more a part of the discussion, I would recommend, because your family are the ones that also give you some guidance. And I also mentioned too that surrounding yourselves with professionals, people that are expert in that field, health, policy. I didn't have many former officials, elected officials in my circle, but I relied heavily on science, on the data and the information that was being provided. Maybe I could have used some elected officials to be a part of that mix, but just being in public service for 20 years, being a county supervisor at one point for Navajo County also helped. And so just surrounding yourself with, people that know a little bit more than you. And the other is not to make decisions. Of course, we all know this, on emotions. I think I made some decisions based on emotions because was happening fast, right? This was happening fast. People were, getting sick. And you needed to make a decision right away. And sometimes we had to kind of retract some of those decisions that were made during that time. Because, we didn't know what the future held throughout this pandemic. So I just think that that's a question that I'm still pondering. Just fresh out of politics, what would I do different? But I think a lot of the policies that we put in place, bottom line was to save lives. And as I mentioned this morning, I might have lost the election because of some very strict protocols, but you know what? I'd do it all over again. I would, because saving lives was priority for me.
Matt, Dr. Shaw.
I can. Oh, go ahead. Go ahead.
Go ahead.
So I guess I'll say I'll start. I'll end this where I started it at the beginning. Again, talking about the idea of humility, right? One's own credibility must not be assumed. So I have. You can see I have a couple letters after my name. I also have a D next to my name, usually in media, and whenever the media quotes me or whatever. But that doesn't really matter. So some people might trust that or choose not to trust you just because of that, right? And I can't presume that other people would trust me because of either of these two roles, or in spite of them, I guess. And so the thing that I think all of us can understand from that is ask yourself, do you know the person to whom your audience? Do you know your audience? Do you know the people you're speaking to? Because what you might be trying to do is you might be trying to persuade them of something, of anything, right? Of the way you see the world, of what might need to be done. If we're having a political discussion, it's a societal discussion, and you want society to make decisions a certain way, move a certain way. You want to talk to your friends and neighbors or whoever, coworkers about how things should or could be done in society. Well, ask yourself first, have you asked yourself, like, where do they come from? What is their perspective? Have you gotten to know them before trying to persuade them that you're right, and that you're correct? It starts with listening. It starts with humility. And you'd be surprised how much further you can get if you take into account that you've fully and thoroughly heard where somebody is coming from before saying, "Hey, I'm going to try to tell you what to do." Right? So I think we're very, very sensitive to that as a people. I think people. I think we've talked about American culture as being very individualistic. People have a reaction to people telling them what to do, and I think we've just got to be very, very cognizant of that. I also will say that, from the trust perspective, I worked with people in both parties throughout the entire pandemic, and during the time we were really in crisis, As President Nez says, we were just trying to save as many lives as possible, and we really mean that. There was no ill will, that I, or almost no nefarious intent throughout all of this. We weren't trying to wreck people's lives or businesses or all that other stuff. And I really mean from people from both parties. All I saw was an outpouring of goodwill from the actual politicians saying, what are we going to do to serve the population best? And what you see is during a crisis, Americans actually came together. At least our leaders did come together and tried to do the best they could, regardless of whether they felt that they were going to win their next election. I mean, and that's what we politicians get blamed for a lot is hey, you're just looking out for your next election. Well, the thing is, I during that crisis and that pandemic, I really saw a lot of goodwill come out, and I saw a lot of the best of us come out. Not always, but I think back at that period, and I say to myself, well, that gives me a lot of hope.
Okay, well, great. And that's, oh, wait, Matt, we skipped you. We went in a different order. Usually we've been around. Okay. I was like, wait, you thought you were going to get out of this last question.
Yeah, I thought so. I'd say run the other way. If you see a pandemic,
move to an island.
Is mine still on? Yeah, if you see a pandemic coming as an infectious disease epi, run. No. And if you don't run, then the preparation is huge. The surveillance,
extreme
piece.
Social distancing. Yeah.
Yeah. Where can you go hide? But the preparation is huge. The surveillance piece. We have such far advancements when it comes to identifying and identifying new variants of a disease, new diseases. We're finding that stuff, and so that surveillance piece, and that's what I really hope is one of the main takeaways from this is how important our technological advances are in our surveillance, that genomic epi work. This was identified. I don't know that it could have been stopped, but this SARS-2 virus was identified. It was known. The laboratories saw we have this version of virus we've never seen before, and that's happening all over the world. And putting money towards that, understanding that we have that technology and knowing that we can prevent these things is very, very important, and not pulling away people around the world that are doing that work. And then bringing, as I said when I opened up on response, bringing more people to the table when you're planning, bringing everyone to the table. Here's what the plan is. What might you need? How can your organization be more resilient if this were to happen? It may not even be a pandemic. It might just be an outbreak that's at your location. What are you going to do? How are you going to continue your operation? How is education going to continue? How's the university? How's your business? How's shelter? The homeless shelters that was a huge one. That was a very difficult situation, and they were not at the table beforehand as far as a continued operation standpoint goes. And then the metrics. What metrics are most important? We've been talking about the data, but and I really like because I try to do this, not just graphs and data points and everything, but describing that and putting the emotional context behind that data and what metrics are going to be most important to and information to get out to the public, and how are you going to organize that? How are you going to manage it? And then how are you going to then provide that information out is a lot of the advice that I would give. And I really like that trust part that Dr. Shaw was just talking about, being open, being honest, listening, understanding where people are coming from. You're going to be talking to at least somebody filled my shoes. You're going to be talking to people from all different backgrounds, and it's very important to build that trust with them and listen. And across the ideological spectrum, when I talk to somebody one-on-one, they'd say, well, why didn't they just say it like that? And really get people to understand where I'm coming from by being open, honest, and especially listening and finding that commonality somewhere. So, yeah, thank you.
I think think ending on empathy and listening is a good place to end this conversation, and good takeaways in general for anyone in any kind of role. So we have just a couple of minutes for Q&A. I've given to understand there is a question online, correct? Now I know I'm not glued to my chair. Sorry.
Okay, so online, the question was from Cindy, and about strategies to inform politicians of the evidence to impact policies for improving public health. The question about politicians, valuing evidence to drive decision making. We can take that many different directions, but we'll say, what's the best way to help? What can we do to help our representatives really get the information they need, or listen to the information that they get to inform policy decisions? Cindy, I hope I did not butcher your question.
You did great. Thank you.
Great. How do we get the information to the political leaders? Everybody's looking at Dr. Cha.
You want to start off on what would work for you, Dr. Cha?
What works to convince your legislative colleagues of the science?
Well, that's it's totally right up my alley. So if you come tell me, please use evidence, I'll just do it. So I guess that answers that question. or if you've got to talk to now again, I'm just going to refer back to what we just talked about is that we want to try to when talking to a politician, it's actually the exact same thing, right? So you're trying to figure out when talking to somebody, you're trying to convince them. You're trying to say to them, look, have you considered this evidence with regard to my position? And you want them to think a certain way, act a certain way, make a decision a certain way. So it starts by figuring out where do they stand currently? Why do they believe what they believe at the moment? And usually, maybe not always, they might give you some answers about why they believe a decision needs to be made a certain way. Some of that could be based in evidence that you might not know about. Some of this might not be. And that's a case-by-case basis. And that means what you're really talking about is advocacy, right? Lobbying is another word for it. And when I tell people over the last 5 years in office, I've talked to people about how do you effectively lobby politicians and get them to listen to what you have to say. I tell them the exact same thing that we just talked about. We said, well, build a relationship, help them understand, who you are, where you're coming from, but figure out who they are, where they're coming from, why they believe what they believe, and what other people perhaps in their orbit might think something different. So I think that's the first place to start. Once you've gotten to that place, I think then you will create an opening where that person might say, well, now I do want to kind of hear from your perspective. And that's the opening that you'll have to be able to share your evidence as to why you believe what you believe and what you want them to do in response to that. And I think most people really do have a sense of that, especially being down at the legislature. We're tasked. I mean, we have like 1,000 bills a year or something, and on every one we have to try to learn and make the best decision we can. And after a while, you start to get it. You'll have two lobbyists come in, one on the pro side, one on the con side of every bill, right? And you'll be the judge, and you'll sit there and try to figure out. And I think most of us start. I hope at least to make decisions in this way and to ask, well, what's going on here? What's the problem? What's the evidence? Not just other things like how's my party voting or whatever. What would my mom think or something? You know what I mean? It's like there are a lot of considerations for how politicians make their decisions. There really are. Some are better, some are worse. And I think that it's that relationship building and that space that you create of trust that will allow you to then present your evidence that would then sway or persuade in the best way possible.
Matt, you had something to say to that too?
Sure. Yeah. I mean, that's perfect. It's exactly that. And that's what I do is the transparency piece is here's where my evidence is coming from. Here's the information I'm able to gather. Here's what we know so far. Here's our understanding. Here's the sources that this is coming from. Here's the research, the legitimate sources that this is coming from, I should say. And yeah, building that rapport, building that credibility, and being transparent, showing that this is the information here that we have. This is what we understand, and how we're gathering it, where we're gathering it from, and delivering that information. And so instead of just, here's a graph, but how did we get to this place? Showing the pitfalls too. This is what we don't know. This is what I need your help. So that was one of the things I was able to or that I did anyhow with the community leaders that I was with was here's what I want to know. Here's what I don't know. I would show the good information, but then also say here's where we're lagging. Here's what we need to know in order to make these decisions, and show a little bit of that humility, I guess, or the vulnerabilities there of I need your assistance, and that always helps. I'm right here on a panel with some great political experts here, but feeding egos, right?
Everybody wants to be asked for their input and their help, right? Yeah. Do we have any other questions?
Thank you. And I hate to throw a theoretical question at you, but considering much of this workshop is kind of diving into the future, which is what we're going to be doing with these roundtable discussions. If you could go back, and I know there's not a one solution to fix everything approach, but knowing what we know now, if you could go back and say, put in a policy in 2018, 2019 to kind of prevent much of the disaster that happened, is there anything that comes to mind?
Who wants to go first?
The back to the future to try to prevent, is that what you're talking about? And for mine, it was that piece I was talking about on that last question that we had about the surveillance piece, and the infrastructure in that, really bulking up the infrastructure in. We have the capacity to identify these new diseases, these new and emerging diseases early on. And if we can isolate and quarantine quickly, then I feel like we can do a much better job. I don't know that's going to be the end all cure all, but that's happening in a lot of different ways, right? Within our food production areas, there's a lot of potential new viruses and diseases that are spreading. And so we have a constant testing of those animals to see, what's emerging, what's taking place, these emerging infections. And so to really deliver a lot of resources towards identifying new and emerging infections, and then really quickly getting on new cases and seeing if we can't isolate and quarantine, and being open and transparent about it. I'll stop there.
Well, for the Navajo Nation, I'm going to take this question in a different way. Prevention, right? Building your immunity. The reason why Indian country, people of color communities got hit hard is because of the high rates of diabetes, cardiovascular disease. So, we at least during my years in office, really focus on health and wellness, and taking better care of your body, getting away from, all the processed foods, and just building up your immunity so that viruses like COVID-19 doesn't wreak havoc on an individual or the community. We have food summits that are happening on Navajo, going back to our traditional foods. I'm not talking about Navajo tacos. I'm talking about like beans, corns, and squash, things like that. And really just educating our Navajo people about taking better care of themselves. That's a whole retraining of the mind. I'm doing a food summit in Kayenta, Arizona. I don't know if many of you know where Kayenta is. People see it as the fast food capital of the Navajo Nation. There's so many fast food places there. And the reason for it is to tailor towards the tourism industry. But what about the people who live there? What is the data? What is the information gathered about what fast food is doing to their health in that community? So I think really, if we want to go even way back, it's just focusing more on prevention work. Since we're in a public health talk here, really just educating our people, take better care of themselves.
I certainly agree with both of those. I heard about from President Nez, the underlying conditions certainly make a difference as far as COVID mortality. So anything we can do to move in that direction, absolutely. That's one. From Dr. Jewett, Mr. Jewett, I heard that we should be doing surveillance. Yeah, absolutely. Just tracking these things all over the world. We also know that COVID can affect other species, such as cats, right? And so that has to, also be out there, and our research is out there across the world for doing that. The thing that I want to add, though, from the political part, is that it reminds me a little bit of when 9/11 happened years ago, and you had the FBI and the CIA just weren't talking to each other, and we heard about all that and what a systems failure that was. And I think also at some level, we're a very large country, 330 million people, and the information flow that happens from top to bottom and back up, it isn't exactly as robust as you think, right? Talk about then putting partisanship onto all that. So I have a Democrat governor now, and I have a Democrat president, and I have, but that won't always be the case. And, the Speaker of the House of Representatives in Arizona, as far as and the federal Congress is Republican controlled. And so all of a sudden, communication just sort of stops. It doesn't matter, regardless of party, if it's the same party, things do get a little better sometimes. And then things get worse, but that's not actually helping the people. Right. And so the robustness of that communication in both directions really would help us quite a lot coordinate what's going on, because if you're issuing, say, orders from the very top, and then you created distrust at the bottom, you can say to yourselves, well, perhaps if we were engaging a lot of people down at the ground level, and then those messages were filtering back up, and that communication was happening a lot better, that would certainly be of help in terms of policy and implementation. And so in my limited time in elected office, I can tell you that I expected that our government at the multi-levels, from federal down to local school board, I thought that there would be a lot more sort of formal communication going on. And I've sort of been, I wouldn't say surprised, but I've sort of been taken aback by how little of that formalized communication does happen, and how partisanship also as a lens tends to disrupt that. I don't think that that's a great thing for the American people, and perhaps we could foster more trust if we started to sort of insist on professionalism from our politicians to sort of communicate up and down with everybody.
More communication, more empathy. These are the kind of our takeaways. I think we're out of time, right, for questions, unfortunately. But I do want to thank our panelists very much for joining us for this conversation.
The next portion of this is for roundtable discussions. I just sent a message to those of you that are participating on Zoom. We will set up some breakout rooms there as well. But we have a handful of topics in mind that we'd like to see, that you can choose from as far as participating in these roundtables. So let me just read them all off real quick. And then you kind of pick in your mind where you think you want to go with it. So one would be policy. 2, culturally appropriate messaging. 3, communicating the process of discovery. 4 will be communication of information, data visualization, and that includes communicating to frontline healthcare workers. 5 is surveillance strategies, so how to continue to expand while not in an emergency reactionary situation. Could be part of that. 6 would be politics of pandemics, lives versus livelihood. 7 would be continuity of operations, preparing for the next pandemic. And then 8, we just added this one, something about AI and how to leverage that messaging and propaganda. So, Aaron, any chance we can... I don't know. I sent that in that Zoom text. Is there any? We're going to get those shown here. So,
share your screen.
Yeah, I can't. I don't. No. So let's see. And I just posted those in the Zoom text. So, how many of you would want to let's just see a hand for policy? Okay, good. And we're going to go quick on this one. Culturally appropriate messaging. Okay, couple, let's call that a round table. Can you all join here with President Nez if you're culturally appropriate messaging? Let's see, communicating the process of discovery, science communication, anyone? Okay, so we've got 2 there, maybe a third. If you 2 could join in the back at that table, what table number is that? Okay, go on back to 8. Then we have communication of information, data visualization, and maybe we want to, let's just combine that one. So 3 and 4, that's going to be at that background table. 5th one, surveillance strategies, how to continue to expand. Anybody there? Okay. Next one would be politics of pandemics. That's got to be a juicy one. Anybody? Nobody wants, yeah. Continuity of operations, preparing for the next pandemic, which could overlap with policy. No one there. And then the last one we had was the AI, the messaging and propaganda.
That's the politics of pandemics.
Politics of pandemics. That one, okay. Politics. Was there anybody else with that one? If you're interested in that one, why don't you join that table? What table number is that? 6? Okay. Here's an online, I'll get on the chat here shortly and try to organize you all into a couple different breakout rooms. So here's what I'd like you to do. On your table, once you're grouped up, if one person can scan the QR code on the table, and it will take you to a Google Doc, if you could just keep your notes on that Google Doc as you discuss, that way we'll be able to share those notes once we're done with our discussions. Does that sound fit? Yeah.
Hopefully we've been able to have some great discussion and get wrapped up here. And now this is the part where we're going to share what you all were able to come up with. So I believe we have people in the room are going to share and online, correct? And so we'll start off with volunteers. Who wants to go first? Dun, 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 dun.
Winner is.
Who do we got? Communicating the process of discovery. Is that stable? That's stable? All right. So, communicating the process of discovery. I'm going to pass over the microphone.
I mean, well, what are you talking about with the first bullet point? Oh. Yeah. Well, so we really just talked through everything. Like we went on little rants. I think the general thing that we really started with that stuck though is that a lot of the communicating targeted the public in a lot of ways, but there needed to be much more communication to actual healthcare providers and those on the front line. And there was kind of this assumption that they'll figure out the information. They're in the medical field. They'll know without actual consolidated, easily accessible training and best practices for how to handle this situation and crisis for them. And so we spent a lot of time talking on that. You're squinting your eyes. I feel like, okay, no. And then I guess to the first point, and then you can go the rest, is what we don't know, we never figured out what the line is between providing information about the process, right? That information changes, that the pandemic was a very evolving thing, but that the average person only has so much time and cognitive effort and motivation to actually process all of that information. And so, yes, we can say, oh, we just need to communicate the process and trust that they are going to be able to understand it and implement it and be okay with that but there's still, you can't give them all that information because it's going to overload them and then they're just going to they're going to lose sight and just start focusing on bad information. And so that's what we don't know. We didn't have an answer. We just knew it was a problem.
Yeah, that's exactly right.
Yeah, we split our slides into 2 different categories. So what we don't know and what we do know. And one more point for what we don't know is we live in a world where if something happens, a company or individuals or a group of people need to respond immediately because we just have that information at our fingertips. So how do we go about sharing this information with large groups of people in order to reduce their anger, anxiety, sadness, and fear without leading to a larger catastrophe? So on to the next one.
So those are for what we don't know. Those are those 2 bullet points.
Oh, you have it up there.
We have it up there. Yeah, we got it up top.
I mean, we also discussed that there's an inherent assumption again in the figuring out. We don't provide training on how to recognize mis and disinformation, understand its connection to values, understand typical strategies of de-radicalization or other techniques that other fields know. We just assume that these folks are smart healthcare workers that aren't doing anything else, so that they'll also be put in these situations and that they'll just solve that problem. So how do we do that? And also not just have the very painful Zoom training with, crisis actors that are, stock footage, right? That you just put it on play and you go eat while the training. How do we create something that's of real value for a community that's overstressed and overworked so that we actually help them do their jobs and can communicate that to members of the public?
Do you want to hear it?
Yeah. Let me experiment.
So I came in late, but they said, "Hey, Lance, we're going around in circles. So here's the question: how do you communicate the process of discovery, of scientific discovery, to the public?" And so I said, "Let's ask ChatGPT." And so I asked it that, and then I said, and it long thing, and I'm like, "Can you just simplify that into 5 bullet points?" Right? So it's like number one, simplify the language used to explain scientific research. Duh. I mean, none of this is brilliant, but hey, use analogies to help people understand complex scientific concepts. 3, use visual aids such as diagrams and videos to illustrate key points. 4, tell a story about the research, including challenges and discoveries made. Number 5, engage with the public through social media, public lectures, and other forms of outreach. I've got one. Hire brilliant storytellers. Do you remember the January 6th hearings that we had last year? Yeah, and not to get political, but one of the things that those hearings did really well is they must have had people in the background that were like, we know how to tell stories through language, through multimedia, bringing together video. That was beautifully produced. And they must have had some, like, I don't know, Hollywood people or some really great storytellers working in the background to produce that. Anyway.
So was that the AI?
Yeah, it's ChatGPT. So I asked it the question, gave me a really long answer. And then I said, put that into 5 short bullet points, and it did that. The hire storytellers was mine. But it's a good way to brainstorm if you're like in pain facing a blinking cursor.
Just one more thing. I think we were talking about like how Nikki persuaded me into realizing that, like, you know, really all of our education has like values attached to it, right? And we need to, when we're trying to convince and persuade and educate, we need to be really conscientious about like people's values, and our education should be values based and tailored. Because someone living in rural Nebraska might not have the same values as someone who's living in Manhattan, you know, actually almost undoubtedly does not. And our education can't just be one size fits all. It needs to be tailored to those individual populations. Likewise around here. So Flagstaff is a relatively well-educated and like more liberal community, but like a lot of the surrounding areas are like, I would say less so, and like very socially conservative. And so the messaging for Coconino County, which is the county we're in currently, really needs to be like tailored to the individual communities that are within Coconino County in order to like produce buy-in and ultimately help save lives, right? So, right.
Wonderful. Anything else to add there?
I think you can overthink that, though.
Probably can.
No, I think you can overthink that. What I mean by that is when you want to tell a story to a lot of people, and there are people that's what they do for a living, right? Everybody cares about their kids, their families, their community. Everybody wants to live their lives free from harassment and be healthy. Like there's different cultures and different ways of approaching values, but it is possible to communicate across microcultures and even larger cultures, and there are people that do that for a living and are really good at it.
I guess add in that. I think that's completely true. And I think doing work with entertainment, you see that a lot where for example, entertainment storylines are able to tell a whole, like as we were going through COVID, we were experiencing it over a very somewhat long period of time. For some of us, it felt like it was going on forever. Whereas, you know, you can create a story through an entertainment narrative, right? That more succinctly tells that, like I'm going back to that Grey's Anatomy season that just told it, you know, that whole process of discovery. But I think there tends that perspective. I don't know if it's completely held by a lot of, you know, people that I work with who just want to have this belief that it's the science. The science says the science. This is the facts. This is the knowledge. And that there's not this assumption that even that has value in it. Like they're valuing this type of scientific body, this type of process of knowledge, this hierarchy of power, of credibility, of source. And so I think I agree with you. I just think it needs to be implemented. Maybe that's the point of this, right? To get this, make more collaborations.
Go ahead. Covered it very well. Yeah. And so important, right? Communicating process discovery. We've got lots of different populations. We're trying to get on board to this message that we're talking about, storytelling. And so, yeah, thank you. Wonderful, wonderful thoughts, wonderful ideas to try to implement. So thank you. Yeah.
We're just all hanging out chatting right now. Relatedly, there's a media scholar who studies technology and media named Dana Boyd, and a few years ago, she gave a keynote address at a conference that has really stuck with me a lot, that relates kind of to this issue, and that is where there's a media conference. I think it was ONA, Online News Association, yeah, and she was talking about, so one of the big things that has come up in the last decade, but maybe even the last 5 years in particular, in media is fact-checking, right? Fact-checking organizations is part of, media literacy and news organizations trying to be transparent. Of course, there's also a lot of distrust surrounding fact-checking in certain communities. But her point was that that is a particular epistemological approach to the problem. And that is, what's the facts? Let's go and let's verify and say, is this a factual statement? But for large segments of the population, arguably for all of the population, because talking back to our earlier conversation about us telling ourselves that we are part of the fact-based community, every one of us has things that we believe that fly in the face of actual facts. I would put my hand in fire, as they say in Italy, that all of us have at least one thing that we believe despite the facts, not because of it. And she said, until we address this epistemological divide, and, saying that it's a divide makes it sound, again, like it's very simple, two sides of a situation. But there are a lot of communities, many faith-based communities that have a different way of approaching how they do their research. And we've seen in conspiracies like QAnon, and a lot of other types of examples, that the refrain, do your research, arises in a lot of contexts that don't have a lot to do with the kind of research that many of us in this room think about. And so going to this idea of facts is just never really going to get to the heart of persuading people or connecting with folks who just come at the world from a very different perspective about what is important. And I think that ties into the storytelling angle that you're talking about, is that you have to bypass some of that, with visuals, music, particular types of language, metaphor, all these things that make it not about just laying out the facts, or not even just about contextualizing the facts, but about getting to different ways of knowing. And that also, leads into other types of communities that privilege other ways of knowing anything. Anyway, don't want to ramble on too much, but I think about that a lot. And if you look up Dana Boyd, ONA keynote, she says it much more eloquently with a lot more detail, but I think it's really directly relevant to these conversations we're having today.
Awesome. Yeah, it really reminds me too, especially for the pandemic, as we're talking about it, and outbreaks in general, is as we're looking at discovery, and this in particular is looking at biological research, a hypothesis and everybody's different ability to understand a hypothesis and how we're describing that. And I noticed throughout the communities that I was working with that there was varying degrees of people being able to understand what that meant and how that process went. And we talked about a lot of today, oh, you told me this, and now you're telling me this, and now you're telling me this. And of course, that is rooted in a lot of our social determinants of health, where environment's at, who we're around socially, the education that we have, the education access that we have, but all of us who are the leaders understanding our audience and being able to communicate that well.
If I could add, thing came to mind here was earlier we were talking and listening about research with an agenda. And I would argue quality research really shouldn't have an agenda. It is a question, and we are looking for an answer. And then how we interpret and use those answers lead to all kinds of, appropriate or inappropriate application of research, right? And I see, and this goes back to something that I believe Lance had even said earlier, the whole, what'd you say, weaponizing it was bringing data to the gunfight. Data to the gunfight. That was awesome. And I see that as the struggle of our public health folks and our health the folks with the research. It's like, this is it. This is our data. And this is what we'd heard from Matt earlier. Here are our data. This is a story. Yeah, listen to it. And then the emotional response and the messaging to the emotional response, which goes back to the storytelling, is the challenge. And how can we get an emotional reaction to get people to tune in to what we know are the best data that we're aware of on that particular day or moment, knowing that it is going to change. So I don't know if that was a little off topic, but not so much. So.
Are you going to elect another group to?
Yeah. Okay, we're going to move on. And survey says, I'm going random here. Pandemic, life versus livelihood.
Okay. So one of the main things that we were looking at with life versus liveliness was we kind of got into purpose and passion and kind of what that meant for people in a time where everything was forced to slow down significantly. And one of the conclusions that we sort of came to was that for the people who were working online or forced to stay home or forced to just have that extra time to think and to soul search, because there was a lot of soul searching going on at the time. If they were able to find a sort of purpose, find their passion, they thrived. Like there was a lot of startup companies that were going on at the time. There were a lot of people that were getting really into social media and were getting really into just kind of working for themselves and making a brand for themselves. And those people really thrived finding their passion. But then on the other side of it, the people who weren't able to find that or who didn't find that, they had a really, really, really hard time. And that was something where there was the mental health crisis kind of heightened because of, I think, not just because of the pandemic and because of the fear that was going on, but also because of the lack of purpose that people were able to find at that time.
A couple different things that thinking about, the pandemic and future pandemics, that those who had trust in the media sources that they were getting, trust in their communities, in their, immediate, social groups, tended to do better, and that, building trust, in light of the next, potential pandemic, that this is a goal that our society should work towards, is building more trust so that people can be better prepared. Also, the question of how adaptable were people usually had a big indication of whether they were able to thrive or not. Maybe thrive isn't survive or what have you, or maybe thrive. But the ability to adapt to new circumstances mattered a lot for whether people became more outraged about the changes that were required during the pandemic. So really looking at how do we prepare people to adapt to new circumstances is going to be really important in, a next potential pandemic. And I think we had sort of talked about how yes, in some ways, a lot of people experienced a lot of mental health issues, maybe had economic stressors they hadn't had before. But in other ways, with a lot of things shutting down, people had more time for maybe to connect with certain activism causes. That certainly a lot of things that were also going on in our society during the pandemic, that they were allowed to connect with that. It was a lot of people maybe doing that soul searching and really looking and seeing like, hey, maybe it doesn't make sense that I'm working as hard as I am. Maybe I need to spend more time with my family. Creating that whole better work-life balance are some things that did come out of the pandemic and that we see probably, playing itself out in our society moving forward. And that, we will have to continue to figure out going forward. You good? Okay.
Yeah, thank you. This is as all these topics are another very important one, and really groups that were pitted against each other, and those having to make the decision. I heard from President Nez, those that actually had to make the policy decisions on are we going to support lives? Are we going to try to save lives? Or are we going to try to support our economy? And what a difficult place to be in, what a difficult decision to make. And then this was such a complex issue altogether, especially when it first happened. We had no idea how much death and disease was going to have, an uncontrollable spread of disease. How can we have uncontrollable spread of disease? How can we just let that take place? And then how can we burden our society so much that we may not rebound? A pandemic is not going to be easy. I haven't really read any pandemics where it's like, oh, they did this good of a job to where society flourished afterwards. No, it destroys. It's destructive. I'm very shocked it didn't destroy even more. And maybe we're yet to see that. Maybe it just hasn't happened yet. I was very surprised to see it wasn't as more of a disaster than it was. And so there's none of these are any easy answers. But I believe that hopefully, I'm hoping that we can move forward to do a better job. Right now, it seems like it polarized us even more, but I think we can do a better job of combining the two, doing a good job of saving lives while still building up livelihoods and keeping our economy rolling, if we're willing to make those decisions. But I don't know.
Yeah, I was just going to kind of touch on that. I think one of the biggest struggles with policymaking during COVID, but then something that's also kind of transferring into elections now and like what policies are going to be now is, living versus existing. Like I think a lot of policymakers, their priority was let's keep as many people as alive as possible. Let's try and save as many lives as we possibly can. But then on the other end of the spectrum, and some things that other people were starting to look at was the mental side effects of it, and how people were going to stay not only alive, but actually like living their lives and actually having something to live for and being able to find that. And I think that was such a big struggle in policymaking, and that's something that people are going to be looking at in the future when they're looking at elected who they want to elect and what those policies are going to be as far as what their priorities are with their mental health versus their physical health.
Yeah, wonderful. Anybody else want to add? The mental health was a big component. We ended up having, there's certain professions out there, in the medical world or first responders where they have it built into their systems to follow up with, we had a tragedy, we had a trauma take place. We're actually going to now get together as a group and debrief and talk about it. But then we had all these traumatic situations happening in with groups and organizations that don't have that. Public health doesn't have that. Public health wasn't like, oh, you just had 3 conversations doing a case investigation with somebody who was in the hospital whose family members had died, and they were telling you and spilling the beans, and there was no mental health follow-up on that because it wasn't built into that to that culture. It wasn't built into that system to have that debrief, and it's still not.
We'd kind of also talked a little bit about a lot of customer service related, the essential workers and what have you during the pandemic. as far as a perhaps positive is that a lot of people were less likely to just deal with their various systems of exploitation without, speaking up a bit more. We saw a little bit more of a turn away from, the customer is always right, and all of these things that I think as well, these sort of conversations going forward and, into potentially the next pandemic is something that's also people just standing up for themselves a little bit more in whatever system of exploitation they happen to be under, that became more of a conversation during the pandemic.
So I was just going to say, it's kind of along those lines, but when I was thinking about the inequities and a lot of the things that happened, and we didn't really talk about much of this today. And these are certainly important lessons to learn, but like thinking about the original, like signing up for the original vaccine was like at first exclusively an online deal. And I mean, I was trying to get my parents who are over 65 vaccinated. They could not understand. I mean, and they're privileged white people with computer access and all of the things that you would hope. And I had to sit with my mom because I couldn't figure it out, for a couple of hours to get her even get an appointment to be vaccinated. And by that, we were able to be on at the earliest possible point, and she still couldn't get an appointment for like a month's time because of the difficulty to be able to even sign up. So as one example, and then I was also thinking about, is it the TPP, the loans that people got, the intention was to support small businesses and people who aren't able to work. But now we're hearing, of course, and you just knew from the beginning that people were going to exploit that system. And now we're hearing about these ways in which people were able to get these loans. Just egregious, abuse of these systems. And again, the process for applying for those loans was not accessible to the people who needed them the most, people unhoused, people, not working, like just people without computer access. So, we probably should have been talking about that more today, about how like inequitable even just getting services has been through this whole process, and what we can learn about. I mean, that there wasn't even like a phone line to sign up for vaccinations at the beginning, and they had to think that through as a second step is just bonkers, right? So anyway, those are just, some people couldn't have good livelihood for any number of reasons. And, thinking about those tools, you talked a lot about tools, but the tools for the public, that's probably a really important thing for us to think about also. The end.
Yeah, a very important piece, that health equity part. And so much was dependent upon the internet, even just the data points, like, oh, what's happening in my community? I got to go online to check it out. And, in rural communities, Coconino County being one of them, there's a lot of people without access, or with the elderly, or not just elderly, but other groups who were not able to go through and understand that. And that's a big deal, and an important issue that we need to tackle moving forward.
Is there a reason that the federal government or state governments can't just set up that kind of infrastructure before we're hit again? Like you talked about systems to get people vaccinated, systems to get people access to the federal funds that they need. Like, okay, we're in a period of calmer now. Like, can we set up those systems now as perhaps as part of the rehearsal we were talking about earlier?
Yeah, anybody want to tackle that? That's
I was going to say, it sounds like a question for a policy guy.
That's a excellent question, and yeah, it's so. Yeah, exactly. It's resources, and it's that reaction part, and a little bit of what I was talking about in public health. We get so frustrated because it's so much less expensive for prevention and primary prevention, and if we set those up, but it's very hard to convince it's very hard to convince leaders to say, hey, let's spend the money now before it's a problem. And then we save money in the future. We're very reactionary. Once there's a problem, then we go for it. But it's a very complex issue, but it's a very important one. And the focus there of let's have this established, and can we set this up to where we're more so ready for it, or on a prevention level before it's happening, and that is just not where we're at. Yep.
For example, when we're not in a shooting war, we make sure we're freaking prepared for one.
I know, and that's a whole nother topic, really, the healthcare industry and how we could redirect some of those federal funds, right?
Think of it as a national security issue.
I don't know if you would think that now we've learned some lessons with things like the lack of PPE and all of this, that maybe there are people having those conversations and making those arrangements. But I think the other thing we've learned and has come up today is that we can't assume that somebody is doing this thing, and if it is being done, it's not communicated. And maybe it's not being communicated because they're bad at communication. Maybe it's not being communicated because it's not happening, or maybe it's not being communicated because it is happening, but the topic of pandemic has become so polarizing that they don't want to talk about it, because they'll say, oh, they have a whole warehouse full of masks. We already know that masks are useless, like that kind of debate. So I don't know. So choose your own adventure.
Or care, or a system for primary care.
But more politically controversial than war.
Yeah.
I don't know. I mean, how many people did COVID? How many U.S. people did COVID so far?
Yeah, how many deaths are we at now? Is it 7 million?
7
or 700,000? I mean, no, worldwide is that's what it's at. What's it at in the U.S. right now? I don't have the latest stats. About a million, pretty close to a million, right? 700,000. Yeah.
We lost that many people in a war. I would call this a national security issue. Maybe that's a way to frame it.
Okay, everyone in this room is going to write a grant proposal. There we go.
Oh, and a very important comparison there, very important analogy, one that I've looked at too, when you look at natural disasters or even wars. So I think the deaths in the US, I think the Civil War is what's comparable as far as deaths. Yeah. So but that was over several years. And we got to that number with COVID with just a couple. And when you compare it to any other natural disaster, when you compare it to fires or floods, and on a world scale, it's not even a comparison as far as, and this quote unquote, this was a wimpy virus. This one was, the symptoms were not that bad. The fatality rate was low, even without medical interference. And, a 2% fatality rate, that's pretty low for a virus compared to something like influenza. Is that like 4%? So you think about double the amount of death. Or you have, Ebola is at 30% fatality rate. So, very, very important conversation. But we might be digressing on talking about that one. Yeah.
Just FYI, the CDC says that total deaths, 1,123,000 and change.
1 million in 3 years. In fact, what's our March 25th? So our first case in Arizona was almost 3 years. It was March 15th, I think. Almost 3 years ago to the month.
Happy anniversary, everybody. Okay.
It was an ASU student. Yeah. And that's when we started our response too. Is mid-January. We had NAU students that had come back from Wuhan from winter break, and so we really started right then. Some people were sick. We started our testing, and it started really mid-January. But the first case in Arizona was
All right, I don't
ASU.
know which table this is. This table.
I just want to say, for the record, I typed this on my phone and it was very small. So no judgment on the typos and whatever if it's nonsensical.
Let me see if I can.
Good job typing. It was real small. I didn't know what I was typing. So, but I know you've got it right in here.
She also came equipped with some great questions. That's right. Like first year research assistant, you're knocking it out of the ballpark.
Thank you.
That's really great question.
So we're looking at culturally appropriate messaging, another very, very important topic.
We have the pleasure of speaking to President Nez about culturally appropriate messaging on Navajo Nation. Just a few major points that were made. It was important to have a Navajo name for the coronavirus, and it was important to tailor the messages and make them into the Navajo Nation so that elders can understand. And I thought it was really interesting that town hall meetings that Navajo Nation had to send out those messages, they were aired at some senior centers, which was, in my opinion, a great idea because a lot of people may not have had access to the internet or the radio to get those messages. So for them to have a place to go in order to get those culturally appropriate messages, I think was a great idea and something that I haven't heard in my research other than it happening on Navajo Nation. And there was an effort, a positive, successful effort to tie traditional stories and metaphors into the COVID messages and measures to get people to kind of understand how important it was to follow those mitigation measures. Anyone else? Sorry.
One of the really interesting topics that was brought up was the role of researchers. And I saw your note up there, which is what made me think about this, was the role of researchers starting to flood Navajo Nation. And coming in and it sounded like taking information without necessarily giving back. And it kind of also brought up, selfishly, some notes about working again with different populations and not just taking and coming back and actually sharing your results, sharing what's meaningful, and that it's not just it's no longer the ownership of the researcher, but it's really the ownership of the community who provided this really great information. But for so many reasons, Navajo Nation had these great practices. I think something that was also really powerful about those town halls was talking about this matriarchal figure who led them and who led some of the town halls, provided information that was broadcast twice a week on Tuesdays and Thursdays at 10 a.m. So you knew when to tune in, you knew when to get this good information, and it came from a relevant source. And I think that's so powerful that is what worked. It worked especially for the elders, that some of the younger folks maybe we were talking about the different generations and how in different generations you've got some folks who are like, we will listen to authority because that's how we've been trained to think. And then some of the younger generations have learned to kind of question authority, but bringing in some of the metaphors, the relevance of the family, and even the gatherings of families help push forward the need to enact preventive measures to protect family and community. Hot potato. Ready to get rid of it. If anyone wants to take it. That was great.
Oh, yeah. Okay. So in my group, I was talking about how in my position with CHER, I am now on this trajectory where I am assisting with supporting our researchers here at NAU who are doing health equity research to really examine their own social identities or their positionality in the context of their research, from developing, well, first of all, how do you see the issue from all of these different social identities that you hold? Second, how do you interact with the people that you will be working with, and how do you connect with them? So again, going into that storytelling mode of sharing information is you as the messenger have to disclose who you are, how you see this issue being positioned. And you're not necessarily trying to get people to say, hey, I'm trying to persuade you to do it this way or my way. It's just like, hey, let's have a conversation. This is who I am. We might have some things in common. We might not, but this is how I see it. And then going from there and unrolling the conversation about the topic at hand. But it's really important just to share your positionality, because I think that does open up the conversations so that, we all know that we have different ways that we see the world, and we need all of those on board in order to come up with a comprehensive set of solutions.
One of the items I didn't mention when we were getting information out to our people and using our culture and traditional teaching was the story of the hero twins. We grew up hearing those stories about the hero twins fighting off monsters. And we learned that at a very young age. These monsters, old age, hunger, poverty, these monsters that are plaguing the Navajo people, individual Navajos. And of course, you got this modern day monster now, COVID-19. And we started a messaging theme where it's warrior up, and I think it got that young people, that age, that we're trying to figure out how to get them, vaccinate them, how to get them on board, because as was mentioned, young people feel that they're in control. and so when we did that messaging, we started to see an increase in vaccination and young people getting more engaged in our town hall meetings, because it was something that they could relate to and something that we heard as young people. And so when you warrior up, what do you need? You need armor, you need weapons to fight. And in our culture, we're a very proud warrior society. So what are the armor, the masks, the protections, the vaccination, what are the weapons, the teaching that we were challenging people out there. We also told them, don't just be at home all scared. Share your cultural teaching with your family members. Well, now you're at home, there's no excuse. Of course, for some families, not all families have a loving household, but those families, we challenged them. Talk to each other. We challenged them to speak to each other in Navajo. We even went as far as challenging them to do a garden or a farm during that time, and let them know that food is medicine too, and to get as I was mentioning earlier, the immunity, build your immune system. And so I think that type of cultural teaching really helped us on Navajo. And it was, when we were talking about messaging, in this day and age, when you say messaging, first thing is a reaction is negative. Well, why are you trying to persuade somebody by messaging? But it also can be done in a good way, because you have to know your audience. We were talking about faith-based groups too. You have to have a message for them, because there was some pushback on vaccination by faith-based organizations, even on Navajo, masks too. Does that mean you have less faith than other if you're wearing a mask? And so you also have to have a message for that, and we did have a message for that. Those of you that know, the Bible, the Passover story, right, when the plagues happened to the Israelites when they were in captivity in Egypt. And I think all faith-based groups recognize that the Creator puts leaders in positions of authority. I think it's across the board in all faith-based groups. Then why not listen to the leader that was ordained by the Creator? And sometimes these individuals, most of the time, they get instructions to oversee their people, just like Moses and Moses did during the Passover, right? Told them to put the blood on the doors, and what happened? The plague passed over them. Something like that, so that those groups or could understand, the importance of what is happening, and this was a worldwide pandemic. And I think when I did that, I'm a Christian, so and I told them about the story, and they understood it, and there was a different change in seeing the virus then. And to we got to honor our leaders. We should listen to them because the Creator put them in positions of authority. So I thought I'd mention that, because it's not just about African Americans, Native Americans. It's also about faith-based groups, interest groups out there when it comes to appropriate messaging.
I think for the young people on Navajo, I remember there was a governor, right, who said that tribes would be depleted by this virus. And when you hear something like that being aired, that just that sentence in itself, I think it sparks more motivation for tribal peoples, or at least it happened, I think, on our nation. And a lot of those type of things, when you start hearing stuff like that from external, entities, or, it does play into some of the things of how you want the response, right, to all of this. And that part of it, I think once you started sharing that with some of the, I think you even mentioned it probably on the town halls. And I think that resonated with a lot of, especially the young people and the nation as a whole, because then it gets into that messaging about, collective versus individual responsibility. And there's a huge cultural component to that for Native peoples, because we don't see ourselves so much as we don't put individual priority above seeing ourselves as a collective whole. And when you put the historical collective context to Native peoples, to say that you're going to be depleted, and this is probably going to take all of your peoples, that puts more, I think, motivation into people's minds and into changing the way that they see maybe things that they thought they valued at an individual level. So I think that really was a huge proponent to a lot of people maybe changing the way they thought about the pandemic.
Yeah, thank you for sharing it. Culture, not just race, ethnicity, but cultures involves a lot. There's so much. The communication culture, the public health culture. What you do for work, who you associate with, of course, where you live. So much religious, so much with your identity, and could really learn a lot. I like that message, especially being in public health, that is more about, it's less about the individual and more about what you can do for your community. And we can really learn a lot from that, because especially what I see a tone in the U.S. anyhow, that it is very much infringing on me individually, even if I'm making a choice such as smoking inside. That's my own choice, yet I'm affecting everybody around me. We blurred lines there when it comes to that. But and another thing I wanted to add was, it's not just during the event, but understanding whatever field you're in, previous to an outbreak, previous to a pandemic, what are the cultures, especially when it comes to disease. There's so much surrounding disease and how the different cultures that we have think about disease and react to disease and deal with disease and get over disease. And if you are not culturally competent with that, talk about lack of trust. Ooh.
Let's see. Let's see here. Let me make sure I'm getting the right one. Okay, so from Samantha, she says, I think I initially think about tailoring individualized messaging for each culture or groups of people being necessary, but listening to President Nez, I hear similarities across both my Jewish background, my husband's Asian culture, and that I think we'd be surprised in the commonalities in stories and values across cultures. Okay. Yeah, that's a nice comment. Thank you. Yeah. That's a good comment. All right. Any other comments, or we move to the next? Yep, we've got 2 more groups. Ready to move on? Okay.
Great, thank you.
Yeah. Thank you.
Thank you so much. Well done, team. Well done.
Okay, so I don't know which group this was. Second cultural messaging group.
It was ours online.
Okay, perfect.
Yeah, go ahead. Was that who's online?
Okay, so hi, it's also Sam. I know I just put some comments in there, but I'll be speaking on behalf of our group. We had some similar ideas as far as cultural messaging, and so I'll just run through our list here. But as far as things to consider, things that we've identified based on our experiences is to provide messaging in necessary languages just right off the bat. That's a barrier that I think we still face to this day. And then also ensuring that messaging reaches and impacts not just local communities, but also international travelers, seasonal visitors, and others outside of what we think the local population is. We also suggest preventing gaps in resources to reach all levels of cultures and address conflicts between cultural aspects and guidance being given from authorities, as well as inclusion of ingrained community members or individuals of lived experience when pushing out messaging. That way you can build some more of that trust when it is being given out to certain populations. Also maintaining diverse workforce, but also fostering that diverse workforce. So not just hiring people that check boxes, but ensuring that they're being fairly compensated and supported. Also involving all voices and experiences at the table within the team, as well as at the tables that are making the decisions. A couple more items. We have that prior to pandemic times, it's important to build up trusted messengers and then utilizing those voices when it does become necessary. Also fostering relationships and planning to utilize those resources to share that messaging, being aware of the population makeup of certain areas and those who are most vulnerable within those populations. And then the last couple is preparing messaging for a variety of platforms. I think that's something that's come up for all of the previous topics is information comes from all sorts of places. It's not just the news, it's not just online, but from physicians, from word of mouth, from religious places, everywhere. And then also considering the messaging itself just to be understandable, digestible, and actionable for those that it's targeted for. Thanks.
Very efficient.
Great, thank you, Sam. And got to give a shout out because Sam, she helped us. She worked with Coconino County for a while and did a phenomenal job in assisting with the response part of the EPI team that really kind of just slaved away for so long trying to figure out how to help the community, and now is doing wonderful work at ADHS as well. So thanks, Sam.
Any comments, or are we moving on to the next one? We're at food coma. All right. Wait, I see one thing in the chat. Okay. Yes, great job presenting. Okay, next one, last group.
Last group.
Oh, last group, breakout one online. Take it away.
All right, I'll throw myself in there. It's Pauline. It's the journalist in the group. So this was the communication of information, and I don't remember, I didn't write the entire thing down. I think it was category number 4. So a few of the things that we talked about previously. One, build relationships with media, but especially your local media before disaster strikes, right? So that when it does, everybody can work a little bit better together. We talked about this one too, I think. Don't just present data, but really, I mean, again, we see a lot of news conferences where data is being presented and then boom, we're done. But rather really take the time to explain it and spend some time educating whether it's members of the media or the general public or your local practitioners and providers, really explaining the data. Maybe set some time aside for many workshops outside of quote unquote news conferences where this is just occurring even on background. That doesn't happen enough. Continue workshops and sessions like this one today, bringing in more members of the media. Again, I know this was open to the public, and it's a matter sometimes of just spreading that word. Providers and practitioners as well. I think we need to be having more, pardon the expression here, postmortems on how we can do better. This has been mentioned quite a bit, but really make sure when you are communicating that you are connecting with Spanish language media and outlets that focus on underserved communities, whether that is Black owned outlets or again, media specifically in Indigenous communities. And do ensure that you're messaging in a culturally appropriate way, but also in appropriate outlets. I think it was really, really important that President Nez mentioned something that very few people know. And that is that on the Navajo Nation, a lot of people do get their news via radio. So think about that too. I think that we sometimes look to the giant in the room, which maybe in the state of Arizona is the Arizona Republic, for example. But, are you reaching out to and connecting with your local Telemundo affiliates and some folks who might get overlooked? I may also call on somebody else to chime in, Lisa, if you want to, on some of this, especially on some of the research part of this and the collaboration between journalists and researchers, which I think was really, really interesting. Do you want to take over on some of these?
I think you're doing a great job, but I will I'll just jump in and add that one of the things that I was thinking about was how researchers can get our work out quickly, maybe collaborating with journalists to do so, learning how to pitch to journalists and other places, building capacity for our own storytelling so that we can get our work out as quickly as possible, even prior to the years it takes to do all of our analysis and peer review.
Thanks, Lisa. And I'm sorry, I know you're not feeling well.
Yeah, thank you.
There's a lot of bullet points here that relate to that, which is, again, I know sometimes as researchers, maybe everyone wants to wait until there are conclusions and it's all prettied up, right? And you feel like you can speak confidently about the research, but tell people about the research, even in the earlier days, especially if you want to help spread word of that. This one, and we were talking about kind of the both sides of this, right? And I was reminding the group that sadly, media is shrinking. People are getting laid off literally every day. So a good reminder is there are fewer and fewer specialists out there. So there are fewer people who may focus just on health journalism or science journalism or education, fewer beat reporters as they're known. So try to have a list of, here I said communicators at the ready. People you want to share either your research with or news with when the what hits the fan. Maybe it is, the main health reporter at a particular publication. Maybe it's just somebody who, whom you trust at one of your local TV stations. And then on the flip side of that, believe me, the onus is not just on researchers and the public health community. It is certainly on journalists as well. And I can tell you that people who do specialize in health, we do have our list of sources. And I was mentioning CHER here at ASU. I have had, when I've been doing the health initiative, a great relationship with CHER. They've thrown lots of different ideas my way, as well as some researchers at the College of Public Health, at the School of Transporter Studies. So it does go both ways. But you might even want to talk with your universities to ensure that your research and your name is being publicized so that the media can find you, because we need to find you. Just as an FYI, if you don't know, there is this thing called the Association of Healthcare Journalists. Look, I know that you all are trying to get the word out. Maybe you're pitching stories to, again, kind of mainstream media outlets, and maybe they're overwhelmed and there's too few people to handle a lot of this. There are tons and tons of freelance health journalists, many of whom actually work in the health field themselves. There are also lots of students who are always looking for stories, and just because it's a student journalist doesn't mean it won't reach the public. And then again, a lot of this was around the idea of, Lisa is a researcher who wants to write some of her own stories, right? So there's lots of freelance opportunities. There are a lot of people in the medical community doing that. We have a student here who's on a gap year. She's a medical student at Mayo, and she's going through the graduate journalism program here because she wants to be able to communicate to her patients, but also to the public. So I think that sort of sums it up. I really hope you all can hear me.
We can hear you loud and clear.
Okay, shoo.
Yeah. So thank you. What a great list, and a list I would like to have right before disasters strike.
That's a great idea. We need to all have a disaster checklist, right? I mean, what do we want to put into motion ASAP?
I'll add too that there are outlets like The Conversation and Kevin MD and Stat News and those types of outlets that do work with researchers who are working on writing their work either in partnership or on their own, and will help with the messaging, because I think for a lot of us who are researchers in social science, medical anthropologists and others, we want to tell a really complex story, and we have to figure out how to translate that into something that's you can write in 1,000 to 3,000 words. And so these types of outlets are really good for those, and they're good, especially in public health emergencies. So we found something in our research early that we noticed, but we hadn't analyzed yet. And we reached out to Stat News, and we were able to write hey, pay attention to this. We're researching it, and we noticed it prior to having our findings analyzed. So I like the idea of continuing that space of capacity building and the inspiration for researchers to learn from and work with not only journalists, but these outlets that are really open to primary research coming out quickly in those ways.
So I'm just going to add to that, because this was actually kind of part of my comment, but since she mentioned Stat, I'll just point out that a former colleague of ours who recently just left the Cronkite News and the publication Slate, Tori Bosch, is now an editor at Stat. So we have a nice little in with her there. I was going to just two things to kind of bridge on what they were saying. So researchers aren't usually incentivized to do what we now call sort of like public scholarship, which is kind of this middle area where you would be communicating your work to a more general audience, but that's changing. And I and some colleagues at the Cronkite School have done some training. So usually when you think about like media training, you think about teaching the people who are going to be in front of the media, like the press conference, right? Like the public information officers and the others who've been selected to communicate on behalf of your organization. Like media training is telling them how to talk to the media. And that is an important and specific thing. But there is another form of training that I've done with some of my colleagues that I think actually could be a really cool action item for the people in this group, which is a different kind of training with media, which is more along the lines of what like Polly and Lisa were just saying, which is how do you tell really complex stories? How do you simplify them in a way that meets the needs of journalists and satisfies things like their deadlines and the kinds of, journalistic news values that they're going to bring to a story, so that your stories can land in a way that's more effective than just like the typical press conference. And we've done this with colleague scientists within ASU, because sometimes you think you're saying so clearly what you know and you're just not. And journalists are pretty good at like helping you craft messages, and so it might be interesting to have a group of people who have all these different expertise to kind of lead a training like that with folks who haven't had the opportunity to talk to all these different kind of people. That I think that could be a really great value add for all kinds of different organizations, whether they're hospital systems or public health organizations or politicians or journalists. So we have some ways we've already done that, and would be happy to like share that at a different time. But I think we do kind of have a little bit of that work between bridging that gap between journalists and researchers, and it is so important. So
great, thank you for sharing. Yeah, I get caught up in science speak, as we'd call it, quite a bit, and try and deliver that message where something I say every day or my colleagues say every day, but is not a general word that everybody uses every day. So very important. Well, thank you so much. Any questions from that last group? Anyone else? Anything else to add? In the room or online? Okay, great. Well, thank you all. That went super well. I appreciate you all taking the time that you took and taking that seriously and really looking at good approaches.
Thank you all for coming, and what a tremendous day.